Annual Conference. This is the largest oncology conference in UAE to date. My name is 𝗜ጵහිঝ hiscie𝗃𝗁𝗵. I'm the president of the Emirates Oncology Society, and I'm honored to be with you here today. Before I start, I would like to acknowledge our team members, scientific committee, who actually put significant effort over the last month, almost 9 months of hard work trying to put this agenda. I believe actually this is the most comprehensive agenda I've ever seen in a conference in UAE history. And this just shows the commitment from our team and also from our colleagues from around the globe. And also would like to thank our partners from pharma. Without their support, we wouldn't be able to support our international experts to be with us here today. We'll be on time, so please, moderators, you have to be a little bit rough and tough today. We'll be on time, so I'm going to ask the speakers as well to be on time. I would like to welcome my dear friend and colleague, Dr. 𝗘𝗱𝘂𝗰𝗵. She is the EOS Scientific Committee Chairperson, and also she's a consultant medical oncologist. She is the chair of Hematology and Oncology Division at 𝗘𝗱𝘂𝗰𝗵 Medical City, and she's trained at MD Anderson. That's why she feels home today with many faculties coming from MD Anderson. Also, I would like to welcome my dear friend, Professor Atlal Abu Sanad, who's a consultant professor of internal medicine and oncology at Department of Medicine, King Abdulaziz University, Saudi Arabia. She's American board certified, and she is the first female in the Gulf region to be promoted to full professor in oncology. Welcome, and the mic is yours.
Thank you so much, Prof. Hamid. And again, I would like also to welcome you all. I think we will start with the best, as usual, which is the breast session. So I would like, we will try as much as we can to be on time. We will allow for a few questions after each session. So I would like to call our first speaker, Professor Valentina Goneri. We're very excited to have you, Prof. Valentina. She's a professor of oncology, University of Padova, director of the Oncology Division, very well-known expert in breast cancer. Thank you for being with us.
Thank you so much for the introduction and also for the very, very kind invitation. I'm really honored to open the breast cancer session today. So my role is to discuss the possibility of escalating and de-escalating treatment in the HER2-positive breast cancer. And here are my disclosures. So, let me start by sharing with you the data that really changed our approach to the treatment of HER2-positive early breast cancer. Here, the pivotal registrational trials clearly showing how the addition of trastuzumab to standard chemotherapy really improved the outcome of our patients with HER2-positive early breast cancer. The addition of trastuzumab to chemotherapy reduced by more than a third the risk of recurrence and death, as summarized in the Oxford meta-analysis. But over the years, the availability of new agents really help us in personalizing the treatment for HER2-positive early breast cancer. And we have seen a lot of trials trying to de-escalate, but also to escalate treatment. And of course, because of the time, I will review with you only the strategies that are currently part of our practice and of our guidelines. And in the past few minutes, I will discuss with you some of the possible research project in this scenario. So, and discussing treatment de-escalation, I think you are all familiar with the data from the APT trial dedicated to stage 1 patients. And here you can see that the reduction of the chemotherapy with only 12 weeks of weekly paclitaxel plus 1 year trastuzumab is really associated with a very good long-term outcome. Here I have reported the results of the 10-year follow-up, where you can see that really the number of recurrence, and in particular of distant recurrence, are very few. However, we have to take in mind that this trial was dedicated to stage 1 disease, but if you look at the patient's characteristic, you see that approximately half of the patients have T stage lower than 1 centimeter, grade 2. The majority have hormone receptor positive disease. So, and I will discuss later that we can further refine our ability to identify those patients to be candidate to de-escalation. The attempt trial dedicated in a similar, conducted in a similar patient population. Here there was a randomization between TDM and the APT schema for 1 year. Apart from the, of course, the trial was not aimed to compare the two strategies in terms of efficacy. Here are the results of the TDM1 alone arm. Same consideration. You can see that over the time, here we have 5-year follow-up, over the time, really very good long-term outcome with no particular difference according to the dimension of the disease or to the expression of hormone receptor. In terms of escalation, the dual blockade with pertuzumab, trastuzumab, and chemotherapy was associated with improved invasive disease-free survival as compared to chemotherapy plus trastuzumab in patients with intermediate to high-risk patients. You can see here the updated follow-up from the affinity trial. The benefits seem driven by the not positive cohort of patients, where you can see that at 8 years we have almost 5 years of benefit for the dual HER2 blockade with trastuzumab, pertuzumab as compared to trastuzumab plus standard chemotherapy. And lastly, considering the adjuvant context, the possibility to prolong the HER2 targeting with neratinib. In the ExteNet trial, patients who have completed the standard treatment plus 1 year trastuzumab were randomized to introducing neratinib, so maintaining the HER2 blockade versus control. And you can see at a longer follow-up the benefit that seems restricted to patients with hormone receptor positive disease. Of course, this advantage came at the cost of some side effects, in particular diarrhea. I have to say that this is not an approach that we currently use in Italy. This is not reimbursed. And I think that the most important thing is that this study was conducted in the pre-pertuzumab and in the pre-TDM1 era. And now trastuzumab, pertuzumab, and TDM1 are standard treatments available for patients with intermediate to high risk. But I think that in selected patients with very, very high risk disease, maybe something that can be case by case discussed and is also endorsed by the ESMO guidelines. And here just a summary of the last version of the ESMO guidelines. I have the opportunity to take part of the writing of these guidelines that summarize the approach for those patients candidate to surgery upfront. But as you know, in the HER2 positive disease, probably the most appealing scenario to test escalation and de-escalation with the aim to personalize treatment is the neoadjuvant setting. With this approach, we can really personalize treatment, leveraging the prognostic significance of pathologic complete response and the possibility to escalate treatment in the post-neoadjuvant setting. And indeed, in the subset of breast cancer with negative characteristics, this strategy is becoming more and more used, progressively lowering the threshold to offer the neoadjuvant approach, because in these two subtypes, the prognostic significance of pathologic complete response is the strongest in the context of using the PCR to tailor treatment. And for instance, we have used the neoadjuvant platform to endorse the possibility to de-escalate on the type of chemotherapy. So now the anthracycline-free regimens are standard of care in HER2-positive disease, because we have trials in the neoadjuvant setting that has shown that the pathologic complete response rate is comparable, but also the outcome is comparable when using an anthracycline-free regimen as compared to the sequential anthracycline taxane combinations. And also, thanks to the neoadjuvant approach, we learned the importance of enhancing the anti-HER2 targeting with the dual HER2 blockade, first with lapatinib and then with pertuzumab. So we have a lot of trials demonstrating how by increasing the HER2 targeting, we can really go up with the rate of pathologic complete response rate. And also, thanks to the neoadjuvant platform, we recognize the importance of tailoring the post-neoadjuvant treatment. So the KATHERINE trial demonstrated the role of adding post-operative T-DM1 in those patients with less than pathologic complete response after neoadjuvant standard chemotherapy plus anti-HER2 targeting. So the KATHERINE trial demonstrated a significant improvement in invasive disease-free survival. Here are summarized the data consistent in all the most important patients and biological subgroups. And we have seen last year also the results in terms of overall survival. So clearly paradigm in the treatment of HER2 positive breast cancer with this escalation in the post-neoadjuvant setting. And here just again a summary of the ESMO guidelines for those patients candidate to the neoadjuvant treatment upfront. Of course, there are a lot of things that will change. So there are a lot of trials, and I know that we will see the results very soon because I heard that DB11 will be presented at ESMO and also the DB05 I will show you later. So there are trials that have tested the escalation of the neoadjuvant part. So as the DB11 introducing TDXD in the neoadjuvant part. Also, very important trials such as the ADAPT-HER2-4 and the CompassHER2, trying to personalize treatment according to the response. So here you see very complicated study design, but very interesting, where treatment and randomization are allocated according to the response to the neoadjuvant part, and also the CompassHER2 is exploring the role of neratinib in the post-neoadjuvant setting, and trials dedicated to escalate the post-neoadjuvant part, such as the DB05, to be presented in a few weeks, comparing TDXD versus TDM1 in the patient with no pathologic complete response after neoadjuvant treatment, or the ASTEFANIA evaluating if there is a role of adding immunotherapy in the context of a patient with residual disease after standard neoadjuvant treatment. So the scenario is going to rapidly change. And of course, the escalation is straightforward because we know that higher PCR translates into improved survival. For those patients with less than PCR, we can escalate the post-neoadjuvant treatment. Of course, to safely de-escalate treatment is more challenging, and the way is through biomarkers or through early marker of treatment effect. And in this scenario, of course, I think one of the most interesting trial is the FERGAIN trial, led by 𝗂𝗲𝘀𝗲. Of course, again, a very complicated study design, but in the end, the issue was whether we can spare chemotherapy for those patients having a very good response in the assessed after a window of opportunity treatment without chemotherapy with pertuzumab and trastuzumab and hormonal therapy for patients with also hormone receptor positive disease, with an early assessment with FDG PET, and those responders continued with the treatment with the dual blockade without chemotherapy. And here are the results of the 3 years IDFS for those patients not receiving chemotherapy, but because of this triage with the FEG PET after 2 to 3 weeks of treatment. And you can see very long, very good outcome. Here, of course, we have to wait for probably more mature follow-up, but we have the opportunity to have this commentary, and I think it's a very important trial conducted with the aim of de-escalation, of course, without compromising a long-term outcome. Tumor-infiltrating lymphocytes are potent and powerful markers of patient outcome, in particular in the triple-negative and also in the HER2-positive setting. This is just a summary of the results of our shorter trial. The shorter trial was an adjuvant trial comparing 9 weeks of trastuzumab plus chemotherapy versus standard chemotherapy plus 1 year trastuzumab. And here you can see in terms of distant disease-free survival, where patients with high TILs have a long-term very good long-term outcomes, and as shown here. And so probably patients with high TILs can really be candidate to de-escalation strategies. And this is the first demonstration of the association of tumor-infiltrating lymphocytes, not only with invasive disease-free survival, but also with overall survival. And another important marker is the Oncotype DX. We contributed to the development of this tool with LH-BRAT, and this is a tool that integrates the clinical information with combined information deriving from 4 gene signatures that evaluate the immune infiltration, the luminality, the tumor cell proliferation, and the HER2 amplicon. So this is a tool that is able to inform on prognosis, but also to inform on the probability of pathologic complete response. And I think it's very interesting to see the results of Oncotype DX applied to what we call low-risk populations, such as the population of the APT trial. As you can see from the graph, there are patients, the Oncotype DX is able to identify in a group of good prognostic patients, those patients with probably still need the standard treatment or even an escalating strategy. And on the right, you can see the application of the Oncotype DX in patients with pathologic complete response. So again, in a group of patients that in our mind are considered cured, still there are patients that probably need something more. And this is the definitive trial, is a European project that has been funded through our European Horizon application. And we are trying to prospectively validate the approach of assigning treatment on the basis of the results of the Oncotype DX. And lastly, just a note of caution in terms of, because you know that everything now in terms of escalation or de-escalation is around the concept of pathologic complete responders as cured patients. This is a meta-analysis that we ran together with a lot of friends, including more than 12,000 patients treated with anti-HER2 therapy. And you can see that stage still is an important driver of the risk of relapse and death. So here are all patients with pathologic complete response, and you can see that there are patients still at high risk despite having achieved a pathologic complete response. So having trials that totally exclude from escalation strategy those patients in PCR probably is not the correct answer. So keep in mind that if you have a patient with a high disease burden, a diagnosis, even in complete response, probably you have to carefully consider to going ahead with treatment as you do for high-risk patients. And this was my last slide, and thank you all for your attention.
Thank you very much for this excellent review. And I would like to congratulate my colleague from the Emirate Oncology Society for this ongoing success, and all the best for the coming years. Our next speaker is Dr. Marianne Khatib. She's a consultant breast surgeon from Brazil. She specializes in breast surgical oncology and advanced technique in breast conserving surgery and reconstruction. And she's going to discuss de-escalation of axillary surgery in breast cancer patients. Yeah.
In hospital in Dubai.
Okay, American, all right. We switched you to Brazil. Maybe they should invite you over there, okay? Yeah, you should recruit her. You have the Hamid will bring her to Brazil.
Can you just guide me through this thing? Yeah, okay. So good morning, everyone. Now I'm gonna give the surgical perspective about de-escalation. So in the context of surgery, what is de-escalation actually? Is to reduce the surgical burden on breast cancer patients while maintaining excellent oncological outcomes. I'm gonna present 3 trials and see if we are really ready for this de-escalation. So the role of axillary surgery has gone through a lot of changes during the last few decades. We started in the 1970s when the axillary lymph node dissection was the standard of care. And then in the 1990s, the sentinel lymph node biopsy came into our lives and became the standard of care for clinically node-negative patients. And until the Z11 in 2011, which also showed that we can omit axillary dissection in patients that had small breast cancer up to T2 with 2 lymph nodes that are positive. It was widely, I can say that it was widely adopted, but still in Europe there was a delay in adoption of this trial. There was lots of criticism about closing early, about unclear radiation therapy fields. So the Europeans felt that they still need to do more trials in this field in order to confirm the findings, in addition to AMAROS, the famous AMAROS trials also as well. All right, so the first trial I'm going to discuss is the SOUND trial that was published in September 2023. And it tried to even show that we don't need axillary surgery at all in certain subgroup of patients. So it's a prospective non-inferiority phase 3 randomized trial that was conducted in Italy, Switzerland, Spain, and Chile. Recruited a total of 1,463 women of any age with breast cancer up to 2 centimeters and a negative preoperative axillary ultrasonography. It's worth mentioning that routine ultrasound for the axilla is not a standard of care in the US. In many centers in the US, but it is, as far as I know, in Europe. So this was one of the conditions for enrollment for this study, is to perform an axillary ultrasound and for it to be negative. So the data was analyzed from October 2022 until January 2023. And patients were randomized on a 1-to-1 ratio to receive sentinel lymph node biopsy or no axillary surgery at all. The primary endpoint of this study was distant disease-free survival at 5 years, analyzed as intention to treat. There were also secondary endpoints as disease-free survival, overall survival, and incidence of axillary recurrences. So the results showed no difference, no statistical significant difference at all between the 2 groups. But if we look deeply into the results, we can see, although it was not in the inclusion criteria, not mentioned in the inclusion criteria, we see that most patients, the median age was above 60, was 60 and above. Most patients were postmenopausal, and most of them had either T1B or T1C, were ER positive and HER2 negative. And And here, these graphs show that there was no difference in the primary endpoint and in the secondary endpoints. So the conclusion of the study was that omission of axillary surgery was non-inferior to sentinel lymph node biopsy in patients with small breast cancer and a negative result on ultrasonography of the axillary lymph nodes. So I'll move on to the next trial that is quite similar, and then I'll discuss if it's really practice changing or not. And then came along the ENZIMA trial that was published this year in March 2025, that basically wasn't very different from the SOUND trial. It had a larger population, and the primary efficacy outcome was invasive disease-free survival as opposed to distant disease. So it recruited 5,154 patients. And if we look deeply, we see lots of similarities between the two trials. Also, most patients had a tumor that was less than 2 centimeters, that was ER, PR positive, HER2 negative, and the median age of the participants was quite high. Most of them were above the age of 50. And the results were the same. The surgery omission group had the same results in terms of invasive disease-free survival as the surgery group, the same overall survival, and the same invasive disease-free survival. So this trial also showed that omission of axillary sentinel lymph node biopsy does not compromise survival in patients with early stage clinical N0 breast cancer who plan to undergo primary breast conserving surgery. It's worth stressing that both trials enrolled patients who were planned to undergo only breast conserving surgery and not mastectomy. And the question is if we can conclude from these trials that we can let go of the sentinel lymph node biopsy. So I don't think that we are ready yet, because as we see that it's suitable for only a very specific subgroup of patients, which anyway, I think didn't change a lot from the Choosing Wisely that was already published in 2016 that said that we can omit sentinel lymph node biopsy in 70-plus-year-old patients who have good biology tumors, which are ER, PR positive, HER2 negative, and clinically node negative disease, especially in the light of the previous presentation with the escalation and de-escalation of the HER2 positive disease in the era of the pertuzumab and the pembro. I don't think we can afford omitting sentinel lymph node biopsy in triple negative disease or in HER2 positive disease, and also in premenopausal in the era of our responder, where we saw advantage of giving chemotherapy for all premenopausal patients who had positive lymph node. I don't think sentinel lymph node biopsy omission could be performed just yet. And the third trial that I'm going to present is the CENOMAC trial, which basically tried to check the same things that the Z11 trial, the non-Z11 trial checked, but claimed to have a wider, bigger population and also more inclusion criteria. As opposed to the Z11, it did include T3 breast cancer patients. It did include mastectomy patients, and also patients were given radiotherapy to the axillary, to the lymph node drainage, which more similar to the AMAROS trial rather than the Z11. So it recruited 2,766 patients, which were randomized to two groups. Patients were assigned to undergo sentinel lymph node biopsy even if they had 2 positive lymph nodes, up to 2 positive lymph nodes, and the other group continued to have axillary lymph node clearance if they had positive lymph nodes. Again, if we look into the characteristics of patients that were recruited, we can see that most patients were above the age of 50, postmenopausal, And although it claimed to recruit T3 patients, it had only 5% of the patients who were T3. 95% of the patients were either T1 or T2. So the results showed that sentinel lymph node biopsy only versus completion axillary lymph node dissection were equivalent in terms of overall survival and recurrence-free survival after follow-up of 60 months. And the conclusion of the study was that omission of completion axillary lymph node dissection was non-inferior to the more extensive surgery in patients with clinically node-negative breast cancer who had sentinel lymph node macrometastasis, most of whom received nodal radiotherapy. So is that new? I'm not sure. Thank you.
Exciting session. Thank you so much, Dr. Mariam, for this excellent review. I believe we'll have a lot of questions on that too. So we'll move on to the next exciting session. It's a debate. It's going to be moderated by Dr. Saeed Rafi. Please, Dr. Saeed, you can lead this debate.
Thank you, Dr. I highly appreciate it. Thank you so much. First of all, ladies and gentlemen, esteemed colleagues and distinguished guests, welcome you all to those of you here in Dubai and those who are joining online. For those of you who are familiar with the EOS, you know that we have always tried to address the most important questions in oncology throughout open dialogues and throughout full discussions. Over the years, these conversations have shaped our practice, inspired collaboration, and kept us focused on what matters the most, and that is improving the outcome for our patients. Today, at the 6th EOS Annual Conference, we take this mission a step further by the formal launch of the Dubai Debates Oncology. This initiative reflects our ambition in the UAE to be the forefront of the cancer care, bringing together world leaders in oncology to debate the most vital and timely questions. Our goal is to recognize that modern oncology demands modern data, to openly challenge long-standing practices in areas where uncertainty remains, to educate and inspire our oncologists, and to stimulate research that redefines the standard so that the debate today translates into better outcome for our patients tomorrow. Dubai Debates Oncology is not just a session, but a platform where science meets dialogue and where together we shape the future of the oncology. With that, ladies and gentlemen, it is my pleasure to introduce the first debate of the day, which captures this spirit precisely, and that is the role of the nodal irradiation in early breast cancer. Should it remain as a necessity, or can it be safely omitted in selected patients? RNI has been a cornerstone of curative therapy in early breast cancer for a long time. However, the growing use of neoadjuvant chemotherapy has caused us to ask that question, whether it is really needed. Does every patient still need RNI? Can it be safely omitted in selected patients? To help us to explore this controversy, we are honored to have Professor 𝗘𝗱𝘂𝗰𝗵, who will argue for the omission, and Dr. Remo Jaime, who will make the case for the necessity of RNI. Let us begin with one of the most respected figures in breast oncology worldwide. It is my pleasure to introduce Professor 𝗘𝗱𝘂𝗰𝗵, Professor of Surgery at the University of Central Florida and Clinical Professor of Clinical Sciences at the Florida State University. Professor 𝗂𝗰 currently serves as the chair of the NRG Oncology Breast Committee and is the past chair of the NSABP Breast Committee, where he has led and overseen some of the most practice-changing trials in the breast oncology over 3 decades. His work has fundamentally shaped our modern breast oncology practice, and today he will share his perspective on whether regional nodal irradiation can be safely omitted after neoadjuvant chemotherapy. Professor 𝗂𝗰.
Thank you very much, Dr. Afri, for a very nice introduction. And I'd like to thank Dr. Al-Shamsi for the kind invitation to be here with you to debate this very important and hot topic. So, as we know, there has been, and you heard it already from Dr. Guarneri, an evolution in the clinical rationale for neoadjuvant chemotherapy. Initially, we used it for converting operable patients to surgical candidates. And of course, when randomized trials showed us that chemotherapy either before or after surgery had the same effect, neoadjuvant chemotherapy became a reasonable alternative to adjuvant chemotherapy with several potentially clinical advantages, but underscore inappropriate candidates. And you heard that pathologic complete response leads to significantly better outcome than patients that do not get a pathologic complete response. And as a result, pathologic complete response has become a surrogate endpoint for neoadjuvant chemotherapy efficacy. So over the years, we have seen the increasing rates of pathologic complete response with modern regimens going back all the way to the single-digit results with CMF-based therapy to about double that with anthracyclines, double that with taxanes. And of course, for patients with hormone triple-negative breast cancer as well as HER2-positive breast cancer, significant improvement in pathologic complete responses with anti-HER therapy, dual anti-HER therapy, and of course for HER2-positive breast cancer. And for triple-negative breast cancer, as we know, the introduction of carboplatin into the anthracycline taxane regimen, and more recently, the adoption of immunotherapy has pushed pathologic complete response rates even higher. Now, pathologic complete response rates don't only occur in the breast, but similar rates are seen in the axilla. In the early randomized trials, such as the BAT and the URDC trials, have shown about a 30 to 40% downstaging of involved axillary nodes. That number now can be up to 50 to 75% in select patients, particularly with HER2-positive and triple-negative breast cancer. And of course, that led to the question that we can potentially de-escalate axillary surgery, but here we'll talk about the potential for de-escalating regional nodal irradiation. So I'll talk a little bit about axillary surgery because that's not the point of this debate, but it's important to realize that we as surgeons have a responsibility to actually get it right in the axilla in terms of involvement or not, particularly after neoadjuvant chemotherapy, because that has implications for additional treatments. So for clinical and zero patients, performing a sentinel lymph node biopsy after neoadjuvant chemotherapy has shown to have the same performance characteristics as upfront sentinel lymph node biopsy, and now it's widely adopted. When it comes though to clinical node positive patients with documented involvement of the axilla, the false negative rate of sentinel lymph node biopsy after neoadjuvant chemotherapy was a little higher than we anticipated, about 12 to 14%, but we can drop it down to maybe 7 to 9% when we did dual mapping in the axilla and remove at least 2 to 3 sentinel nodes or use immunohistochemistry in the sentinel nodes for more accuracy. In addition, though, an important development of the last few years is the recognition that removing the node that was already positive before and it was clipped at the time of diagnosis, what we call now targeted axillary dissection, when we add that to the sentinel lymph node biopsy procedure, the false negative rate drops to about only 2 to 4%. That's an important advancement to get actually the information that we need for treatment. Why is that important? Because accurate pathologic assessment of the axilla after neoadjuvant chemotherapy dictates appropriate post-neoadjuvant systemic therapy. You heard from Dr. Guarneri. We know that there is survival benefit with capecitabine for triple-negative breast cancer, with TDM1 in HER2-positive breast cancer, even with the CDK4/6 inhibitors. A lot of the neoadjuvant patients got into these studies, and of course with olaparib more recently in the Olympia trial for BRCA-positive patients. So clearly we need to get it right from the systemic therapy standpoint, but as we will debate here, we also need to get it right because this can now dictate appropriate use of post-mastectomy regional nodal radiotherapy. So the question is, can we tailor the use of regional nodal radiotherapy for clinically node positive patients who convert to YPN0 after neoadjuvant chemotherapy? And of course, for patients who undergo surgery first, we have ample evidence of the effects of regional nodal irradiation. And for patients that have positive nodes and get surgery first, there's clear benefit from regional nodal irradiation. I'll show you some of the slides in a minute. But what about patients who present with positive disease, but then become YPN0 after neoadjuvant chemotherapy? Do they behave like node positive patients that they presented us, or would they behave more like node negative patients after neoadjuvant chemotherapy? And those patients in studies that I will show you, one from the NSABP, have shown to have low rates of locoregional recurrence. So it is important to actually ask the question, if these patients have low rates of locoregional recurrence, do they benefit from regional nodal radiotherapy? So again, here are the results of the early breast cancer overview showing that post-mastectomy radiotherapy in the upfront setting clearly improves outcomes in terms of local reduction recurrence, distant reduction recurrence, and also breast cancer mortality. The differences in local recurrence here are fairly large, and this is based from older patients and older trials. But on the right side, we see the MA20 trial and the EORTC 22922 trial that also showed benefit for regional nodal irradiation, either after mastectomy or breast conservation. And again, the benefits here are smaller, but they were significant. So what about the patients that undergo neoadjuvant chemotherapy and then they have positive nodes before but become negative later? One of the largest studies that we able to gather is a combination of two NSABP trials, the B18 and B27. The B18, as you know, compared preoperative to postoperative surgery, and the B27 added taxane-based therapy after anthracycline. So when we combined, let me go back once. So when we combined the results of all the preoperative arms in the study in a cohort of 3,088 patients with 356 locoregional recurrence as first events, we essentially showed that there were different factors predicting locoregional recurrence in lumpectomy plus radiotherapy patients versus mastectomy. And I'll get into that in a minute, but the particular importance of this review was that in these trials, there was no post-mastectomy radiotherapy, there was no regional nodal radiotherapy per protocol, and patients with lumpectomy only received breast radiotherapy. So when you look at the factors that predict locoregional recurrence, was clinical nodal status for both groups, the lumpectomy radiotherapy to the breast or mastectomy. And for lumpectomy radiotherapy, it was also age of the patient. For mastectomy patients was tumor size, as you see on the right. But for both groups, a combination of pathologic response in the breast and in the axilla lowered significantly the local recurrence rates. So as we can see here, patients that had clinical positive nodes, that are pathologically not positive to the left, have very high rates of local recurrence, and that drops with PCR in the nodes, but not in the breast, and furthermore, complete PCR in the breast and nodes. So this review provided a rationale for testing the question, do we need to give regional nodal radiotherapy for these patients? And of course, with that, we designed the NRG Oncology NSABP B51 RTOG 1304 trial. But as you can see, it took patients with clinical T1 to T3, clinical N1, M0 breast cancer, just to make sure these were clinical N1, who means involvement of clinical involvement of movable, ipsilateral, level 1 and 2 lymph nodes. Not 1 to 3 positive nodes. There was a erratum in the paper, and it's now corrected. It's clinical N1, what we call clinical N1, not matted node. The biopsy of the node had to happen, and the node had to be involved with the disease, and then neoadjuvant chemotherapy was given. Then patients were stratified according to type of surgery, hormone receptor status, HER2 status, adjuvant chemotherapy, yes or no, and whether they had breast PCR as well or not. And then they were randomized to either the no regional radiotherapy group or regional radiotherapy group. Now, if they had breast conservation, they received breast radiotherapy, and then with or without regional radiotherapy. But if they had mastectomy, they received no radiotherapy with or without regional nodal radiotherapy. And chest wall radiotherapy if they were in the RNI group. So the primary endpoint was invasive breast cancer recurrence-free interval. As you see, the secondary endpoint, locoregional recurrence-free interval, distant recurrence-free interval, disease-free, and overall survival. We recruited 1,641 patients, And at San Antonio in 2023, and then in New England Journal in 2025, we published the per protocol 10-year analysis, a time-driven analysis, 10 years since the first patient enrolled in the study. The median follow-up was 59.5 months. And in that time, with 10 years from the first patient, we had 109 events. That was less than what we expected for the event-driven analysis that was supposed to happen at 172 events. But we presented the per protocol time-driven analysis. If you look at the patient characteristics, about 40% of the patients were less or equal to 49, about 15% less or equal to 40. African-American patients were overrepresented because they get more triple-negative breast cancer. Clinical tumor size, the majority were T2, about 60%, but about 20% were T1 or T3. You see the tumor subtype, about a quarter for each subtype. Triple-negative, ER positive, HER2 negative, ER negative, HER2 positive, and triple positive. And as you can see, about almost more than 50% of the patients are HER2 positive disease because of response to neoadjuvant chemotherapy. About 58% of the patients had lumpectomy, and about 55% of the patients were staged with sentinel lymph node biopsy. The only requirement was to have at least 2 nodes removed at the time of sentinel lymph node biopsy. Targeted axillary dissection was not used very frequently in the trial, came later. And about 78% of the patients had also pathologic complete response in the breast. So these are the results of the primary endpoint, invasive breast cancer recurrence-free interval. You can see no significant difference between the two groups. The lines are practically superimposable. The hazard ratio was 0.88, not significant p-value, and the absolute difference is less than 1%, 0.9%. In one slide, you see all the secondary endpoints. There was no significant difference in any of them. Local-regional recurrence-free interval, distant recurrence-free interval, disease-free survival, overall survival. The hazard ratios are all close to 1, except for the local-regional recurrence-free interval, where it's 0.57, as you can see in the upper left of your slide. And again, there were 6 local regional recurrences in the RNI group and 11 in the non-RNI group. The difference is 0.5%. Now, we did subset analysis according to the stratification factors, and when you look at the type of surgery, ER/PR status, HER2 status, pathological complete response in the breast, yes or no, or adjuvant chemotherapy was very uncommon. We see no significant interaction on the effect of radiotherapy according to the stratification factors. Of course, you see the confidence intervals are fairly wide. But then we did an exploratory subgroup analysis looking at the age of the patient, the race of the patient, tumor subtype in a more granular form, and axillary surgery. And none of this was significant except, as you see here, tumor subtype, where patients, for example, as you can see here, with triple-negative breast cancer appear to do actually worse when they get radiotherapy. The hazard ratio was the opposite direction, 2.3. On the opposite side, ER/PR positive and HER2 negative patients appear to get some more benefit with a hazard ratio of 0.41, barely touches 1. And of course, HER2 positive patients did not seem to get much benefit with wide confidence intervals. So what we concluded from this paper is that in patients who present with biopsy-proven axillary node involvement and convert their axillary nodes to YPN 0 after neoadjuvant chemotherapy, chest wall plus regional nodal irradiation after mastectomy, or whole breast plus regional nodal irradiation after lumpectomy did not improve the 5-year endpoints, IBC-RFI, original recurrence-free interval, disease-free, overall survival, or distant recurrence-free interval. And these findings suggest that downstaging involved axillary nodes with neoadjuvant chemotherapy can optimize adjuvant radiotherapy without adversely affecting oncologic outcomes. And of course, follow-up of patients continues because we know that sometimes events may accumulate at distant sites even later on, 10 to 15 years. Now, just to finish, these results, of course, like with any trial that we conduct, by the time we present the results, the standard of care has changed. So we know now there are several new developments, both with neoadjuvant and post-neoadjuvant therapy, that potentially will make the results of this study more important, because they can expand the pool of patients that are candidates, and also they can improve their outcomes. And here I'm listing, for example, post-neoadjuvant capecitabine for triple-negative breast cancer, the addition of neoadjuvant carboplatin for TNBC, TDM1 for HER2 positive, as you heard earlier today, neoadjuvant pembrolizumab for TNBC, adjuvant 𝗜𝗂𝘂𝗰𝗵 for hormone receptor positive, HER2 negative, and of course, olaparib, adjuvant olaparib for patients with BRCA germline mutation. Again, these developments expand the pool and improve the outcomes of these patients, where local regional therapy probably would matter less today than it was when we conducted the B51 trial. But what about the exploratory analysis? A lot has been said about that. But for triple-negative breast cancer, the results may be spurious because only 20% of the patients were included, may be related to immune suppression, effects from RNI. Some preclinical data may suggest this, but we don't have a lot of clinical data for it. We have seen also in the previous PMRT trials that triple-negative breast cancer had less benefit for radiotherapy. It's more resistant, but again, it was with different chemotherapy of the past. And it's unlikely, though, that RNI benefit will accumulate in this population of patients given their recurrence patterns. Most of these patients recur within 5 years. Our median follow-up was already 5 years. Our minimum follow-up in the study was 3 years. So I don't think more follow-up would change the results in triple-negative breast cancer towards benefit. For hormone receptor positive, HER2 negative breast cancer, we have to be more cautious because this group also has a different recurrence pattern later on. And of course, we have seen also large post-mastectomy radiotherapy benefit in this subgroup for the Danish trials. Overall, they have lower PCR rates, so they have more likelihood to have residual disease. And we have to be very careful, particularly for patients that have residual disease in the breast, but the axilla is negative on the sentinel lymph node biopsy, because there was this issue, again, of the potential for false negative rates. So we have to get the axilla right, particularly for these patients. Finally, to finish, there are some potential harms if we don't apply B51 RTOG1304 findings. Clinical harms in terms of overtreatment resulting in increased risk of lymphedema, pneumonitis, or cardiotoxicity. Negative impact on breast reconstruction outcomes, which we're going to look in the trial. Patient-centered harms in terms of reduced quality of life due to pain, restricted mobility, increased financial burden and time commitment for therapy that may not be effective, of course, as we see, and system harms, potential misallocation for RT resources, and widening global disparities for treatment access. So to finish, when it comes to RNI and clinically no positive PN0 breast cancer after neoadjuvant chemotherapy, I'll end with a Nike admonition, which was just do it. In this case, just don't do it. Thank you very much for your attention.
Thank you so much indeed, Professor Mounas, for this very nice and enlightening session. So now it's my pleasure to introduce Dr. Rimmo Jamie, who will be presenting the opposing view on the necessity of regional nodal irradiation. Dr. Jamie is an Associate Professor of Radiation Oncology at King Abdulaziz University, Saudi Arabia. She completed training in radiation oncology in Canada and is a founding member of the Saudi Association of Radiation Oncologists. Dr. Jamie specializes in breast radiation oncology and brings extensive expertise and experiences to this discussion.
Thank you very much for the introduction, and I thank Professor Chamsi and the organizing committee to give me this invitation. It is a pleasure and honor, but also a great challenge to be debating with Professor Mounas, so bear with me. So I will be trying to convince you that we still need regional nodal irradiation in breast cancer patients after neoadjuvant chemotherapy. Okay. So like the previous speakers have mentioned, we're going a long way to de-escalate the local and regional treatment of the breast and axilla in order to improve the quality of life of our patients through decreasing side effects without affecting their tumor outcomes. And we're here today because systemic treatment with chemotherapy and other medications have done a great job at downstaging the tumor and improving outcomes, including tumor control, local tumor control, that we've questioned whether or not for those patients who achieve pathological complete response, do we still need to intensify their local treatment? And multiple meta-analyses looked at whether or not we need to use radiation therapy in this setting, and with the different results, but basically this brought up the question to do a randomized trial looking at whether or not we need adjuvant radiation some of these trials did show that adjuvant radiation does improve outcome, including overall survival. Then comes the famous randomized trial, and I congratulate Professor Mamounis and his team for conducting such an excellent trial that gives us level 1 evidence to spare out some of our patients from the intensive treatment that we give them. So I will not go in details. Professor Mamounis have already mentioned the trials in detail, but basically just to remind everyone, it was a trial for clinically N1 patients, so those who have movable axillary lymph node at the time of presentation who convert to pathologically no-involved lymph nodes. And the trial did not show any improvement in outcomes with the addition of post-mastectomy radiation treatment. And multiple subgroup analysis did not show a specific subgroup that did benefit from radiation, except for the hormonal positive. They had a trend toward improvement, and the triple negative patient, like Professor Mamounis has mentioned, did not benefit much. I would have to echo what Professor Mamounis has said, that we need to be careful analyzing this forest plot because of the small numbers of events. Now, where do we stand now after the B51? We know that many patients now will be safely spared regional nodal irradiation. We've been eagerly awaiting for the results to spare those patients. But I argue that not all patients who achieve complete pathological response and are eligible for the B51 are candidates for omission. So I'll start with a clinical scenario that we often face in clinics and tumor boards. So this is a 35-year-old female who presented with a palpable right breast mass. On physical examination, she was found to have an 8-centimeter mass in the upper outer quadrant of the right breast with palpable movable axillary lymph node. Biopsy revealed an invasive ductal carcinoma, triple negative, grade 3. So she had the staging workup, including CT chest, abdopelvis, and bone scan. All were negative for metastases, but she did have multiple right axillary lymph nodes. The primary was 9 centimeter on MRI, and the FNA of the largest lymph node revealed invasive ductal carcinoma consistent with metastases. So she was staged as clinically stage 3A, prognostic stage 3C. And so she received neoadjuvant chemotherapy, and after her neoadjuvant chemotherapy, exam revealed some partial response in the primary, about 60% on images, but the lymph nodes looked normal on images after chemotherapy. So she underwent skin-sparing mastectomy with immediate reconstruction and sentinel lymph node. And the final path revealed 3 centimeter single focus breast mass, grade 3 triple negative with positive LVI and 0 out of 3 lymph nodes with tumor effect in 3 out of 3 lymph nodes. This is a typo. I've sent updated slides, but it's not here. It's a T2, so it's a YPT2 and YPN0. So the question was raised to the board as whether or not this patient should receive radiation treatment. We reviewed her images, and as you can see in these 2 slides, she did have at least 4 to 5 suspicious-looking lymph nodes in her axilla. So is this patient eligible for the NSABP B51 trial? And the board members all agreed that this patient would be eligible for the trial. However, everyone in the board meeting agreed that this patient should be receiving radiation treatment. So should we count lymph nodes on pre-chemo images? So if you look at, again, there are 2 slides that I've added to this presentation, but basically, if you looked at in the upfront setting for N2 disease, we have evidence that radiation does improve outcomes. In fact, there aren't any new trials looking at emitting radiation in N2 disease in the upfront setting. And if you look at all guidelines, including the NCCN guidelines, radiation in those patients is not optional or strongly recommended. It is given. You have to give radiation treatment for patients that are in the upfront setting. So how about post-neoadjuvant chemotherapy? In this Dutch registry trial, they included patients that were N1, but in this particular trial, which is a prospective trial looking at their outcomes of patients who, based on guidelines, wouldn't receive radiation treatment if they initially have N1 disease, but with lymph node counted to ensure that only patients who had 3 lymph nodes were included in their Bay guideline where we spared radiation treatment, and they found that the outcomes were excellent with this approach. So should we be counting lymph nodes? And do we know if patients were in the B51 were not preferentially included with low burden disease? We know that imaging was included in the protocol for assessment of the axilla. So was it possible that majority of patients in the trial were actually of low burden disease with 3 or less lymph nodes? And we also it would be great to know what was this, the median number of sentinel lymph node removed. I'll be very nervous to have a patient with 4 or more lymph nodes involved pre-chemo and have a sentinel lymph node, two sentinel lymph nodes that were negative, but without targeted axillary dissection, which we know improves the false negative rate to less than 5%. In the trial, like Professor Mamounous has mentioned, targeted axillary dissection was allowed, but it was not mandated. It would be great to know how many of the patients had targeted axillary dissection or higher number of median sentinel lymph nodes. Going back to our patient, beside the issue of the lymph node, she had multiple risk factors. She's young with grade 3 disease, triple negative, a 9 cm primary, and looking at her post-chemotherapy outcomes, she had a residual T2 disease, 3 cm with a positive LVI, again, grade 3 and triple negative. Now, I know that the subgroup analysis of the B51 did include all these subgroups and did not show much benefit, but like I said previously, the number of events were not very high, and we cannot ignore the old evidence. And I'm echoing in the coming few slides, I'm basically echoing what Professor Ganier has said in her last slide about not ignoring the initial stage of the disease. So in this National American Database analysis, patients who were stage 3 at presentation or had primary residual at the time of surgery or had initially T3 or T4 did benefit from the addition of adjuvant radiation treatment. In a retrospective review, also patients who had stage 3 did benefit in terms of local control or local regional recurrence from the addition of post-mastectomy radiation therapy significantly, but also in terms of disease-free survival and overall survival. Analysis of the ERTC 10994 trial, a chemotherapy trial, showed that patients who were triple negative had significantly higher risk of local regional recurrence and would benefit from the addition of adjuvant radiation treatment. This retrospective review from Korea of a relatively newer era of chemotherapy from 2013 to 2017 compared to the older trials also did show that patients who had triple negative disease did benefit from the addition of post-mastectomy radiation therapy among those who completely responded to chemotherapy. And again, we have more trials looking at the residual primary in the breast after chemotherapy, and they did show that patients who were younger or had residual primary at the time of surgery in the breast did did have better outcomes with the addition of radiation treatment. Now, how about the having multiple risk factors? We've known for facts that patients who have multiple risk factors behave even worse than those who have one single risk factor. The same Korean study showed that even among those who are pathologically node positive at the time of the surgery, if they have multiple risk factors, including grade 3, LVI, or in this situation it was a luminal A HER2 positive patients, the benefit of radiation therapy was significant for those patients who have multiple risk factors, similar to our patients in the study, in the clinical scenario that had multiple risk factors that would make her risk even more higher for local regional recurrence and probably benefit from radiation treatment. So just to summarize this, why I don't think all NSBP eligible patients should be spared radiation treatment. There is a possibility that the trial have included lower burden patients, lower risk nodal burden, lower risk patients. And like Professor Mamounous has said, the more follow-up would be great, particularly for those patients who are hormonal positive that do have late recurrences at 10 and 15 years. The number of events in each subgroup was low, so we cannot really, we have to be very cautious in analyzing those subgroup analyses, and again, emphasizing the importance of careful axillary staging pre and post-operatively. or pre-chemo and post-chemo. So speaking of the harm of radiation treatment, I'm not going to start by saying that radiation is absolutely not harmful, but we have to remind ourselves that the major determinant or the main determinant of lymphedema in the breast is the axillary surgery. You add radiation to sentinel lymph node, it does increase the risk of lymphedema, but it's still very low. The main determinant is the having axillary lymph node dissection. So we should really be looking at, and we're doing this already, but we should emphasize on not having axillary lymph node dissection and have sentinel lymph node biopsy for all patients that are appropriate for that. And I wouldn't be a radiation oncologist if I don't show one of these slides. So this shows how beautifully we can spare the heart with our simple modern techniques, which is really simple, just asking the patient to hold her breath or doing that for her. We are sparing the heart almost completely in these patients, which brings more safety to our radiation treatment. So with that, I'm just saying that RNI is still necessary in many patients, in many clinically unwell patients who convert to YPN0 after neoadjuvant chemotherapy. Thank you.
Thank you very much indeed. Can I invite Professor Mamunas and Dr. Jamie to join us here? We will have a very short discussion here on this one. So just starting maybe with triple negative breast cancer. We have the B51 data, but we also have data from KEYNOTE-522. And if you look at KEYNOTE-522 in patients who achieved PCR, and these are roughly around 68% of the patients, and the patients that they do not have any disease, complete pathological response to treatment, the risk of local recurrence in the breast is 0.6%. So how much, if you have already got B51 data, and if you already have data from larger trial like KEYNOTE-522, how much do you think that additional radiotherapy is going to improve that 0.6%?
Thank you. So I don't think we should be offering radiation treatment just based on the fact that this is a triple negative. I think we have strong evidence to say that even those who were triple negative, if they responded completely, then we can omit radiation treatment. My argument is that if the patient had multiple risk factors, including triple negative status and larger primary or larger burden lymph node, then we should still offer them radiation treatment. Triple negative on its own, if it was a small tumor to start with low burden, I don't think this should be a reason to routinely offer adjuvant radiation treatment.
Yeah, it's a great question. I think, of course, in the KEYNOTE trial, it was kind of before the results were published from B51, and some of the patients may have gotten already radiotherapy, even if they had a PCR, right? They were treated like that. But triple negative breast cancer is very hard to argue, in my mind, against if they meet the criteria for B51, because it's possible that they may actually be causing a little bit of harm. So it's very hard to imagine that these hazard ratios will go the other way. Now, in the case, for example, that was presented here, the patient had 3 centimeter residual disease in the breast. That's a little bit uncommon to realize that still the disease in triple negative breast cancer remains 3 centimeters and all the nodes are negative. It's not impossible, but it's unlikely. So for that patient, I would also be a little bit cautious because he had disease in the breast. But if there were total PCR in the breast and even 3 lymph nodes that have treatment effect, I would think that the patient would actually meet criteria and treat him that way. One last comment real quick. In all the retrospective studies, it's very hard to imagine. There's a lot of bias in these studies. We know that. And it's hard to imagine, for example, a patient with stage 3 disease did not get radiotherapy. Why did they get it? I mean, it could be because maybe there were other factors that made them think that this disease is past local regional phase, and therefore they didn't treat him, or the patient refused, is possible. But I'm very cautious about retrospective studies that show big differences. We've seen this in many other situations. stage 4 disease with surgery, for example, consistently a harm, I mean, a benefit if you do surgery, but it's not because you do surgery in the randomized studies, we don't see that. So I think all this evidence is important, but that's what we do randomized trials, because during all these studies, the conclusion was we need a randomized trial. Now we have a randomized trial. Now, of course, we have to follow more, we have to see more events, but now I think can I erase as much of the previous?
Thank you. Thank you so much. I have a question to you, but I would like to invite Dr. Marianne and Dr. Valentina to join us on the stage kindly. Thank you so much. Okay. So how do you reconcile, you showed us M820 and the EORTC trial, and there was a modest benefit, but we didn't see this benefit with the P51. Is it attributed to the improved radiotherapy technique or chemotherapy protocols that we're using nowadays? What do you think?
No, it's because these were patients that have surgery first. Okay. And of course, for those patients, nobody argues that there is benefit from regional radiotherapy, but with the neoadjuvant chemotherapy, you can select a group that actually is so responsive to systemic therapy that local regional therapy may not add much to it. And I think that's the main explanation in my mind for this data.
I have a question. How much the oncotype DX or the genomic assay would influence your decision, and mainly in maybe the postmenopausal, status?
So in the upfront setting, actually, there are now trials that evaluate the role of regional nodal radiotherapy for patients that have a low oncotype score. But in the neoadjuvant setting, it's a bit different because typically we don't take into account the oncotype score for these patients, the oncotype DX. We do neoadjuvant chemotherapy because we have clinically advanced states like positive nodes, multiple tumors. And of course, we have seen that those patients do benefit from chemotherapy, particularly in the premenopausal setting. Right? These results did not influence the B51. They weren't part of the trial, but for the upfront setting, we now are again trying to evaluate whether regional nodal radiation adds anything. This is in the MA39 trial for patients that have oncotype recurrence score under 25.
Professor Rost.
Thank you very much. This was a very nice presentations, multiple presentations. I would like to continue. I raised my hand at the same time with Dr. Aida. I wanted to speak a little bit the same. Why only in medical oncology we are raising all those molecular biology status, refining our treatments, desescalating? We are coming from high dose chemotherapy to nearly no chemotherapy, and later on with no treatment. Why those molecular biology status, not the oncotype, maybe other ones, are not applied for radiation therapy desescalation and for surgery desescalation?
Well, I can agree with a quick say, but they are applied because we have shown and others have shown that oncotype DX and some of the other molecular markers not only predict risk of distant recurrence, but they also predict risk of local regional recurrence. So we now are asking the question in randomized trials whether, for example, low oncotype score can be omitted breast radiotherapy. We have a trial that we're completing in the US now. So lumpectomy with or without breast radiotherapy. And the regional nodal radiotherapy setting, the MA39 is asking the question. So we absolutely taking into account genomic profiling for these patients in terms of local regional therapy decisions. However, we're not there yet. We need to complete these trials and see the results before we can omit safely radiotherapy.
In fact, we have 3 trials now. We have Lumina trial, we have IDEA trial, and we have Europa trial, all in patients with low oncotype DX.
And Deborah trial in the US.
Indeed.
An expert, also rather randomized. Several.
Did lymph node size matters at all in your review of the data? And those who had residual breast with negative nodes, did they have higher incidence of recurrence first and benefit from radiotherapy?
Lymph node size did not matter as long as the nodes were not matted, right? That's clinical in one. So, and then the second question was,
if you have residual in the breast.
Yeah, residual in the breast. So The hazard ratio trended a little bit towards more benefit with patients that had residual disease in the breast versus total PCR, but the confidence intervals clearly overlap one. So we cannot make the argument that, but obviously we feel a lot more comfortable if there is no disease in the breast and no disease in the nodes. Although, again, we know for sure that sometimes the disease in the breast may remain and the nodes could be negative, and vice versa. Sometimes the nodes remain and there is PCR in the breast. But definitely I will feel more comfortable. If you want to apply, for example, in an ER positive HER2 negative patient, I will feel much more comfortable if the total PCR in the breast and lymph nodes to avoid radiotherapy.
Prof. Naji. Can we get a mic for him, please?
Thank you very much. Naji Saghir from the American University of Beirut. Very nice presentation. I just have two questions, comment and questions, sorry. Dr. Khatib did not sound convinced of the sound trial. I think, you know, that the trial is really very important, and ASCO issued guidelines, you know, following that sound trial. I think the question of, so the patients with T1, you know, small tumors, clinically and ultrasound negative axilla, grade 1 or 2, postmenopausal, definitely the data is clear. The issue that we are faced with, you know, if you have rather an older age patient, 50 is not old, by the way, you mentioned that here. If you have rather older patients and you want to skip radiation therapy, here it becomes a question, do you skip both sentinel and do you skip radiation, or you do either? And you have to make sure your patient will take endocrine therapy. The other question I have for Dr. Mamounis is the number of negative lymph nodes. When you do the sentinel, if you have treatment effect in 5, sometimes you get 5 lymph nodes, 6 lymph nodes. If you get treatment effect in the 5, are you more sure that definitely no need for radiation, or you are concerned because they were not included in the inclusion criteria as having 5 positive nodes?
So as you mentioned, I am completely convinced with postmenopausal ER/PR positive small tumors that we can omit sentinel lymph node biopsy. The question is, what's the age cutoff, first of all? I agree that 50 is young, it's not old. Would it be 65 or 70 and above, as a choosing wisely already mentioned in 2016, so that won't be something new. As a declaration, I did a small retrospective trial in my previous work where we omitted radiotherapy and sentinel on such patients, 70 plus, who had up to T2 tumor with clinically node negative breast cancer, who were ER/PR positive, and we used to omit both. We didn't find any difference, but it was a very short follow-up, 5 years follow-up. And that's a very good question. Can we de-escalate in everything? Can we omit sentinel and radiotherapy, or shall we still go for sentinel in order to know if the patient will need radiotherapy or not? What I said about the sound, I think that we're still not ready to omit sentinel in premenopausal women and with aggressive biology. So.
Yeah, I will agree with that. I think we already started in our practice to omit sentinel lymph node biopsy for T1 and 0, grade 1, 2, postmenopausal patients. Age is not the factor so much as menopausal status, because you don't need the information to make decisions. You use a genomic profiling test to tell you when you need chemotherapy or not. Whether you don't give radiotherapy, that's a different question. Obviously, in the SOUND and the ENZIMA trial, about 14–15% of the patients still had disease in the sentinel lymph nodes. That did not make a difference, but they all received radiotherapy. So when I talk to a patient about sentinel lymph node biopsy omission, I typically tell them that they will need radiotherapy. Can you de-escalate both? Probably could in the 85% of the patients that had no lymph nodes, but you don't know who they are, and that's the issue. The other issue, of course, is systemic therapy, because now some of these patients may be candidates for a CDK4/6 inhibitor, so we kind of weed those out if we're going to offer omission. Going back to your question about the B51, if you have a clinical N1 disease, and I looked at this recently, what is the proportion of patients that have more than 3 nodes? And about half, give or take. So in B51 with a clinical N1 disease, it's fair to say that probably maybe not half, but close to that, had more nodes positive. But of course, we didn't know because we gave neoadjuvant chemotherapy. So to the patient that you mentioned, 5 nodes that are negative with treatment effect, particularly if I took out the targeted dissection with a node that was biopsied before, I feel comfortable even if there were that many nodes. Because they were included in the trial, we just didn't know, we didn't ask for PET-CTs or other imaging studies. But a good proportion of the patients probably had more than 3 nodes.
Excellent. One last question, Dr. Valentina. I'm one of those who are intrigued by the HER2-DX data. So how would you use it in your clinical practice? What have you started using it, and what particular situation would you incorporate it in making decisions?
Okay, thank you for, no, it's not working, thanks. No, because, okay, sorry. In Italy, we have the problem that is not yet reimbursed, but I use for a patient who has a private insurance. She had a tumor 1.5 centimeter, grade 3, hormone receptor negative, and we were in doubt of having she was 37, so we were in doubt of moving to, no, it was less than 1 centimeter, to go with the Tolani scheme or to offer the sequential therapy or the more extensive 6-8 courses of chemotherapy. And she turned out to have a low risk of recurrence, so we decided to use the Tolani, to apply the Tolani schema. So maybe in this situation, but of course we have to prospectively demonstrate the efficiency of the problem of the tool with the definitive trial. So we are about to start in Italy. In Spain, they already recruit more than 80 patients. So I think in the next few years we will have the results.
Excellent. Thank you so much. I think for the sake of time, we'll move on to the next session. I think it was an excellent panel discussion. Thank you to all the speakers. So we'll move on to the next session of breast cancer. I think all of us know Prof. 𝗜παιχ is an expert in breast oncology. He's the previous division chair of breast medical oncology at the MD Anderson Cancer Center. He ran multiple trials involving hormone receptor positive HER2 negative disease, and will help us answer some of the challenging questions in subsequent lines of therapy for those patients. Thank you so much, Prof. 𝗜παιχ.
Thank you very much. I appreciate being invited here. I'd like to thank Dr. El-Shamsi and the organizers to present this topic to you. So let's get started. The management of hormone receptor positive breast cancer in its metastatic setting is of course important. It is the most common subset. And I want to emphasize today the importance of biology in where we are today with management of these tumors. It's important to understand that the estrogen receptor pathway is an important driver of breast cancer. We've known that for a long time. Estrogen replacement, for example, is a risk factor. Other clinical factors that increase estrogen exposure is, and we have learned over the last few decades that resistance to endocrine therapies, which of course has been a very important modality in both the adjuvant and metastatic treatment of breast cancer, can be modulated by growth factor receptor pathways. And this can lead to resistance to endocrine therapy. So we have to look at the broader picture that I have illustrated here, that estrogen receptor interactions with estrogen can drive cell growth, which is mediated by the cell cycle process. But you can also get feed into that process through growth factor receptor pathways. And our modern therapeutics metastatic breast cancer now for the last decade. So I won't spend too much time on this, and I'll show you a summary of all the completed trials. And I do want to point out one thing, and that is that these trials have all shown roughly the same benefit with the different 3 agents that are approved and mostly used worldwide, and about a hazard reduction of a 45% in the risk this year, and showed again more than half reduction in the number of PFS events. And this study also looked at overall survival as a secondary endpoint and did in fact show a difference in that outcome as well. So this is now for that select group of patients that not only has a PI3 kinase mutation, but is recurring within a year of endocrine therapy. Side effects, again, as you might expect, similar to what we see with PI3 kinase inhibitors, but to a less extent because it is more selective for the mutant PI3 kinase as opposed to the wild type, which of course guides many other signaling activities. Another mutation that is of key importance and was discovered actually decades ago, but we didn't really understand the meaning of this, was mutations in the estrogen ESR1, which is the gene that encodes the estrogen receptor. And you particularly tend to see this after exposure to endocrine therapy, particularly estrogen deprivation therapy. So it is a subclonal mutation. We generally do not see it in cancers at the time of diagnosis, these mutations tend to occur in the ligand binding domain, but other domains of the estrogen receptor that essentially encodes an estrogen receptor that is constitutively active. So even in the absence of estrogen, it is signaling as though estrogen were present. So as you might imagine, the patients with these mutations tend to exhibit resistance to endocrine therapy, particularly aromatase inhibitors, but also fulvestrant as well. So there is a whole new class of drugs now being investigated that directly target the estrogen receptor. Remember, drugs like tamoxifen and aromatase inhibitor don't do that. Aromatase inhibitor lowers estrogen receptors, and tamoxifen interferes with the estrogen binding to the estrogen receptor, but when it's constitutively active, these drugs are not effective. So this new class of drugs, selective estrogen receptor downregulators, also SERANs, complete estrogen receptor antagonists, and PROTACs, which degrade the estrogen receptor and target it towards proteasomal degradation, are now being tested. The first one of these to actually be approved several years ago was elacestrant, the first selective estrogen receptor downregulator. And this showed an advantage in patients who had previously been treated with either tamoxifen or aromatase inhibitor therapy, and they were randomized to fulvestrant or elacestrant. And you can see that the benefit was primarily seen in patients with known ESR1 mutations and not in patients without it. So it is approved now selectively for that group of patients in any line of therapy. And we do know that patients who have longer progression-free intervals tend to do a little bit better with this drug. And this has been published subsequently, but it's really approved in any line of therapy once an ESR1 mutation has been shown. Another selective estrogen receptor downregulator that recently showed very positive findings at the ASCO meeting just this year was of a very interesting design. And this was guided by circulating tumor DNA analysis of patients who were on first-line therapy with endocrine therapy and a CDK inhibitor, who started to show new evidence of ESR1 mutations based on liquid biopsies. And those patients were then randomized to switch over to the SERD camizestrant or to stay on their current therapy, which of course would be the standard of care. When these patients were found to have these mutations, they did undergo restaging to make sure they weren't having clinically progressive disease, and then they were randomized. And this study did in fact show a clear improvement in progression-free survival in the group that switched over to camizestrant. Now keep in mind that when patients clinically progressed, they didn't have access to camizestrant if they were on the control arm. So there is a little bit of difficulty in interpreting this study, and it is now being evaluated by the US Food and Drug Administration. So we'll see how some of these issues relate to whether or not it'll be approved with this type of trial, but it is an innovative design. The other study that was presented at ASCO with the PROTAC, vepdegestrant, which is PROTAC's down for proteolysis targeting chimera. And they've been an instrument in the laboratory for many years because they bind a particular target to the proteasomal machinery, which is the trash can of the cell. It degrades proteins. And these drugs selectively bring the estrogen receptor into the proteasomal machinery for degradation. And in this study, patients who had progressed on first-line endocrine therapy were randomized to fulvestrant or vepdegestrant. This was a phase 3 trial that showed a clear improvement in progression-free survival, as shown here, roughly half of the events seen at this point in time. And in the overall patient population, you didn't see a clear difference. So again, like elacestrant, this drug is really specifically effective in patients with known ESR1 mutations, including by blood biopsy, which, by the way, is the best way to detect these, because as I mentioned, these are subclonal mutations. These drugs are relatively safe. They have similar side effects of SERDs, maybe a little more than you might see with aromatase inhibitors, hot flashes, and also gastrointestinal side effects, decreased appetite. Some people have diarrhea, fatigue as well. But generally, these are of low grade, and the number of patients who actually discontinue treatment for this is rather small. So overall, well tolerated. For patients who are refractory to multiple endocrine and biological therapies, we do use chemotherapy. And I'll later show you what our overall framework for treating patients is. But as you know, over the last few years, there has been a clear movement towards treating patients with endocrine therapy first. But those that are refractory, either due to low ER levels or refractoriness to endocrine-based therapies, are candidates for these drugs. And the antibody drug conjugates are really emerging as the most preferred, although they're not the only drugs available. One can use capecitabine and taxanes. And this is due to the fact that they do deliver drugs in a more targeted way to the cell. The DESTINY-Breast04 was the first one to look at this in the hormone receptor positive population and compared T-DXd to standard chemotherapy and showed a clear improvement in progression-free survival, and is now indicated in this situation. I think the key issue is how many endocrine-based therapies before you move on to drugs like this. Overall survival has also been shown. The DESTINY-Breast06 trial included the ultra-low group of patients. These are patients that are hormone receptor positive, but HER2 0, but some membrane staining, so 0 plus, if you will. And in this group of patients, again, you see a benefit from T-DXd, and also a slight benefit in overall survival. More follow-up is needed for this endpoint. The TROPiCS-2 study showed a similar benefit with sacituzumab govitecan, another antibody drug conjugate that did show a benefit in patients who had progressed on 1 or 2 lines of endocrine therapy, and both in terms of PFS and a small benefit in terms of OS, not quite statistically significant. So here is how we are approaching this group, really, to summarize things. I won't go over this in detail, but you have the slides available to review. But generally, we do CDK inhibitor and endocrine therapy as first line for patients with PIK3CA mutations, either upfront if they've had a very short time to recurrence with anavolocib, or in later lines of therapy with either with capivasertib now because of the side effect profile. We're not using alpelisib very much. And then moving on to chemotherapy when they become resistant, or if they have very rapid kinetic disease. And of course, elacestrant for ESR1 mutations. And then don't forget PARP inhibitors for patients that have germline BRCA1 or 2 mutations. So that's my whirlwind tour for refractory hormone receptor positive breast cancer. Thank you for your attention.
Thank you very much. That was wonderful. And our next speaker is Prof. Nuhad Ibrahim, consultant and medical oncologist from MD Anderson. It's our pleasure to have you with us. He's going to help us navigate the trajectory of endocrine therapy after progression on CDK4/6 inhibitors.
Thank you.
for this introduction. And without ado delay, let me get started, if I know how. Okay. Now they started up with a maze. I don't know where this maze come from. I know how to get into it, but I hope that I will get out of it. It's actually, in my opinion, is about to line up the ducks and how to get started when we plan the treatment of hormone receptor recurrent disease, because I feel like people rush into looking at numbers, published numbers, and saying this I want to do because it's better than the other, but it is a little bit more than that. Dr. 𝗘𝗱𝘂𝗃𝗁𝗂 touched on a lot of things, and there will be a lot of commonalities there. And I think he tried to get out of the maze by going to chemotherapy. That's smart of you, Dabu. Maybe I'm still in the maze. But let me get started. First of all, beyond the issue of aromatase inhibitors and tamoxifen and all those good easy days when we want to struggle about what is the best dose of tamoxifen and so on. But now with the era of CDK4/6 inhibitor, we see that a lot of data has been published, and I think the data is mature enough, but still continue to drag on all the future, all the coming studies comparing to fulvestrant. And every time when we see metastatic disease, I can see in my practice people who coming to the clinic to ask for second opinion or different options, and I see that their doctor says go with fulvestrant plus minus whatever it is. The CDK4/6 inhibitor studies in general showed that there are some improvement in overall survival, particularly in the Mona Lisa trials, but certainly when it is based on fulvestrant, then we need to think about, do we need to implement fulvestrant as a front line, with the understanding that fulvestrant in studies did show in the combination with CDK4/6 inhibitor improvement in overall survival. Let's go first to earlier studies. I'm not going to present everything there is, but it was tried that using a non-steroidal AI with CDK4/6 inhibitor followed by fulvestrant, or the opposite, and we see that does not really matter when we use fulvestrant in combination of CDK4/6 compared to AI, although there are some data to show there is improvement in overall survival. But this trial particularly, it is one of many showing that there is no rush to start with fulvestrant in the first place. And second, Dabu also touched on a switching of CDK4/6 inhibitor if a patient shows some progression on one of the or other of the CDK4/6 inhibitors. And it has been shown that the switching strategies may be beneficial for some of the patients, but definitely the outcome did not improve more than a few months, basically 2 to 3 or 4 months. The strategies discussed were switching from palbo to palbo, or keeping palbo on the scheme, but changing the endocrine therapy, and the other studies looking at the switching to ribo after palbo, which shows an improvement in about 3 months in the progression-free survival. Also, we have the post-menarche trial that switched to abemaciclib and fulvestrant. So if you use fulvestrant as a front line, this does not apply anymore. But again, the progression-free survival was modest, but still showing that there is not a complete resistance when a patient progress on one of the CDK4/6 inhibitor, and it is not a given like we used to think in cytotoxic therapy paradigms, that if you progress on one drug, you do not continue with the same. And also the post-monarch showing that progression-free survival with the prior CDK4/6 duration did not really matter a lot, nor the other biomarkers that were looked at in this trial, that is ASR1 and PIK3CA. So if the patient started on CDK4/6 inhibitor and endocrine therapy and progressed, you may still consider switching the CDK4/6 inhibitor, but the success rate is not really very good, but something you need to discuss with it. So should we be more savvy about the use of fulvestrant, therefore, as a frontline, despite the fact that when it's used with CDK4/6 inhibitor, it shows improvement in overall survival. And therefore, the bigger question here is, should we check PIK3CA status before we decide on using fulvestrant combinations as frontline therapy? So PIK3CA/PTEN AKT, there's a typo here, sorry, pathway is a very important pathway and need to be taken with heavy weight there before we really are able to line up the ducks. And to make it easy here, it says, if the patient presenting to the clinic with a mutation in the PIK3CA, and you start the patient on fulvestrant with CDK4/6 inhibitor, are you really depriving the patient of options that should have been considered in the first place? At least in my clinic and my practice, and I have that chance, before even I start any frontline hormonal therapy, I do check PIK3CA to see if I can see that I need to take advantage of the presence of a potential mutation, which is about 30 to 40% of these patients before I move on with my first choice of therapy. And this here comes the importance of the INAVO 120 study, which is a frontline therapy, however, for patients who have mutation in PIK3CA, where the inavolisib was used with palbociclib and fulvestrant versus palbociclib and fulvestrant and a placebo. And indeed, it shows the addition of the INAVO showed improvement in the progression-free survival, 17 months versus 7 months, although the palbo and endocrine therapy data showed a longer duration of progression-free of survival of about 10 to 12 months. Why it is shorter in this study, we do not know, but certainly the difference is statistically significant and very well welcomed. So if a patient coming to the clinic to discuss frontline hormonal therapy, should we consider this option if the patient is having a PIK3CA mutation? I think this is very appropriate before we use a fulvestrant with CDK4/6 inhibitor, and then we will not be able to implement this option. The overall survival has improved to 34 months compared to 27 months with the placebo arm, and the response rates were really significantly better, 63% versus 28%. So there is a real value in using these options here before we proceed with the others. But remember, and Dr. Tripathi had touched also on the second line options for PIK3CA mutations, and so here becomes the question: would you bet on CDK4/6 inhibitor and non-steroidal, which gives you the progression-free survival of about 26 to 33 months versus INAVO-based, which gives you progression-free survival of 17 months, but also improvement in overall survival. This is really something need to be discussed with the patient, but also I'm not sure if it is appropriate that we can add the benefits that we can have
from giving the PI3K inhibitors as a second line after failure of a frontline endocrine therapy with a CDK4/6 inhibitor. And indeed, which is very, very impressive, is that using the inavolisib option delayed the use of chemotherapy significantly to about 35 months compared to 12 months in the standard of care options. So this really indicates that before you discuss any therapy, including fulvestrant-based therapy, you need to know if this mutation is there or not before you line up your ducks of what to do. Many times it's very easy to say, this is your front line, go with it. But also, I always think, what do I do next? I know this patient is going to fail this therapy one time or the other, 1 year, 2 years, 3 years later, I do not know. But I'm going to face what would be the second option. And I don't want to see, oh, I wish I did not use fulvestrant before, because now I know she has a PI3K mutation and I missed some options to that. Moving on to the other PI3K pathways in the second line of therapy, including alpelisib and fulvestrant, or capivasertib and fulvestrant. So you see fulvestrant shows up every time, and all the future studies that I might touch on, and Dr. 𝗘𝗱𝗂𝗰 touched on, the control arm was also fulvestrant, and I hope we get to the point when we challenge our studies with a control arm, which has proven over the years that it's more effective than fulvestrant itself as a single agent. In the SOLAR trial, indeed it showed that in patients that have PI3K mutation, the overall response rate almost doubled compared to the control arm, and the progression-free survival also doubled to 11 months compared to 5.6 months. So we know that that PI3 addressing PI3 mutation, even as a second line, is extremely important, but I'm not sure if these numbers hold if the patient will have a prior exposure to fulvestrant. I would rather to see that the patient will fulvestrant naive before I would use alpelisib. However, it did not show a significant improvement in overall survival, although there was a trend towards that. Capitello is also a very important study. Definitely, it is less toxic, but again, it is compared to fulvestrant. So fulvestrant is my nightmare, because every time I see it, and then I have to look backwards, say, did she receive the fulvestrant one place or the other? No. If not, then it opened the road for me. But if it was, then it limited my options when the patient shows or is tested positive for the PI3 mutation. In this trial, it shows that about 2/3 of the patients received the prior CDK4/6 inhibitor, and also about 2/3 of them they were shown or labeled to be resistant to that option. Progression-free survival shows significant improvement, almost doubled from 3.6 to 7.2. The same hold true with the AKT pathway altered subpopulations. So this option is a very good option to be used on these patients. And the forest plot, indeed, it showed that all subgroups of patients did benefit from this drug. But again, all these patients on these studies did not receive a prior fulvestrant, so be careful of that. The old second, third line therapy, we can always revert to it. However, in the absence of clinical trials, we do have a lot of clinical trials in our department. Dr. 𝗘𝗱𝗂𝗰 witnessed the development of many concepts there, and also in the phase 1 group. Also, they have multiple trials to that. But in the absence of any further clinical trials, we still use exemestane or everolimus, and for that matter, fulvestrant and everolimus as a second or third line, depends upon where do we stand with. Now, we cannot stop there without looking at the other important mutation. And the bigger question now, is it still relevant to test for it? With the understanding that while the more hormonal therapy the patient is exposed to, the higher the chance that the patient will develop ASR1 mutation. The landmark study is the Emerald trial, the elacestrant, which showed that the patient's improvement.
Continue.
What?
1 minute.
No.
No.
Everybody took more than 1 minute.
Okay.
CDK4/6 inhibitors.
You're objecting.
Okay, can we stop now? I have no problem.
No, continue, please.
Okay. Right, Terry? Okay. I'm sorry for that. So indeed it shows improvement, and the improvement was noticed at over time 6, 12, and 18 months, which was a very good breakthrough for patients who progressed on endocrine therapy but chose to develop ASR1 mutation. Chemist's strength also touched on a little bit earlier and showed that is a significantly improved progression-free survival and definitely better than fulvestrant. AMBER is a very landmark study. Again, is as equally important as the previous PIK3 studies that we mentioned, because here it shows that probably we do not need to test for ASR1 mutation, and for that matter, whether the patient has the mutation or not, they may still benefit from imlunestrant, and it shows not only that but also improve the overall survival. And it was recently approved, and it is a welcomed approval. However, the more significant results included when abemaciclib is added to imlunestrant, and it shows again significant improvement in progression-free survival, irrespective of the ASR mutation, and it's almost doubled the progression-free survival, and this much better than what we see in progression-free survival with imlunestrant and the SR1 mutation, and irrespective of a prior CDK4/6 inhibitor or not, or P3K mutation or not, the results benefited, and there was significantly different minimum doubling the effects. And this is shown even with the patients who have prior CDK4/6 inhibitor, or whether or not they have PI3K mutation or not. Not only that, as a side results, it showed that it is decreased the CNS disease activity or lack of progression in the CNS. So ASR mutations and oral search showed across the board significant improvement, but did not cross the 40% level, as it was shown in this slide projected at ASCO by Kamel, and indeed remains a good option. But do we really have to stick to give search to patients with ASR mutation, or we can go beyond that point? VERITAC trial also is another study that shows significant improvement. It was recently published in New England Journal of Medicine, and pretty soon we are going to add it to our list. However, in ASR mutation, lasofoxifene, which is one of the drugs being developed actively by one of my colleagues, Dr. Damodaran, and he is pioneering a lot of the data over there, and we hope that also will join the rhythm of this progression. Adopted from Dr. Bernstein, showing that all these studies, however, only to show that AMBER-3 stands out in terms of median progression-free survival, and I am sure that the future data will show that there are significant further improvement in overall survival. ESMO guidelines, which to how to line up these studies was projected and illustrated in the last San Antonio trial, which talks about the importance of the mutations and implementation in our line of thinking, how to think about lining up all these options and take advantage of any single piece of data that we have. Also at MD Anderson, we developed our own algorithm, which is a big overlap between the two, but it's not a photocopy of each other. Also emphasizing the importance of these mutations and not avoiding the choices of chemotherapy when needed, and Dr. Tripathi went across these options very thoroughly. And with this, I would stop it. I'm sorry for this delay, but I'm following through. But I'm following.
Thank you so much. I would love to give you the whole day to discuss this, but no, Hamid signaled me. So. Okay.
They're using our friendship, Ahmed. I'm not believing her.
Thank you very much, everybody. And of course, now we are using CDK4/6 inhibitor in adjuvant setting. And the question that is arising, how do we do if the patients progressed on CDK4/6/7 while receiving it in adjuvant setting? Dr. Saeed will moderate this discussion. Please have a seat, Dr. Nohad. We will invite also, you're going to invite Dr. 𝗘𝗱𝘂𝗰𝗵?
Yes.
Yes.
Thank you so much indeed, Professor Nohad. Amazing discussion. So we have this panel discussion now. Can I invite Dr. Aida, already here, and Dr. Naji Al-Saeed, please. And then Professor Valentina Guarneri, and then Dr. Farouk Latif as well to join us. Okay, perfect. So
can I invite Dr. Adima to be with us as well?
Yeah, sure, absolutely. If there is enough space here. I don't know if you have enough seat. Okay, so we're going to discuss, how obviously to make, this landscape a little bit more difficult, because obviously, a lot of data that we currently have, they are coming from the time that not a lot of people, they had adjuvant CDK4/6 inhibitor. And as you can see, we are increasingly using adjuvant CDK4/6 inhibitor. We have two clinical trials, obviously one monarchy and the other one NATALEE clinical trials as well. So, it is a little bit confusing now how we're going to manage the recurrence while the patient they are receiving adjuvant CDK4/6 inhibitor or shortly after. So obviously, like I said, both of these CDK4/6 inhibitors, they have shown to improve the invasive disease-free survival, and obviously the OS data is going to be announced shortly, hopefully in ESMO as well. If you look at the curves, actually for this is for monarchy, for the invasive disease-free survival, you can see that around 5% of the patient, they're going to have a recurrence of disease, sometimes within 12 months, while they are still having adjuvant abemaciclib. At 24 months mark, which is the completion of the adjuvant abemaciclib, another 2-3%. Again, at 30 months, 6 months after the completion, and around 12 months after the completion. So we have roughly around 10% of the patient, they are having a recurrence while they are taking CDK4/6 inhibitor, and the same is true also for the distant recurrence as well. Looking at NATALEE, it is not too dissimilar. It is the same kind of stuff. You are taking CDK4/6 inhibitor at 36 landmark, which is you are still on CDK4/6 inhibitor. Around 10% of the patient, they're going to have a recurrence of the disease. So the key challenge here is at the moment how best to treat recurrence during or after adjuvant CDK4/6 inhibitor. And I have a series of questions to ask of our colleagues here. One is that how actually we define recurrence. What is the early relapse on or after adjuvant CDK4/6 inhibitor? Is there any timeline for primary CDK4/6 inhibitor recurrence? Professor Nuhat, would you like to start?
The early relapse is really defined in that trials, which when patients are still taking the CDK4/6 inhibitors and adjuvant and relapse within 6 months, but definitely not more than 12 months from completion of the CDK4/6 inhibitor. Basically, these trials will use the definition of resistance that was coined many years ago: primary, secondary, and tertiary resistance. Although secondary resistance takes the recurrence within 2 years, but on these studies is within 12 months. So a patient coming within 12 months with a recurrence while on or after receiving abemaciclib or ribociclib, yes, the question of resistance becomes very high on the list. But again, as I showed, that crossing over to other CDK4/6 inhibitor is worth trying in this group of patients as well, but do not expect to see the same results that we have seen when it is given as a primary line without prior exposure.
So everybody agrees with that definition, or within like 6 to 12 months from the completion of CDK4/6 inhibitor, we call it primary CDK4/6 inhibitor resistance?
Well, I think now with the new trials of introducing ESR1 inhibitors, I mean, we're going to have this even a bigger problem, right? When we have the adjuvant setting, the ESR1 inhibitor plus CDK4/6 inhibitor.
That is in the early setting. That is not in the
Correct. But now we have many trials that is taking the ESR1 inhibitor plus the CDK4 in the adjuvant setting, right, Dr.
Yeah. This is really highlight even more the need to check the PIK3CA mutation, and if it is mutated, you have other options that you can use and allow you to reintroduce in that situation palbociclib, which was not used in the adjuvant setting, and I think you have options, but besides to detect ESR1 mutation. You need the chances of higher rate of mutation goes with more endocrine exposures. So if it was only 5 to 10% early on, you may miss an ESR mutation later on. But now with the immunocistrin is becoming on board, can open the another avenue for these patients.
One comment, if I may. Very interesting. I agree with Prof. Nuhat 100% on the definition, but sometimes I wonder, because I had 2 patients who soon relapsed after I stopped CDK4/6 inhibitors. And I wonder whether they are actually sensitive, and I pulled out the CDK4/6 inhibitor, and now the clone started to act. So just a thought, which I think is very
Professor
interesting.
𝗔𝗡𝘂, are you agreeing with this PIK3CA in the early setting? Do they actually behave PIK3CA mutation in the early setting as they do in the metastatic setting?
They do to a small extent. There was a very nice study by Ben O'Leary looking at the PALOMA-3 study that showed that PIK3CA can emerge on treatment and can be a little more resistant. I don't think it's a huge driver, but we don't really have a good definition for primary CDK inhibitor resistance, certainly in the adjuvant setting, because it's all very new. So we're going to need to have some time to define that. But I think what Nuhat proposed is reasonable. It's what we've used for endocrine therapy in those timeframes. The complicating issue is we don't know if the resistance is being driven by hormonal resistance or by CDK resistance, because if you're not sensitive to endocrine therapy, you're not going to respond to endocrine therapy plus CDK or PI3 kinase inhibitors. That was shown very nicely in the metastatic trial of Mona Lisa. We pooled all the data from the 3 Mona Lisa trials, and we had liquid biopsies available to look at, and about 5% of patients have the basal phenotype by RNA profiling if you go to the primary tumors, and those do not respond at all. Another mutation that you see is retinoblastoma loss. If you have RB loss, you are not going to respond to a CDK inhibitor because the retinoblastoma protein is the target of CDK inhibitors. That's not very common mutation. So we need to be studying these cases, defining the genomics, which is a very important part of the new classification, I think, and have enough cases so that we can start to define these and develop a better treatment.
Farooq, you have any comment?
I just wanted to make one comment really. I think what we are trying to define here is once we define resistance, are we going to re-challenge CDK4/6 inhibitors? I think the 12 months timeline is probably reasonable. I think that's the question we are trying to address. So if somebody in the adjuvant setting progressed after 12 months of stopping CDK4/6 inhibitors, can we use it? I think yes, 12 months is a very reasonable timeline. The question now is, obviously you will have to change your endocrine partner because they progressed on AI. And the other question is what genomics these patients have after the molecular profiling, whether they have developed an ESR mutation, and what would you do in that situation? So I think the data at present, we don't really know, but yes, if somebody progressed after stopping, 12 months after stopping, you probably will go back to full Western-based therapy with CDK4/6 inhibitors.
Professor Naji.
Thank you very much. So to summarize this up, excuse me, we have to determine if the patient has endocrine resistance secondary to endocrine therapy, or is it endocrine resistance secondary to CDK4/6 inhibitor. At the ABC guidelines, ABC7, we included CDK4/6 inhibitors in the definition, primary resistance or secondary resistance. That's something that we really have to sort out. The duration, is very important. How long the patient was sensitive to endocrine therapy and CDK4/6 inhibitor has to be taken into consideration. It's very important. The mutations, PADA1 and the SERENA had shown that if you get mutations along the way, you can switch. The one thing is important also, I think, when you have primary resistance to both, relapse within a few months, then there you should consider chemotherapy as mentioned. And considering TDXD, I would say, that you have to really look into the clinical situation because TDXD was compared to in DB06 with capecitabine, paclitaxel, etc. So if the patient has visceral high load disease, suspect of minimal brain mets, then definitely would go for
we address this one in a second. How do you have another?
Yeah, to try to avoid the clinical relevance of the definition of resistance, we have a patient is progressing and what you want to do for it. And I think there are two things you can do. If the patient is PIK3C mutated, you can put her on the inavolisib study. And if not, as Dr. Tripathi said, and it's in the post-menarche trial where patients did very well when they were put on fulvestrant and abemaciclib and doubled their progression-free survival. So you have two options if you do not have a clinical trial.
We come to those options because it is just we are at the definition. We are trying to address it. So, Professor Guarneri, what is the difference, in your opinion, between somebody is having a recurrence while taking adjuvant CDK4/6 inhibitor or after completion of therapy? Do you treat this patient, in your opinion, differently?
I think it's not only a matter if they're relapsing while on, or because there is not the magic number, 24 months, okay, and then 3 months later you consider sensitive or not. I think it's an issue of probably the timing between the end of the adjuvant chemotherapy, because don't forget that the majority of the patients in the monarchy trial have received chemotherapy. So if you have a patient who progressed after 3 months of taking abema plus hormonal therapy is different from those who relapse after 2 years of taking abema. So I think it's a matter of the kind of clinical progression on the degree of expression of hormone receptor at the beginning, because you know that we can enter also patients with 20% estrogen receptor as soon as they relapse 6 months after the adjuvant endocrine plus CDK4/6. Maybe it's better to recharacterize the disease, because don't know if you are selecting emergent clones who tend to be ER negative. So it's a matter of endocrine resistance, not to the combination. But of course, in terms of patient who you consider still candidate to an endocrine option, if you have 12 months after the completion of the CDK, I will consider again CDK4/6 inhibitors. If you are while on, or maybe I could try to find alternatives, including the possibility of having DXD, because
so coming to question number two, apart from the the definition that and the ones that we just discussed about PIK3CA mutation or BLAS, etc., is there any other genomic or clinical classifiers that you guys suggest that if I have this pattern of the patient with these characteristics, whether they are clinical characteristics or genomic characteristics, these are the patients that are probably going to progress on adjuvant CDK4/6 inhibitor. I treat them as a high risk. Is there any, Professor Tripathi, do you want to comment on that?
We don't have any established ones, but some of the rare ones that I mentioned are almost always predictive, like retinoblastoma loss. But this is something that we absolutely have to gather, as the other speakers have suggested, prospectively or even retrospectively where the data exists, to put together a framework of both clinical and genomic predictors, and then to test, to develop clinical trials that are rationally based on the targets that we feel are true vulnerabilities.
So one more.
The signal of
P53.
Excellent.
And also the pattern of progression is important. Like, is it oligomets or like it's full-blown metastatic disease, right,
Absolutely.
Dr. Nihat? Because now we can address it locally, sometimes keep them on the same hormonal therapy. You do that, Dr. Nihat?
Okay, so another question that I have, maybe we can start from the other end, from Professor Nadia. Do you think that we should incorporate ctDNA in that kind of follow-up in the early setting?
On a clinical trial, yes.
I think, yes, we do have strong data, for incorporating ctDNA. It is always very important to check at recurrence. Now, the issue is how to do it. As far as we are concerned, first of all, how often we should do it, every 2-3 months or longer. Second of all, the cost, with all those available on the market, the Guardant and the Foundation and all this, they're important, but they're very expensive. Now, we are starting in the process of acquiring the RT-PCR. I think then doing the RT-PCR become less expensive, and it will be definitely more useful for clinical decisions.
Any other comments on ctDNA? You use ctDNA in the early setting?
No, we are having a whole platform of research on ctDNA and minimal residual disease, but we are not really using it for making clinical decisions at this point.
And why not? I mean, we have used SERENA-6 in the metastatic setting, so why not in the early setting?
What test you want to use to check on ctDNA?
That is, I mean, PIK3CA mutations to begin with. That may be a case. But anyway, we do not have any data, so let's move on to the next question. So I think, we early on, we tackled some of these things, but I just wanted to get your views regarding re-challenge to CDK4/6 inhibitor. Maybe we start from the middle and we'll come back to you in a second.
No, let me finish with the ctDNA. What is a bigger question there? If you follow the data, you can see patients may start up with high ctDNA and then go down, or normal ctDNA and then they go up. So really, we do not understand the clinical course and the clinical implication of that ctDNA, and until we find a very sensitive test and the importance of how to address the variations in testing the ctDNA, I don't think we'll be doing proper clinical decision based on that. I know there is a significant data in the neoadjuvant setting, may change the definition of pathologic remission there. This is a very good start, but definitely it is not the prime use in the clinic today.
Sure. Now, regarding re-challenge with CDK4/6 inhibitor, Professor Guarneri, do you have any feedback on that?
Yes, I think it's reasonable if you have a significant, to me, time between the end of CDK in the adjuvant. So if you have 1 year, why not re-challenge? And my option, of course, would be to switch, since now we have the possibility to have, so not to re-challenge with the same CDK, because also from...
Would you do the same, Farouk? You would?
Yes, I think 12 months is a reasonable time. So I think switching to CDK4, maybe using a different CDK4/6 inhibitor, which you use in the adjuvant setting, and switching endocrine therapy partner as well. And the chemotherapy, if patient is in visceral crisis, or you're worried about.
Perfect. I think, we tackled some of the other questions, such as the molecular targets, obviously, and then the chemotherapy, and obviously ADCs. So with that, thank you so much indeed, everybody, for your participation, and thank you for listening.
Thank you so much. We are half an hour late, so we'll move now to the next session, Innovation in Oncology. I would like to welcome Dr. 𝗘𝗱𝘂𝗰𝗵 Mohammed, who is the head of anatomical pathology at Berger Cancer Institute, Dr. 𝗜ጵ الفهيدي, a consultant oncologist from Saudi Arabia, and he's the president of the Saudi Medical Association. Also would like to welcome back to Saeed Al-Rafai as well to moderate the next session. دكتور متعب تفضل.
Hello, doctor. Assalamu alaikum. How are you?
دكتور متعب. دكتور سعيد. Professor Timothy.
I actually have, before this, I have, okay, I will introduce Professor. Yes. So actually, this is a session about innovation in oncology. So since we have the AIs and everything, what are the odds of the two oncologists who haven't seen each other for 10 years and living in different countries would randomly meet in a pottery shop in Taiwan? What is the odds of that? So we gave this question to ChatGPT, and obviously there are different calculations. One is the daily probability of being in the Taiwan at the same time, in the same pottery shop, and overlap in time, and total probability, if you are generous, 1 in trillion. And this is what happened at the same time with Tim and me. So with that, it is my absolute honor to introduce Professor Timothy Yap, who is a professor of oncology at the MD Anderson, and also head of the therapeutic phase 1 clinical trials at the MD Anderson as well. Tim and I go a long way back at the Royal Marsden Hospital, but he was in a different level, and obviously he has done quite a lot of work on DNA repair, PARP inhibitors, and Capitello trial that you saw before. He is also part of development of that medicine as well. So with that, it is an absolute great honor to ask Professor Yap to deliver his keynote lecture. Thank you.
Thanks so much, Saeed. Good morning, everyone, and thank you all for being here. I really want to thank the organizing committee for inviting me to your beautiful country. Professor Al-Shamsi, thank you so much. So it's wonderful to be here today. Great session this morning. I've learned so much about breast cancer and all of the arguments for and against different therapies. You know, as an early drug developer, all of these drugs, I'm so envious of all of my breast oncology colleagues. You know, I walk through the corridor and I see that each of the drugs that they give has its own stand, right? You know, and all of the trials that you guys do are huge trials as well, thousands of patients involved. In my world, as a drug discoverer, drug developer, and early phase clinical trials, we don't have that kind of luxury. But why I'm so excited about early phase drug development is because we keep ahead of the entire field. That is the pressure on us. We have to identify new drugs that are going to be successful in the next 5 to 10 years. So, for example, you know, we talked about PIK3CA inhibitors, AKT inhibitors. Right now, we're already working on AKT1, E17K specific, mutation-specific inhibitors. We also have mutation PI3K specific H mutant inhibitors as well, just against very specific mutations. Also, we're developing CDK2 inhibitors, KAT6A inhibitors for CDK4/6 inhibitor resistant breast cancer patients as well. So it's a very exciting time in oncology, but I've been asked to talk about how we're now drugging the undruggable using something called synthetic lethality. And that's what I'm going to be focusing on in the next 15 or 16 minutes. These are my disclosures. So what is synthetic lethality? I think this is an important concept that we should all think about, and I'll come to why that it's so important. So a guy called Theodore Dozansky termed synthetic lethality back in 1946. This was a concept then, but now it's a bona fide anti-tumor strategy. And it's actually the strategy that led to the discovery that PARP inhibitors such as olaparib, niraparib, talazoparib work in tumors with BRCA1 and BRCA2 mutations. So what is this concept? The concept, put it simply, if you think about two different genes, gene X and gene Y, if both genes are normal, the cell lives. You don't have a problem there. If you have a mutation in gene X or gene Y, there is also no effect on the viability of the cell, and the cell lives. However, if both genes are affected, loss of the gene function, for example, through a mutation or through pharmacological inhibition, that will basically lead to cell death or apoptosis. So in other words, a mutation in either gene individually has no effect, but combining the mutations leads to apoptosis and cell death. So you're probably wondering, why do I care about that, right? I'm a clinician. Why would I care about that? Well, because you can actually induce inhibition of one of those genes, if you like. So essentially, the whole concept here is that by introducing a PARP inhibitor to patients who have a BRCA mutation tumor, that will lead to death in the cancer while sparing the normal tissue where the BRCA function is still present. So why is it important? And I want to try and convince you by the end of this talk that synthetic lethality is not just about BRCA mutations and PARP inhibitors, but it really helps us go beyond the usual tapped cancer lesions that we've gone after for the past 20, 30 years. Because I'm sure you'll agree here, I mean, in the previous talks, the whole focus of precision oncology for the past 20 years has been on the gain of function targetable alterations like HER2 amplification, for example, EGFR mutations in lung cancer that you'll hear about in the coming talks at this conference. But by thinking about synthetic lethality, it'll actually allow us to go beyond that 30%. And as an early drug developer, we really want to be developing new drugs for patients. We can't be focusing on the same 20 to 30% of patients. We need to raise that bar by going after gain of function, untargetable, undruggable alterations like CCNE1 amplification. We need to think about other tumor suppressor alterations beyond BRCA1 and BRCA2 mutations. And so there's an untapped space that's out there. 70% has not been drugged to date, all right? And that's why it is so important to think about how to do that. And we can do that with synthetic lethality, all right? And there are now examples. PARP inhibitors are one of them. So going beyond the FDA approvals in BRCA1 and BRCA2 mutations, we know that PALB2 mutations behave very similarly. The B in PALB2 stands for BRCA, right? RAD51C and D alterations similarly as well. They all lead to homologous recombination deficiency, and that has a synthetic lethal relationship with PARP inhibitors. We're also finding, again, in early phase trials, not approved, nothing I'm talking about here, by the way, is approved, right? But that to me makes it exciting. That to me shows you that things are coming up in the next 5 to 10 years. And you know, one of the big advantages I have as an early phase doctor is I can see what's going to be hot in the next 5 to 10 years, or will get approved, hopefully in the next 5 to 10 years. ATR inhibitors also work in ATM loss of function alterations. That is a common alteration that we see in different cancer types, including breast cancer. PKMYT1 inhibitors have a synthetic lethal relationship with CCNE1 amplifications. That's commonly seen in about 30% of ovarian cancer. We're also seeing it in about 10–20% of breast cancers as well. I'm going to be touching on Werner helicase inhibitors in MSI-high tumors. I'm sure you guys have heard of MSI tumors because of the efficacy of PD-1 and PD-L1 inhibitors and also CTLA-4 inhibitors. But not all of these patients will respond to those immunotherapy drugs. And even if they do respond, ultimately they will progress at some point and will need a new treatment. And this is a new class of drugs. It has a synthetic lethal relationship with MSI tumors. Another exciting class of drugs, SMARCA2 inhibitors, they have a synthetic lethal relationship with SMARCA4 mutation tumors. For those of you who treat lung cancer, non-small cell lung cancer, this is not uncommon. It's found in about 10 to 15% of patients. Similarly in esophageal cancer as well. And then finally, I'm going to be touching on MTAP loss or MTAP deletions in tumors. And again, it has a synthetic lethal relationship with a new class of drugs called MTA-cooperative PRMT5 inhibitors. Why is this important? It's because we don't have drugs for these patients who have MTAP loss. And what was so interesting about this relationship here is that these drugs actually led to many different NGS companies actually introducing a new gene into their panels. So Foundation actually introduced MTAP deletions into their panels because they saw early efficacy of these drugs in MTAP loss tumors. So why is this so exciting? I think it's exciting personally. Again, I'm biased, but it allows me as a physician to use biomarker-driven patient selection strategies to really guide the clinical development of multiple different agents. It's not just about ESR1 mutations. There's so many different alterations that one can think about. Dr. 𝗂𝗂𝗂 mentioned NGS testing, ctDNA testing. We're using that now routinely. Cost is absolutely an issue. But my prediction is that in the next 5 to 10 years, that cost will come down. And increasingly now in clinical trials, what we're doing to reduce the cost is to actually just bank the samples and then to retrospectively analyze it, because banking the sample costs nothing. It is actually the NGS test that is costly, ultimately. So I'm going to be touching on these 3 different classes of synthetic lethality in the next 9 minutes. I promise to keep to my time. Anyway, we all know that there are 4 approved PARP inhibitors out there. They're approved in different settings, different cancer types, but you can see that they all have side effects, all right? But it did provide proof of concept for this whole synthetic lethal approach in oncology. But these first generation drugs are limited by side effects. When we ran the first in human phase 1 trial, we couldn't dose escalate the drugs because of toxicities that we were seeing. There are 3 mechanism-based toxicities: myelosuppression, fatigue, and GI toxicities. In addition to that, resistance always sets in. And so there is still an opportunity to do better. And so what we found through many years of research is that actually to shrink the cancers, you only need to block PARP1. And the PARP2 inhibition, which many of these first generation drugs actually inhibit, actually leads to myelosuppression. And that's because PARP2 is integral for erythropoiesis. All right, so all of the first generation approved PARP inhibitors block PARP1 and 2. So wouldn't it be great if we could dial out the PARP2 inhibition and really focus on these PARP1 selective inhibitors? This will, as predicted, have a more tolerable profile. It will allow us in the clinic to actually get much higher doses of the drug into patients, which means that we can get much higher drug exposures and also target inhibition as well, and hopefully better inhibition ultimately and efficacy. And you can see here, and I'm not going to go through this, but really impressive tumor regression, even after stopping the PARP1 selective inhibitor in the graphs on the right-hand side. And that has really led to an explosion now. We started the first in-class drug from AstraZeneca only a few years ago, and now there are more than 10 PARP1 selective agents out there. And I think in the next 5 to 10 years, these drugs are going to get approved. So what have we seen so far in the phase 1 trials that we've been running? I'm just going to highlight 3 key areas. First of all, in the graph on the right-hand side, you can see the drug exposure, so how much drug you can get into patients. And the box in blue are the approved PARP inhibitors. Compare that with the increasing doses of the PARP1 selective inhibitor and increasing doses in a phase 1 trial of the PARP1 inhibitor 𝗂𝗏. You can see that already in a phase 1 trial, we are achieving up to 50-fold greater drug exposures. And these were the responses that we're seeing, for example, in heavily pretreated HER2-negative breast cancer. And again, we were looking beyond BRCA1 and 2 mutations. So we were looking at PALB2 mutation patients, RAD51C and RAD51D mutation patients. And we saw responses at different doses, as you can see here. We saw responses both in HR-positive breast cancer and also triple-negative breast cancer if they had one of these 5 different mutations. We also saw that the actual different mutation would still lead to efficacy as well, whether it's BRCA1, BRCA2, PALB2, RAD51C, so on and so forth. And ultimately, there was nearly 50% response rate in the phase 1 trial out of 30 patients, and a PFS of 9 months, which is pretty impressive. And then to Dr. 𝗂𝗂𝗂𝗏's point about ctDNA, this is so important. I don't think of this as a single utility biomarker, but really as a multi-utility biomarker. First of all, in the adjuvant setting, but also in the metastatic setting, in terms of monitoring patients for progression, for response, so on and so forth. And also as an early treatment biomarker for PFS, as you can see here, majority of patients with this drug actually had pretty nice molecular responses there on the left-hand side. And then on the right-hand side, we see that a molecular response at an early time point would predict that patients would do well with superior PFS. All right, very quickly in the last 4 minutes, I just wanted to highlight a new class of drugs called these PRMT5 inhibitors. There was also a cousin called MAT2A inhibitors as well. And again, this is a synthetic lethal drug with MTAP lost tumors. I'm not going to go through the basics here, apart from saying that this is an active area of research. There are now multiple phase 1 clinical trials, but this is what we're seeing. The whole, traditional thing about phase 1 trials where you see 2 or 3 responders is a thing of the past, because we can now select for patients with these new alterations. And by selecting for MTAP deletions using a foundation NGS assay, for example, and these are patients who are out there, we can actually help these patients by giving them this new drug called an MTA cooperative PRMT5 inhibitor. And there are different companies now, as shown earlier, that are actually developing these drugs. As I mentioned, it's also got a cousin that works along the same pathway and also has a synthetic lethal relationship with MTAP loss tumors. MET2A inhibitors are a burgeoning class of drugs as well, and again, showing great promise as well, with nice overall response rates of 33%. And again, just to show you that we are doing ctDNA testing in all of our patients, you can see here, even in a phase 1 trial, those biomarkers are showing a lot of promise in terms of predicting for response and also guiding us in the drug development of many of these drugs. Now, finally, just want to touch on MSI tumors. So what has been known for some time is that MSI tumors are responsive to immunotherapy drugs, but they also have a synthetic lethal relationship with these drugs called Werner helicase inhibitors. So the whole rationale here is that MSI tumors are highly reliant on a protein called Werner, and if you actually inhibit that protein, it will actually lead to apoptosis in those tumors. Not very much is known about Werner helicase. It's a DNA caretaker enzyme. It's a DDR enzyme. You've probably heard about DDR in terms of PARP inhibitors, ATR inhibitors, and it's another kind of a DDR drug, if you like. And so that first discovery was made in 2019. 5 years later, we were in the clinic developing this in a phase 1 trial. We presented the first data at ASCO last year. There are now multiple different Werner helicase inhibitors that are out there, and we're seeing responses. So we saw responses across different cancer types, including endometrial, ovarian, and colorectal cancer, if these had MSI high tumors, importantly, because you have to have that molecular alteration. Again, stressing how important it is to do NGS testing on all of your patients. And what we saw was very durable disease stabilization or response as well. Our first patient treated at MD Anderson, you can see here, I just saw her a couple of weeks ago. She's still on treatment, 0 toxicities. She's a patient who had progressing MSI colorectal cancer. She's been on treatment now for more than 2 years. Quite remarkable. We're also using FDG PET scans to monitor patients for metabolic responses. You can see their responses in more than 50% of patients. Again, ctDNA showing nice molecular responses, indicating that this drug is an active drug, doing something for all of these patients. What we're working on currently is better molecular biomarkers, so TA repeats using whole genome sequencing, and also thinking about resistance as well to these drugs. So these are the current challenges that we're working on, better predictive biomarkers to reduce the toxicities, to think about resistance in all of our patients, even at a phase 1 level in clinical trials. And also ultimately, how to do better, how to better serve our patients by thinking about different combinations. And with that, I thank you so much for your kind attention, and I've kept my time, so thank you very much, everyone.
Thank you, Dr. Timothy, for this really interesting talk. We'll introduce Dr. Suwatni. She is the Medical and Precision Oncology Director, Clinical and Translational Oncology Research at the HN Reliance Foundation Hospital in Mumbai. She led medical oncologists and specialized in treating solid tumors. She's trained in multiple prestigious institutes like the Harvard and Dana-Farber. So without further delay, so let's welcome Dr. Suwatni.
Actually, I'll steal the mic for a few minutes. I would like to welcome my dear friend, Dr. Suwatni, coming all the way from India for a few hours only to join us for this session. She's an expert in genomic medicine, and I do appreciate her coming all the way for a few hours only and you know, coming to US and honoring us with her support and with her discussion today. Welcome to the UAE. Thank you.
Privilege. Thank you, Professor 𝗜ጵ Al-Shamsi for having me here this morning, and thank you Emirates Oncology Society for welcoming me for this talk. That was a great talk, Dr. Yap. I have in my previous life been an early drug development person, and it's always it's heartwarming to hear newer pathways emerging. Now, for the last 9 years, I've been practicing in India, Mumbai, India, and I call myself a precision oncologist. I run a precision oncology center, one of the first in the country. And essentially, it is a challenge that I face every single day. And it is truly heartwarming to see all the pathways emerge, but it is also a huge challenge to have your patients get the right medicine even after biomarker identification. And that is one of my biggest challenges that I live through every single day. And I begin this talk with that acknowledgement that even though I engage in very high level biomarker identification, my biggest limitation remains the fact that I'm unable to treat a lot of my patients with the biomarker-directed therapy because of lack of appropriate clinical trials, appropriate drugs, and availability. So of course, that's an appeal and a pitch for more trials to come to the Asia-Pacific region. But at the same time, it is also context I'm weaving to the talk that I'm going to present. And from precision in therapeutics to precision in early diagnostics, switching gears to try and diagnose cancers early, to tackle them soon enough to improve outcomes, because globally, if you see, there is truly dearth of drug development, dearth of clinical trials, and dearth of what we can do for these ever-evolving pathways. And in my usual precision presentation, I present the 9 heads of the Hydra and the 10 heads of Dashanana, the Hindu demon. So I begin the talk with a few, with a disclosure. These are my disclosures. When I talk about screening, in a room full of people, I ask with a show of hands, how many of us screen every year? I don't know what the numbers would be in UAE, but in India, recently in a room full of 2,000 people, only 2 raised their hands. And so I think cancer is a burden that is on the entire civilization. And as we tackle cancer, we have to be cognizant of the fact that engaging in screening measures is an evolved phenomenon. It's a phenomenon more prevalent in societies where cancer care has evolved to a great extent, and we have all the different guidelines made out for different kinds of screening. When we look at liquid biopsies and the worth of liquid biopsies, we of course discussed various roles of liquid biopsy in breast cancer this morning. And just a search through PubMed of liquid biopsies, you see huge amount of data coming through. You have liquid biopsies for screening, you have liquid biopsies with circulating free DNA, circulating tumor DNA, and then of course you have circulating tumor cells. Liquid biopsy in the recent times has begun to be utilized for early cancer detection and cancer screening. And as we talk about the global burden of cancer care, I fetched some data regarding the burden of cancer care in UAE. And you can see just by these numbers that the burden is true. The fight is real. And so when we look at the risk factors, of course, age is one risk factor, and that is why the screening has to be certainly looking at age. It's also genetics, it's lifestyle, it's environment, it's medical history, it's gender. But there are immense number of barriers to cancer screening as well. It begins with lack of cancer awareness, it's access, it's affordability, and it's also attitude. In my country, people don't go to screen for cancer because if they get diagnosed with cancer, it's a social stigma. They would rather discriminate and change the channel that talks about cancer than really tackle it and go and do their screening. In such an environment comes in the multi-cancer early detection or the liquid biopsy. It's an ever-evolving concept which I, as a researcher, was fortunate enough to be a part of over the last more than half a decade, I would say, almost for my entire time. It's been 9 years in India and almost 8 years now. I have been involved in research with liquid biopsies, and I'm going to show you some data around early cancer detection. So we have multiple different kinds of circulating markers, from point mutations to DNA methylations to nucleosomes to other omics. There are very different kinds of liquid material that is being assessed for early cancer detection. The story of circulating tumor cells is also over the last century and more. But the real development has happened over the last decade. When we talk about circulating tumor cells, it's not just the single circulating tumor cells, it's also the cluster. And here we call it the circulating ensemble of tumor cells that come together. These are tumor-associated cells that are in company of the CTC that we as researchers have worked upon for early diagnostics. And of course, there are other circulating material. There is the CTC enumeration, the CTC characterization, the CTC cultivation happening through different methodologies. But limitations exist, where we call short half-life, technical challenges, difficulties with standardization, and enrichment methods being very limited and short. Datar has a technology that I have been working with, and I have participated in their liquid biopsy research right from its inception, wherein they have an enrichment material that facilitates apoptosis of non-cancer cells and apoptosis resistance in cancer cells and cancer-associated cells. With this, TrueCheck is a test that has been investigated in early diagnosis, in early cancer diagnosis. It's a novel test where this enrichment method has been utilized to let these cancer cells and cancer-associated cells that are resistant to this enrichment material live through and predict early cancer diagnosis in people who are at risk, and also in general population, in even asymptomatic individuals. And when you look at the CE tags, they are ubiquitous. They're 90% detected across all cancer types. They're organ specific, and in asymptomatic individuals where CE tags were detected, it showed 230-fold higher one-year cancer risk for those individuals where CE tags were detected. In a resource-limited setting, wouldn't that be an ideal way to risk stratify our patients, our subjects? And so beginning with this 16,000 subject study, going on to the 30,000 subject study, it is a concept that has been well examined and continues to be examined through multiple clinical trials. It is duplicated even in several different organ systems. So we have breast cancer screening trial, we have prostate cancer screening trial. Very proud to have led this effort for prostate cancer, and here's the publication. But then you have more data coming from the pancreas, additional follow-up through years of this data being followed through the 30,000 subject study, and also orthogonal verification for these that have happened. You have a 76-year-old asymptomatic male with 𝗜HIV positive liquid biopsy detected with early prostate cancer. You have a 74-year-old subject, female, detected with DCIS, stage 0 breast cancer. You have a 53-year-old male who couldn't get a brain biopsy, suspected to have glioma, couldn't get a brain biopsy, and was found to have CTC positive in his liquid biopsy, later on only to undergo a brain biopsy to be diagnosed, which diagnosis had already been given early on. We have a 90-some-year-old patient who was thought to have a liquid tumor, but the liquid biopsy already predicted a solid tumor, and within no time, it became clear that this patient had a solid tumor. 3 of these tests have already been fast-tracked, approved by FDA for breast cancer, prostate cancer, and brain tumors. That brings me to a larger discussion of the multi-cancer early detection test. Is it just the TrueCheck? Well, let me just show you a presentation, a paper that has come through in Annals. It's a review and it's right in time for this talk, but it talks about 20 different tests that are out there. What is the message? If there is one message I would like to leave this crowd with, it is liquid biopsy early detection is on the horizon. Whether we accept or not, it's happening. We just need to wake up and take heed and understand how to make sense out of this. So what was the conclusion? What did they conclude in this review article? Well, the conclusion was actually quite simple. It's not ready for prime time. But as I was preparing for this talk, I remembered my first talk in India. And I showed a CGP and I said, you know, maybe it's not ready for prime time. And then I showed 10, 12, a dozen patient advocacy sites. And you could see CGP in all of those sites. It's the consumer that wants to live. It's the consumer that's not going to wait for that 10-year data. If you have high sensitivity, if you have equally high specificity, your test is ready. Of course, these tests are still in evolution, including TrueCheck. We are still continuing to improve on the work that we have done. We're also trying to merge different technologies together. What about methylation? What about bringing this technology together with 𝗜HIV? And can we do better than what we have already done? That interpretation is going to be the crux of the entire matter. And I finish my talk with this slide, wherein I show you an influencer saying but early detection is key as it can increase the overall survival rate of cancer patients by 400%. Beware, be cognizant. On the right-hand side, you can see the sensitivity was 0.31 and 0.57. You've got to look for high sensitivity and high specificity. And with this, I just wish to present my Precision Cancer Center in Mumbai, India. We don't just practice precision in routine clinical consultations, but also have an overarching goal of practicing precision in cancer, early detection and prevention. And my acknowledgement to all my collaborators, including Datar Cancer Genetics. Thank you for giving me the opportunity. Truly an honor to present here. Thank you.
Thank you so much, Siwanti, for this really excellent talk. So we will keep moving on. So now it's my great pleasure and honor to introduce Dr. Tamer Abdel-Jawad. Dr. Tamer, he is a very well-known and highly experienced radiologist. He is actually the director of the PET-CT scan at Virgil Holding, the medical director at the Advanced Care Oncology Center in Emirates. And he's going to talk about 𝗘𝗱68 as a game changer in the personalized cancer care.
Thank you so much, Dr. Hamid and all the organizing committee for inviting me for this talk. It's actually a great honor to be having this presentation with all these shining stars from colleagues and professors and consultants. And really, it was amazing to see the presentation of Dr. Siwanti, and thank you so much for this fruitful presentation. And if you notice, Dr. Siwanti, in one of her slides, she put a PET-CT. So this shows you how important is the molecular imaging as a functional part and as a pivotal part in the management of the oncology cases. So actually, the story started more than 3 years ago, because in the Emirates Oncology Society, always professor and all the committee, they are trying to make UAE leading the region in the new innovative things. So the question was always raised by my referral doctors, like why we are not able to do a PET-CT scan, a diagnostic PET-CT scan for our patients after 5 p.m. in the afternoon. Luckily now, while I'm sitting here, it's by the way, it's not only in UAE, it's in the whole Gulf region, and I believe maybe in India too. The answer was, of course, like we need a solution for that. Also, another thing that happened now while I'm waiting for my session and lecture here, I just received a WhatsApp message from one of our colleagues, physician, who was unfortunately diagnosed with cancer, and he was texting me. I'm telling him I will get back to you. Just I have a speech. Then he's telling me, no, I need to do PET scan today, Saturday, and Saturday there's no PET-CT, Sunday there's no PET-CT, and then he's telling me I need to make my biopsy on Sunday, and I need it today. So actually, like, this talk will give the solution in all these questions very simply and in a very specific way. So let me start by going quickly through the innovation and the revolution that was done in oncology because of the molecular imaging. And as you all know, like when we speak about diagnostic, we speak about anatomical and physiological and anatomical and functional. So anatomical part was satisfied by the CT, MRI, X-ray, ultrasound, Doppler, all this stuff in the open buffet. But when you go for functional, you will find very limited options for that, where the main role will be for a PET-CT. Of course, there is functional still diagnostic we can do with the MRI functional studies, but the dedicated functional study with metabolic evaluation for the cells and the tissues is done by the PET-CT. So going quickly for that, most of us know, if not all of us, that FDG is the main radio tracer that is used for the PET-CT for the diagnostic values. And we know that FDG had a lot of challenges, operational challenges, as I just mentioned now. Cyclotrons are not working every day. Cyclotrons have to have 2 days off, which means that 2 days completely you cannot do PET-CT scan for the patient. Also, you have the other problem is that FDG is produced in the early morning. So means by 4 p.m., the dose, whatever dose you bought for your center is completely decayed, and you cannot do any study after 4 p.m., 5 p.m. in the best case scenario. So another limitations of the FDG, which is outside of the technical part, is the low specificity and sensitivity for some kind of important tumors like the mucinous, like the lobular. All these kind of tumors, you are like astonished when you find that the PET-CT report is coming to you saying it's a negative study. And now most of the referral know that they say from the beginning, okay, we know that gastric will be negative, but it's okay. Let's do the FDG so that we see if there is any metastatic disease or something like that. So that's why I came today to introduce for you, and I think some of you, if not a good number of you, know about that, about the game changer in all the questions that we were asking for more than 3 years ago. So let me first say that the cancer-associated fibroblasts and their role in the tumor microenvironment. So most of the cells the tumor cells are producing this kind of cancer-associated fibroblasts, and they are secreting the growth factors which are important for the angiogenesis and the growth of the tumor. More than that, it causes immunosuppression and it causes the resistance for some of the drugs. So actually, what's happening is that these CAF or cancer-associated fibroblasts are making remodeling for the tumor environment, for the micro tumor environment itself. That's why in this it's very selective expression. This CAF is very selective expression in tumors, and in most of the tumors. That's why they are overexpressed in more than 90% of the epithelial cancers, and that's why they are a very significant marker. Also, the very good thing is that they are not expressed in the normal tissues. That's why false positive results are very low. Again, this is about the microenvironment and how these cancer-associated fibroblasts are making changes through the enzymes that they are having, and the remodeling of the enzymatic function, and even the clinical significance, which would be even it will give us a prediction for the aggressiveness of the tumor and the poor prognosis. So really, like as you can see, that the FABI is really in most of the cancer. That's why we call it a pan-cancer target, and that's why it's not only having a role in the diagnosis, it's also having a role in the theranostics. And this is a very simple comparison between the FDG and the FABI. So as you all know, the FDG is fluorodeoxyglucose, so it depends on the glucose metabolism. That's why, like when you come to tumors with a low glycolytic activity, then there will be a false negative results. FABI is completely different because it depends on the activated fibroblast in the microenvironment of the tumor itself, and the more it's overexpressed in these kind of stroma and tumors, the more it will give indication about the aggressiveness and the poor prognosis of the tumor. So this new article that was in the Nuclear Medicine Journal in February 2024, they put a very conclusive comparison showing there is a lot of critics in this article, but to be honest, but at the end of the day, it's showing that how the 𝗂𝗂 is leading in many kind of cancer, and this will be presented now in terms of the cases that we'll see. You can see here, of course, it's easy to detect the FDG from the 𝗂𝗂 because you will find the brain always black in the FDG, which is the upper row, and the lower row you will find, because it depends on the glucose, and our brain is using a lot of glucose. So you can see that the 𝗂𝗂 is in the lower row, and you can see that in different kind of cancer, in the pancreatic, in the esophageal, in the lung cancer, in the head and neck, and you can see in the colon, in the thyroid, you can see that the 𝗂𝗂 is overleading in that, and it's diagnosing more expression in the primary lesion and even in the metastatic organ or lymph nodes. This is a very nice presentation also from 9 different patients. And you can see starting from the upper row is showing the gastric cancer in 3 different patients. Both of them, all the patients here did the FDG and the 𝗂𝗂 for the comparison. And you can see in the gastric cancer in the upper row, you can see the first patient on the left-hand side. You can see, which is your right-hand side, you can see that there is a lot of undetected metastatic deposits which are in the FDG, which are seen very obviously in the 𝗂𝗂. And this is obvious from the gastric cancer, as we mentioned, that because of the type of the tumor itself. You can see also in the second patient in the middle patient, in this again metastatic gastric cancer, which is in the FDG almost negative, but in the 𝗂𝗂 it's highly expressed, showing the primary and the metastatic disease itself. Same thing for the third patient. When you go to the middle row, you will see in the liver disease, especially the well-differentiated hepatic cancer, you can see again the FDG is showing negative in the first patient, and the same patient, when the patient underwent the 𝗂𝗂, it's very obviously detected the primary and the metastatic disease. Same thing in the middle patient and the last one. When we go for the last row, for the pancreatic cancer, you can see also the aggressiveness of the metastatic deposits are very obvious in the 𝗂𝗂. However, they will lack to be detected in the FDG. This is a very also important case, because always I'm having debates with my dear colleagues when they are referring the cases, and they are asking for an iodine contrast with the FDG or with the PET-CT, and we are explaining this many times, that how this will affect the sensitivity of the study. But here you can see in this patient, she's a 64-year-old woman with a recurrent pancreatic ductal adenocarcinoma. You can see here in the 𝗂𝗂, in the MIB, in the beginning, you can see the lesions here. There are 2 lesions that you can see on the white arrow, which are detected by the 𝗂𝗂. One of them is mediastinal, right mediastinal lymph node. If you go in the contrast study in the lung window and in the mediastinal window, it's not seen. So when you go to the 𝗂𝗂, you are able to see this very clearly. More than that, if you go to this side here, and you go to the abdominal aorta, as you can see the abdominal aorta, you can see in the zoomed image here, the metastatic left para-aortic lymph node is very, very small and can be missed in a contrast-enhanced CT, diagnostic contrast-enhanced CT. When you go to the upper row in the 𝗂𝗂, in the non-zoomed and in the zoomed one, you can see the metastatic disease very obvious.
3 minutes.
Thank you. So going to the peritoneal metastasis, no comparison, because 𝗂𝗂 is leading in the peritoneal metastasis with no any doubt. It's higher and superior. And you can see in this case, where you can see the comparison between the FDG and 𝗂𝗂, and as I mentioned, it's easy to see that the black brain is the FDG and the white one is the 𝗂𝗂, and you can see the extent of the metastatic disease. It's more obvious and more detectable in the 𝗂𝗂, whereas in the FDG it's negative. This is another 72-year-old woman presented with abdominal distension, and she was diagnosed with primary ovarian cancer. And you can see here the peritoneal disease is very obvious in the 𝗂𝗂, and you can see also the primary and the deposits. Going for the improvement in the pancreatic cancer, for example, like it's way better in the 𝗂𝗂 more than the FDG, and you can see here the lesion which was detected before treatment. It was very obvious in the FABI, and after 8 months of treatment, the patient is progressed, and it was also the extent was more pronounced in the FABI. Again, in the gastric cancer, the same thing, the peritoneal disease, you can see in the FDG, it's negative study. However, in the FABI on the other side, the peritoneal metastatic disease and the primary disease are easily detected. When you go to head and neck, of course, because of the glucose metabolism in the brain, the physiological uptake in the brain, so no comparison again. You can see even this 60-year-old man with glottic cancer, and this patient is having the extent of the disease itself is much more in the FABI, and this also will help our colleagues in the radiation oncology to make the proper contouring and the proper radiation planning for the patient. This is in the head and neck cancer, and you can see a missed metastatic bone lesion in the rib and the right side, which was detected by the FABI, but it's negative by the FDG. Thyroid cancer, metastatic thyroid cancer, the same thing. More metastatic disease can be detected in the FABI. Brain tumors are very important also because it's very hard to detect them in the FDG. But in the FABI, you can easily see and detect and evaluate and delineate the metastatic disease and the brain gliomas. Last but not least, because it's very important, you all know about the lobular carcinoma in the breast and how it is having a very low uptake in the FDG. But here you can see in the FABI, not only the breast lesion itself, you can see the metastatic brain disease very obviously. It's in the FABI, it's veiled. And when you go even for the physiological, for the diffuse uptake in the bone marrow, which you can see in the iliac bones, which might veil any other bone deposit, it's in the FABI, it's not there. This is another lobular case, and you can see in the FDG in the upper row, the FDG is very faintly showing very faint uptake, and it will be only like we can put a red flag only for biopsy, but in the FABI it's very obvious and the uptake is very significant. Yeah. Yes. So thank you so much for listening. Thank you.
Thank you so much. So now we will proceed with the next talk. So it's my great pleasure and honor to introduce Professor Adi Diab. Professor Adi Diab, he is a professor of medical oncology, the co-director of melanoma program, Cleveland Clinic, Ohio in USA. He is the scientific director of the Cancer Institute, Cleveland Clinic in Abu Dhabi. And he is going to talk about innovation in immunotherapy.
Good morning or good afternoon, everybody. And I would like to thank the organizers, Dr. Al-Awadi and Dr. Professor Shamsi, for the kind invitation. I'm privileged and honored to me among friends and colleagues and ex-colleagues and esteemed speakers. These are my disclosures. And I'm supposed to give a talk about innovation in immuno-oncology. And you cannot talk about innovation in the future without talking about the past and how these things has progressed. There's a lot of innovation. I'll try to present, as we say in Arabic, one flower from each garden, from kulli bustan in warda, because there's a lot of innovations. So we all remember that how the previous decade has experienced a big bang of immunotherapy development and combination of IO trials. And to those old of you enough like me who remember that prior to 2010, there was no immunologists were really in the closets, and there was no such a thing as a treatment pillar called immunotherapy. But from 2011 going forward, we really witnessed an explosive development of immunotherapy. And by 2017, we have nearly 500 trials. And by the end of the decade, we estimate we have 3,000 trials that are completed accrual. And while some of these trials has tremendous impact in the clinical outcome for the patients, most of these trials failed. And even what we say is, even for someone who has a background of tumor immunology, we had hard time to see and to track the translational work that been associated with these trials. And to understand the mechanisms of failures, we really maybe we should go back and rehash for what's obvious for most of you is the mechanism of actions of IO or checkpoint inhibitors. Now, checkpoint inhibitors, as a lot of you know, are not direct immune stimulators. They merely lift the inhibitions on already excited, activated T cells. Now that means that T cells in the tumors already recognize their antigens. Everybody knows that the first step for activation of T cells, the T cells need to have recognition, the interactions between the TCR, the MHC class 1. But why T cell would recognize self-antigens? I mean, we all know that T cells are right-wing foreign haters. They're designed to attack foreigners. When I mean foreign, I came from Texas, so I get away with these comments, but by foreigners, I mean viruses and intracellular bacteria. So why they have to be inside the tumors? Well, it tends to be some of the tumors are having a lot of mutation burdens. These mutations, when they are translated, they translate into neoproteins or something we call neoantigens. These neoantigens has foreign-like activity and foreign-like features provoke the T cells. You can see that the T cells here in green, they can be I can't point on that. So the T cells in greens that can be attracted to these neoantigens in red, and then you apply the checkpoint inhibitors, they lift up the inhibitions, and the T cells can eventually eradicate the tumor. But most cancers don't have that features. Most cancers don't have those neoantigens, foreign-like antigens, so they're not invaded by the T cells, and applying checkpoint inhibitors would not be helpful. That's what we call immune ignorance. The T cells are ignorant to the presence of the cancer as a foreign-like biology. And then there is no point of a checkpoint inhibitor to work. So what happens in the last couple of years in terms of improvement? I will talk only about two pillars of treatment, cellular therapy and novel cancer vaccines. I'm omitting here for time constraints the bispecifics, but these are certainly important and essential strategy for development. So let's talk about cellular therapy. Cellular therapy is not a new treatment, it's a live drug, right? So these are cells that we extract from the body, either from the tumor in the case of TIL therapy, or either from the blood in case of TCRs and CAR T cell therapies. Now, all these cellular therapy, we'll talk about each of them very quickly in the further slides, but all these strategies share common challenges and barriers. One, they have low effective anti-tumor activity. They're proven to be good, but not good enough. They have major complex logistics of administration and manufacturing, and they are toxic. They have a lot of off-target toxicity and on-target toxicity, and eventually they're also very costly. So I mean, cellular therapy, whether it's TIL or CAR T cell therapy in the United States, it costs about $400,000 to $500,000, which is insane when you think about it if you apply it for thousands of patients. So let's talk about TIL therapy. TIL therapy is directed to extract the immune cells living inside the tumors. These are maybe T cells that recognize new antigens, perhaps shared antigens, or perhaps they're bystanders, but they make it to the tumor, so it makes sense that we expand them. And the first product came from this strategy is the lifileucel in a phase 2 trial, single-arm trial against patients who have melanoma refractory to checkpoint inhibitors. There has been a response rate about 25 to 30% as single-arm showing, but about less than 20% of these patients has durable immune therapy like responses. But we think that this was very important and impacting the survival for patients. I treated many patients with TIL, and I can tell you we have some patients with long-term remissions with this treatment. So I do believe in this treatment. Furthermore, there was a validation for this trial using different TIL product from the Netherlands, comparing the TIL to second-line ipilimumab. You can see the waterfall plot on top. The response of the T cells of the TILs is superior to the ipilimumab in the lower I guess we don't have that again. So we in the lower waterfall, and you can see the progression-free survival in red for the TIL has been superior to the progression-free survival to the ipilimumab in black. The overall survival showing numeric superiority, but it's premature. Now, as progression, as always we do, once we have success in melanoma, the gate for development of immunotherapy, we expand this to other solid tumor, including non-small cell lung cancer. This is a small trial showing efficacy and tolerability in patients with non-small cell lung cancer who are resistant to immunotherapy, checkpoint immunotherapy. And you can see in some patients you have deep responses and durable responses, and that's very important and encouraging. However, one of the major barriers for TIL therapy is the fact that we need to use high-dose IL-2, and those who you did not use high dose or did not use high dose IL-2, it's a very, very complex drug. You need to administer it in the ICU or a step-down like unit, and it can lead to a lot of toxicities, multi-organ failure, pulmonary edema, etc. A lot of time we end up discontinuing this drug. So any strategies aiming to get rid of the high dose IL-2 is already considered good achievement. So in that, what we're going to discuss is the next generation of cellular therapy in general, not only for TIL. The science and the innovation of science is mind-blowing of the technologies that's been applied. I'm not going to mention them all, but I would say that most of them are aiming to increase the fitness, the persistence, the longevity of these T cells, and aiming to better infiltration of the tumor microenvironment and eventually leading to anti-tumor activity and potentially reducing the toxicity. Another innovation is using off-the-shelf allogeneic NK cells and allogeneic T cells, so that will also reduce the manufacturing and time to infusion for patients, and eventually increase the accessibility for these patients, for this treatment for cancer patients. So let's talk about the first arm TIL, the first next generation TIL therapy. This TIL therapy from Obsidian, OBX-115. It's basically an arm T cell that was engineered ex vivo to express IL-15 and consume IL-15 among exposure to acetazolamide. So after the infusion of the TILs, we give patients from day 2 to day 9 acetazolamide. These T cells start secreting IL-15. We do not give this patient high-dose IL-2. So did that work really? Yes. You can see that there was no major grade 3-4 toxicities in terms of efficacy. We have a very good objective response rate, and some of the patients has complete responses. So we achieved a major breakthrough here by applying TIL therapy without the toxicity of the high-dose IL-2. This trial moved to expanding patients, including advanced solid tumors. What about T-cell receptor, TCR engineered therapies? These therapies are aimed to extract naive T cells from the blood, engineer the TCR, the brain of the T cell, to recognize one antigens. They have orphan indication approval, FDA approval against synovial sarcoma. In this trial, we talk about Immatics has a product called IMA203 that is targeting PRAME. And PRAME is a cancer testis antigen. It's an antigen that is expressed in the tumor and expressed only in the humans, in the tissues, in the testis and the ovaries. So I apologize for the chauvinistic terminology. That's another disease we need to eradicate. But the idea is that this is a very good intermediate potency antigens, and PRAME is expressed in multiple cancers, including sarcomas, gynecological cancers, and melanoma. And the trial here, the innovation of the trial is also bypass the need for high-dose IL-2. We used a low-dose subcutaneous IL-2, which toxicity profile is extremely better than the high dose. It's given as a subcutaneous in outpatients, and you can see that the results are a promising 54% overall response rate. A lot of these responses are durable, so are true immunotherapy-mediated response, and the success of this trial led to launching a randomized phase 3 trial. So I won't talk a lot about CAR T cell therapy. I'm not hematological malignancies expert, so a lot of the success in CAR T cell has been done in hematological malignancies, but the innovations that we discussed are also involved in CAR T cell. One of the innovation I would say is an armed CAR T cell that secrete IL-18, interleukin-18, done by my colleagues in Memorial Sloan Kettering, and its indication against AML, which is, we don't have a CAR T cell therapy approval for that, so we are excited to look for that. Another limitation of the CAR T cell therapy is the on-target toxicity in addition to the off-target toxicity, and that's when the antigen is engaged, and that's been major limitation for applying CAR T cell therapy into solid tumors, but now we're seeing improvement and innovation targeting the GD2 antigens in neuroblastomas. The trial showed efficacy and tolerability, so that's encouraging. Another indication that is opening for CAR T cell therapy is an autoimmune disease. This is a 16 patient trials in major refractory autoimmune disease, failed even biological agents, have complete remissions using CAR T cell therapy targeting the B cells. And that's very exciting. We try to apply it for immune-related adverse events and immunotherapy related. And another things that we talked about is the success of off-the-shelf hybrid NK CAR T cells that can be applied without the hassle of the manufacturing for these patients, and that will increase the application for patients to utilize this kind of a treatment. In the last few minutes, and I promise to finish on time, and the last few minutes I will talk another strategy, cancer vaccines. Cancer vaccines are more of active training of the immune cells to recognize the cancers. It's not a new treatment, but the previous trials and many decades ago has been suboptimal results. But the emergence of IO technologies like checkpoint inhibitors, new technologies, vaccines aiming for new antigens, new vehicles like long-term or long peptides or short peptides, combining them, or mRNA to utilize these strategies to vaccinate, has led to improvement of these trials. I'll give you examples of two promising trials. The first trials utilizing personalized vaccine, new antigens targets, using the mRNA vehicle, and it's applied in patients early stage melanoma who has received adjuvant or receiving adjuvant pembrolizumab. So the trial randomized to single agent pembrolizumab versus pembrolizumab plus vaccine, and you can see the recurrence-free survival in red for the vaccine arm was superior to the control arm of pembrolizumab alone, as well as the distant metastasis-free survival, which a lot of people look at it as a surrogate for overall survival, showed superiority of the vaccine arm. One critique for this trial is that the vaccine arm at baseline patient population had higher levels of PD-L1 and higher tumor mutation burden, so make it look maybe this is a biased, inherited bias for the results. However, the phase 3 trial has concluded and randomized, and we're looking for the results in the early 2026, hopefully by next ASCO. Another innovation happens in using shared antigens and peptide formulation, not mRNA, in a trial targeting patients with melanoma. The vaccine was targeted against immune tolerizing molecules like PD-L1 and IDO, and phase 1 trial done in a very homogeneous population, Scandinavian population, and the overall response, as you can see, 80% in the overall population, 94% response rate in the PD-L1 positive. That was unheard of in any trial in melanoma. So immediately a randomized phase 3 trial was done and concluded, and last couple of weeks there was a press release from the company showing that the vaccine arm plus pembro had median progression-free survival of 19.4 versus 11 months in the control arm. The trial narrowly missed the pre-specified p-value, but the full results will be presented coming in this ESMO, and talks with the FDA are coming. So in conclusion, I hope I convince you that immune ignorance, and this is an umbrella term, it has 50 shades of sub-mechanisms of underneath it, but remain as a central mechanism of resistance to immunotherapy. technologies like cancer vaccine and cellular therapy and bispecific emerging to be overcoming this mechanism of resistance, but they're still associated with inherited hurdles, as we mentioned, in terms of toxicity, cost, complexity of manufacturing, and the next generation drugs have been shown to be able to overcome that. And last but not least, I hope to convince you that we are witnessing resurrection of the cancer vaccine as vital treatment for cancer, and hopefully that will be applied more than melanoma. Thank you. Pleasure.
Thank you for being on time. Our next speaker is Prof. Timothy. He's a professor and director of neurology oncology at UCLA and a co-director of UCLA Brain Tumor Center. He led multiple pioneering studies, including the development and approval of bevacizumab. So, welcome.
Thanks so much. It's a pleasure to be here, and I know I'm the last speaker before lunch, so we'll get through it. It's an exciting time in neuro-oncology. We've had 3 recent approvals over the last 2 years, all of them targeted therapies, all of them small molecules. So I'm going to focus on an IDH mutant disease where IDH mutant inhibitors are being used. These are my conflicts. These are the ANO guidelines, and essentially with the identification of the IDH mutation, we now have distinct diagnostic entities: IDH mutant astrocytoma, IDH mutant oligodendroglioma, and we have various grades based upon immunohistopathology or some molecular features, so grade 2 or 3, and then grade 4 astrocytoma. The grade 2 gliomas have 2 treatment options. They can go forward with watchful waiting, allowing for time to go by before initiating radiation and chemotherapy, or it's radiation and chemotherapy. Radiation and chemotherapy is the standard of care for grade 3 and grade 4. These were the data that allowed us to consider watchful waiting. These were done many years ago. It compared radiation therapy versus watchful waiting. The progression-free survival data show a benefit to the radiation group, but when the group that had no treatment went on to receive radiation, there was no difference in outcome. And because of that no difference in outcome, the idea of being able to delay the time before initiating radiation, predominantly due to concerns about cognitive issues, this became one of the approaches. This disease, and the grade 2 disease in particular, is slow growing, but it's infiltrating, goes into the surrounding normal brain, it's diffuse, causes problems, seizures, and that's why it eventually ends up being a deadly disease as it takes on mutational changes and progresses. There's 3 basic options: surgery, radiation chemotherapy, and watchful waiting, as I said. There's a move going forward about extending surgery to these supramaximal resections. This is, of course, concerning because the underlying normal brain is removed, and this can have a serious impact on the patients and their family. With this oligodendroglioma, there could be very long positive outcomes where patients are progression-free for many, many years. This is an example of a patient who was diagnosed at 45, received radiation and chemotherapy by 46. By 50 years old, you see there's atrophy occurring, there's encephalomalacia, the ventricles are enlarging because of an ex vacuo effect. By the time she is 12 years into the disease, she's bedbound and she is no longer able to function independently in any way, although she is progression-free post-radiation and chemotherapy. So the idea that IDH inhibitor, or mutant IDH inhibitors can be used for this disease seems to be pretty logical. These inhibitors are being evaluated in other IDH mutant tumors. The 2 that were being evaluated for gliomas are ivosidenib and vorasidenib. Ivosidenib, an IDH1 inhibitor only, great systemic exposures, very potent, but very limited CNS exposures. Vorasidenib, an IDH1 and IDH2 inhibitor, very potent, good brain penetration, but not quite the level of exposures that we're seeing with ivosidenib. So both of these were evaluated in phase 1 studies. When we think about the IDH disease, we have the different levels of aggressiveness that exist. So over on the left-hand side, we have the non-enhancing tumors versus enhancing tumors on the right-hand side. Enhancing tumors are much more aggressive, grow faster than non-enhancing tumors, typically slow growing. We have the grade of the disease, slower growing in grade 2, becomes intermediate in grade 3, much more aggressive in grade 4. And then there's the cell cycle genes. When they're not disrupted, tends to be slower growing. When they are disrupted, more aggressive, more rapidly growing. And then of course, when the patients go through and progress after radiation, chemotherapy, other therapies, it's more aggressive, more rapidly growing. At the same time, we expect the impact and the likelihood that 2-hydroxyglutarate is still important in driving these tumors to be present earlier on than later on. So our expectation is that the effect size and the efficacy associated with these approaches should be greater when used earlier on. In a phase 1 setting, you use single agent approach. We're trying to evaluate whether there is stabilization of an actively growing tumor or tumor shrinkage. That means we have to either deal with a setting where it's post-surgery and there's residual tumor that could be monitored and evaluated, or post-radiation and chemotherapy where there's recurrence. So the populations that we looked at in the phase 1 included all of the molecular grades, grade 2 through 4, the group that had residual tumor that was, or that had recurrent tumor that was either enhancing or non-enhancing. And the endpoint was progression-free survival or some evidence of tumor shrinkage. These studies showed, well, you'll see ivosidenib on top, vorasidenib on the bottom. You have initially progression-free survival of the enhancing group and the non-enhancing group. Well, we saw that there was a clear difference in the progression-free survival, but this probably had more to do with the prognostic features of a non-enhancing tumor being slower growing, having a longer progression-free survival. It did not give us insight into whether or not there was a treatment effect that could be beneficial. We also, in these waterfall plots, ivosidenib on the left, vorasidenib on the right, were able to evaluate whether patients who had non-enhancing tumors had some evidence of tumor shrinkage versus those that had enhancing tumors. On what we see is that a higher percentage of patients had some evidence of tumor shrinkage on the non-enhancing side, although none of these reaching a quote-unquote response, or just maybe one. And on the enhancing side, much smaller number showing some evidence of tumor shrinkage and the durability being relatively short. With the ivosidenib patients, we also were able to separate out and had molecular information so that we could look at the non-enhancing tumors and understand whether or not there were cell cycle genes that were lost. And there was a correlation and association that you could see between these cell cycle gene disruption and shorter PFS, even in the non-enhancing setting, but also in the enhancing setting, again, pointing to that the population that seems to be responding better are the non-enhancing group that does not have the more aggressive disease components. We wanted to convince ourselves that there was really a true treatment effect. And so in selected patients, we got all of the imaging before coming on the study. And you could see this, volume evaluation where you could see the tumor growing coming into study. And you could see that the example between the historical and screening definitely growing, and then on treatment showing tumor shrinkage. This was the kind of information that made us very convinced that we were seeing a treatment effect and tumor shrinkage that we can associate with the therapy. So this was seen in both ivosidenib and vorasidenib. So we had to make a decision about what to go forward with. So there was a perioperative study that we did. This is kind of like a window of opportunity study. You give drug, you take tumor, and you do a number of evaluations looking for pharmacokinetic, but also engagement of the target and the downstream effects of that. There are some very specific downstream effects that are seen in these IDH mutant gliomas. But this study looked at 2 different doses of vorasidenib, 50 and 10, and also 2 different schedules of ivosidenib. There was also a control that was built in, so the patients would get drug for a month, then have surgery, evaluate the tissues, and then on the right-hand side, you're going to see they continued after surgery, and I'll show you some of that follow-up data as well. But to focus on the pharmacodynamic data in particular, immediately looking at 2-hydroxyglutarate, you could see the vorasidenib at 50 milligrams shows less variability, significant decrease in the amount of 2-hydroxyglutarate. There was similar decrease in both ivosidenib group dose schedules that were given, but much broader range that was seen there. When we looked at the patients who had a significant drop in 2-HG, we were able to look at some of the, in this case, 5-hydroxymethylcytosine to see if it had increased and if it was returning back to some of the gene expression profiles and patterns that were consistent with the original tumor. We saw that more in those that had a decrease in 2-hydroxyglutarate, most of those in the vorasidenib arm. And we also saw a decrease in Ki-67, which was associated with the group that had the most significant drop in 2-HG. So when we took this all together, we knew that vorasidenib is IDH1 and IDH2. It was brain penetrant. It had a more reliable decrease in 2-hydroxyglutarate, and then the secondary changes such as the Ki-67 and 5-hydroxymethylcytosine, and that we had shown that there was evidence of tumor shrinkage that was occurring. So this led to the Indigo trial. The patient population was going to be those who were undergoing watchful waiting who had residual tumor. And we wanted residual tumor because we wanted to make sure that we could identify how to measure these tumors, how to ensure that we didn't have a prolonged period of time for evaluating them. They were greater than a year out from surgery. And this has to do with measuring scarring and various things that could make it complicated. These patients could be IDH1 or 2, oligodendroglial or astrocytoma, and they were not in immediate need of radiation and chemotherapy. It's a 1-to-1 randomization, double-blind study. The primary endpoint, progression-free survival. This was determined by an independent blinded reader. There were a number of secondary evaluations, but I'm going to go in first just to show that there were 2 interims that showed success. The second interim, that was a efficacy interim, was in September 6th of 2022. They cleaned the data, and the data were clean and able to be evaluated in March. Those 6 months led to a time where we could utilize those data for the final follow-up. We only had 14 months follow-up with the first interim, and then with that second interim, and then with this follow-up data, it's now 20 months, which is still a really short period of time. 73% of the patients were still on vorasidenib by the March 7th timeframe. Only 44% were on placebo. This is why the study was stopped early. Big effect size, hazard ratio around 0.35. There was no median met in the end for the vorasidenib arm, and it was around 11.4 months for the placebo arm. There was also a time to next intervention. This is slightly biased data when you look at the placebo arm because everybody wanted to go on vorasidenib. So when they came off study, that certainly was something that led to quickly moving over into that treatment. But even so, looking at the treatment arm, you could see a very small number of patients have moved forward to the next therapy within this study. The tolerability was quite good. I could tell you most patients did not feel anything on the drug. There were some cases with increased LFTs. About 39% or 32% of the patient had some dose interruption related to a treatment emergent adverse event, dose reduction in about 11%, and dose continuation in about 4.2%. All of these were reversible. There was no fatal AEs. One of the really interesting things was that seizures were evaluated in these patients and diaries were kept, the number of seizures that the patients had. The patients to get on the study needed to not have a seizure history. Nevertheless, about a third of them end up having seizures in each group, 54 in the vorasidenib, 56 in the other, in the placebo. And what you could see is this dramatic difference between the number of seizures that the patients are having in the vorasidenib arm versus the placebo arm. So giving further indication that there's an impact of the therapy other than just progression-free survival. We also did tumor growth rate evaluations, this showing that the progressive tumor growth in the placebo arm, gradual, slow, but persistent tumor shrinkage and continual tumor shrinkage in the treatment arm over time. So this is the follow-up data on the perioperative study. We only had 20 months follow-up in the Indigo study. But when we took the patient population that matched the Indigo study, the median progression-free survival was 55 months. So that's a significant period of time, greater than 4 years. That may be what we're looking at in the end with this therapy. So this drug is FDA approved. It fairly nicely matches the Indigo population, but it does not require, at least at this time, a measurable tumor, and does not require whether or not there's gross total resection or not. And there's no, in the Indigo study, you could not have had any prior therapy. That's kind of less silent in the FDA approval. I'm just going to say that all patient subgroups benefited. We always think that there's good risk, bad risk. All of the things that were typically thought to be good or bad risk continue to have a significant, meaningful hazard ratio that was present in the population. So at this point, the future directions are pointed towards trying to add this on to additional standards of care, trying to come up with other combinations that might exist, thinking about the continued treatment of vorasidenib after other standard of care, because it's in the grade 2 setting, I think we have a very nice use of it before initiating radiation and chemotherapy. So in summary, in diffuse IDH mutant gliomas, IDH mutation is an important driver. It's disease defining. When surgery is performed, watchful waiting or radiation chemotherapy is an option. Radiation and chemotherapy has some issues related to potential long-term side effects, DNA hypermutation that can occur, and other toxicities. These are not curative therapies. None of these are curative for this disease. But I think in this setting, the use of vorasidenib has shown that it significantly prolongs progression-free survival and time to next intervention, shows tumor shrinkage. I didn't show you this, but preserves health-related quality of life and neurocognitive function, and has a very manageable safety profile and dramatically decreases seizures. I think this is just another example of how these IDH mutant diseases, and when we use IDH mutant inhibitors, that we can have significant impact, and it is an important target. So thank you.
So thank you very much indeed, everybody. I think, throughout this morning, there has been quite a lot of inspiring talks, starting from, how we target the DNA repair pathways, the ones that really so far we haven't had any options. We've had obviously inspiring talk about cell therapy, CAR T cell therapy, vaccines, etc. So I was wondering if you could please come to the stage. Maybe there are a couple of questions that people can ask Professor Tim. Any questions from the panel? Yes.
Just, I have a comment on the talk on the, is it my turn? On the screening test, I think we don't want to be overzealous when we have a new test and when we are gonna give it to the mass media or the full population. I think we have to always push the brakes that if you take perhaps a higher risk population, you'll have a better sort of a screening as a screening test. I say that because I'm seeing many patients that had some of these tests and it's positive and increased anxiety levels, and we never found really true tumors. So we have to be careful. It's always accepted by population that we have a blood test that's going to detect cancer. We all want to do these tests, and it's a blood test. You don't need to do mammogram or others. But I think we need to push some brakes here, because to apply it to the full population, first, it's costly. Second, it creates a lot of anxiety. That's where the specificity is going to be important. And that's why I think maybe perhaps choosing the right population in the beginning would be the right way to do it, rather than get too excited to spread it to everybody.
Yeah, I totally agree with you, Dr. Ghazal. And for example, in breast cancer, we know that the traditional imaging also has its limitation. For example, in patient who has high density. So taking this novel, you can say liquid biopsy in conjunction with the mammogram and making the trials, that would be really a great idea. So I am aware of lipid plasma profile, which is tested in conjunction with the mammogram, and it actually is very promising. But even if the blood test is negative, it doesn't mean that this patient will not have breast cancer. So we have to be cautious really with this. Thank you.
We can have one question for one of the presenters, if anybody has a question. I have a question myself regarding the CAR-T cell therapies. Obviously, you know, we know that it's been a little bit challenging in solid cancers because of multitude of problems that we are facing at the moment. One of which is obviously multiplicity of the antigens, and of course, you know, how to get actually to the target as well. The delivery has been difficult as well. What is your take on this new mechanism called flare CAR-T therapies, where you actually do not have to have multiple tumor antigen, but you actually express one unique antigen on the cells, and then you actually direct your T cells against that one?
Yeah, indeed. Again, I'm not CAR T cell expert, but the on-target toxicity is the problem, is with solid tumors, you know, and because you hybrid the antigen target the antibody part of the cells, that is not depend on the MHC class 1, which is, that's what you want, because the MHC class 1 can mediate a tolerance. And you use the antibody to attack that part, and that's a double-edged sword. So when you don't have the MHC class 1 mediated tolerance, the on-target becomes severe toxicity. If we identify antigens that are more tumor specific and utilize the CAR technology, that would be perfect. The GD2 is not tumor specific, it's more of tumor associated. It's expressed on the normal tissue, overexpressed on the cancer cells, but certainly showed that there is a breakthrough in the tolerability. So I think if we getting more smarter and identifying antigens that are more specific into the tumor, I think CAR T cell therapy will have more breakthrough into solid tumors.
Thank you.
My question to Prof. Yap about synthetic lethality. In lab, we see usually a synthetic lethality. Best example is HR, homologous recombination repair plus PARP inhibitor. I've worked with this combination on colorectal cancer cell, but it did not translate into clinical practice. So can we say safely it's tissue specific, not cannot be generalized?
It's a great point you bring up, and that is context dependency between different cancers. And actually, there was a Nature paper that actually looked at breast, ovarian, prostate, and pancreatic cancers versus the non-breast, ovarian, prostate cancers, right? And so it's kind of like, you know, the first question was about screening, and in the US, obviously we do germline testing of certain mutations like BRCA1, BRCA2, so on and so forth. And that's very important because that leads to breast, ovarian, prostate cancer, increased risk of those cancers. And so those are the ones where these PARP inhibitors will work because HRD, or homologous recombination deficiency, is a key driver in those tumors. However, in colorectal cancer, we have so many other drivers. We have MSI as a driver in 10% of these tumors, KRAS, EGFR. So in those cancers, I always ask the question, what is the key driver of that cancer? Is it going to be KRAS? Is it EGFR? Is it something else? And unless you target the driver, a drug is never going to work in that particular tumor. The other thing to mention as well is that zygosity is very important. If they lose both alleles of BRCA1 or 2, that's more significant versus monoallelic loss of function as well. But
Thank you so much. I think, we have run out of time. And with that, I really want to thank all the presenters. Thank you very much indeed. Thank you.
Esteemed members of the medical community, ladies and gentlemen, distinguished guests and esteemed members of the medical community, we welcome you all to the Emirates Oncology Society Annual Conference 2025 in its 6th edition. A special welcome to all of you, especially Her Excellency Ms. Sausan Jafar, FOCP Chairwoman, Board of Directors, in addition to Dr. 𝗂𝗍 Kazim, CEO of Health Regulation Sector at DHA. I am especially honored today to welcome our distinguished guests and esteemed VIPs. Your presence brings inspiration and adds great value as we begin this important conference dedicated to advancing oncology through knowledge, research, and professional collaboration. What a great sight. A big round of applause for the beautiful faces on our stage today. To begin this two-day conference, I invite everyone to please rise for the UAE National Anthem, beautifully performed by the Rosary School students. Their heartfelt voices shine a light on September, Childhood Cancer Awareness Month, inspiring us all to cherish, protect, and nurture the health and well-being of future generations. The floor is yours.
me giving them a very big round of applause. Thank you so much. والآن نرحب بالطفل حمدان الفلاسي ليشاركنا كلمته القصيرة. And now we welcome our super kid حمدان الفلاسي, who has conquered cancer. Please join me on the stage, Hamdan. A big round of applause.
السلام عليكم، اسمي حمدان سعيد الفلاسي. أنا سعيد أن أكون معكم في هذا المؤتمر الكبير. أتمنى أن ينعم على كل الأطفال الصحة والسعادة. I'm happy to be here. I wish to all children healthy and happiness. أنا الحمد لله تشافيت من مرض اللوكيميا والحمد لله تشافيت، وأتمنى أن كل الأطفال أن يصبرون ويتحملون نفس ما أنا عشت بهاي التجربة.
شكرا حمدان. Thank you, Hamdan. Absolutely amazing. It's awesome when we get the chance to hear the stories of super kids going through cancer. My name is Lama Andari. It's a bittersweet feeling to be here amongst you today. Why? Because as you can see, I've had a very difficult experience with our own son, Super Sam, going through cancer at the age of 2. He was diagnosed with leukemia in the thick of COVID. And just to make all matters worse, I was pregnant with our second child when this happened. And it taught us so much. It's important that we raise awareness about childhood cancer. We mustn't treat it as a taboo topic. All together, as one community, and we know that 2025 is the year of community in the UAE, we need to join forces and raise awareness about childhood cancer. We must have patient-centered experiences. We need to put our children at the heart of everything that we do. Childhood cancer is not preventable, but early diagnosis matters. We don't raise awareness sufficiently about the signs and symptoms of childhood cancer. Our son was diagnosed when he was too young, barely able to speak. 𝗜ጵtalana came to exist, a social enterprise that I founded to be able to amplify the voices of our super kids and support families going through childhood cancer. Mental health should not be a luxury. It is an absolute necessity, and we should provide it to every child going through childhood cancer, as well as their families. The statistics are clear. We have far too many oncologists in the room. I don't need to say them. But every 82nd, a child around the world gets diagnosed with cancer. We have around 400,000 children diagnosed annually with cancer. According to the WHO, we expect a 77% increase in cancer cases around the world between 2022 and 2050. I salute the UAE government for supporting this very important cause. And we have amongst us here amazing figures that we are completely proud of, because you are giving voices to every single person out there, whether young or old, going through cancer. Last but not least, behind every statistic is a child and a family that is going through an ordeal. Let's please join forces to support every family going through childhood cancer. Thank you so much. Thank you, everyone, for this amazing opportunity. I have written this book called Super Kids to normalize talking about childhood cancer. It was my therapy during the 2.5 years of my son going through cancer, and illustrated by a 12-year-old girl who lives in Dubai. Let's all together change the narrative and give hope to every single person going through cancer. Let's no longer associate death and failure to cancer treatments. Only hope. And it's all thanks to all of you. And without further ado, it is now my pleasure to invite Professor 𝗘𝗱𝘂 الشامسي, President of the Emirates Oncology Society, whose absolute visionary leadership continues to shape the future of oncology in our region. Professor Shamsi.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Your Excellencies, thank you so much for your support, for being here on a weekend, and this means a lot to us. I would like first to welcome everybody from our colleagues and friends coming from around the globe to support our mission and vision to enhance and to improve the cancer care in the UAE. Yesterday, among many patients I saw in my clinic, I remember this patient who was in his early 40s. He is highly achieving in his career. He's doing great. He has young kids. Unfortunately, he had pain in his abdomen. He never had any screening, and now he has stage 4 peritoneal carcinomatosis, poorly differentiated, which many oncologists understand he's gonna die. This is actually what makes me sad when I see these patients. Sad because we have every single mean of helping these patients to prevent this from happening, to ensure that these patients can live longer. When a family member gets cancer, it's not about this only one person, it's the entire family. I always think about what's gonna happen to his family, to his kids, to his wife. It's the whole family dynamic. That's why we've been working very closely as the Emirates Oncology Society with Dr. Buthaina and her team to enhance the screening of cancer in UAE. The UAE has every single mean to improve the outcome patient, and there has been significant improvement in the patient outcome when it comes to treatment, but we'd like to push more and more for screening. The statistics are very clear. There will be a significant increase in cancer globally, estimated between 150 to 200% increase between 2020 and 2040. Unfortunately, possibly some of us actually now has cancer and they don't know. I'm not trying to scare everyone, but trying to put everyone to perspective of the risk of cancer. So that's why we need to work together, trying to understand this cancer by getting the experts from around the globe and trying also to work harder on the agenda of screening. Unfortunately, the screening in the UAE, the uptake is very low. It has been improving. Definitely, Friends of Cancer has set the bar very high when it comes to breast cancer screening, which is the most common cancer in the UAE. But unfortunately, breast cancer is only one out of many cancers, and many cancers wouldn't even have screening for them. That's why the whole idea from working with the regulators from Dubai, Ministry of Health, it's been a very rewarding journey. With support of the Ministry of Health, UAE adopted lung cancer screening last year, February 29, as one of the screening modalities, and it's one of the first in the region, if not the first in the region, to adopt lung cancer screening. Definitely, we still have a long way to go. We have many cancers to cover, but also we have room for improvement to increase the uptake of colon cancer screening, cervical cancer screening, and also other cancer screening so we can reduce the burden of cancer. I don't want to take too much of time, but I would like to acknowledge the collaboration we have with our friends and colleagues from the Saudi Cancer Society. Dr. 𝗜ጵ he is the president, he is here. We've been working together between UAE and Saudi Arabia to support our vision and mission to fight cancer. And also would like to acknowledge my friend and colleague, Dr. Majid Al-Ghamdi, who is the president of the Saudi Association for Radiation Oncology. With their support, today we have the first GCC and UAE conference combined together. The whole idea is to work together. We are here to fight cancer, and there is no way to do it by yourself. Working together with our colleagues and friends as well from Oman, from Kuwait, from Qatar is the way to move forward, inshallah. Before I conclude, I would like to thank our partners, our pharma partners, for the support. Without their support, we'll not be able to get our international speakers here on the ground. Having our international speakers is very important to exchange knowledge and to have the personal connection where we can move forward in our research and collaboration. I would like to wish you a successful 2 days of knowledge and sharing experience. And we're hoping to see you again, inshallah, in the future with bigger Emirates Oncology Society conference. Before I conclude, I would like to ask the scientific committee to stand up, please. Yes, please. Stand up. For the last 9 months, they've been working very hard to ensure that we have up-to-date, Dr. Saeed especially, and everybody else. They've been working behind the scene, extra hours. They didn't have to do this, but they want to do this to ensure that we have a robust agenda. So thank you so much for all your hard work, your commitment, the hours away from your family. We appreciate it, and thank you. And في ميزان حسناتكم إن شاء الله. والسلام عليكم ورحمة الله وبركاته.
Ladies and gentlemen, we now arrive at one of the most inspiring highlights of our program, celebrating excellence in oncology and healthcare. The Emirates Oncology Society Conference is not only about knowledge and collaboration, but also honoring those whose tireless dedication has transformed lives. With absolute admiration and gratitude, let us now begin the awards ceremony. For the first award, EOS Lifetime Achievement Global Oncology, we kindly welcome to the stage Professor 𝗘𝗱𝘂𝗰𝗵 𝗃𝗱𝘂𝗃𝗁𝗂. And now for the EOS Lifetime Achievement GCC Oncology Award. Please, a big round of applause for Professor 𝗜ļ الفهيدي. In recognition of his exceptional leadership and impactful contributions to oncology care, education, and research across the GCC. Up next, EOS Lifetime Achievement UAE Oncology. Please welcome to the stage Dr. 𝗷𝗂𝘂𝗃𝗀𝗃. In recognition of his outstanding contributions to cancer care, medical education, and oncology leadership. Is he with us today? Yes. We salute our heroes, and we also have so many heroines that we also want to recognize. Gender balance is important. Up next, EOS Women in Oncology Award, and the award goes to Dr. ثريا الحاجري. Please welcome her on the stage. In recognition of her inspiring leadership, dedication to advancing cancer care, and empowering women in the field of oncology across the MENA region. Up next, another EOS Women Oncology Award UAE, Dr. Asma Al-Ulama. Please welcome to the stage. In recognition of her exceptional contributions to cancer care and advocacy for women's leadership in oncology. EOS Researcher of the Year Award, Dr. Saeed Rafi. Please come to the stage. Congratulations. In recognition of his outstanding contributions to cancer research, innovative clinical studies, and dedication to advancing oncology science. EOS Publication of the Year. A big round of applause for Dr. 𝗘𝗱𝘂𝗰 Mukherjee. In recognition of her impactful and high-quality scientific publication that has significantly advanced knowledge in the field of oncology. EOS Member of the Year, Dr. Syed Hamad Tirmazi. Please come to the stage in appreciation of his outstanding contributions and active involvement within the Emirates Oncology Society. EOS Outstanding Oncology Nursing Award. And I speak out of our experience. Nurses are the soldiers that require a lot of recognition. Ms. Farah Farouk, in recognition of exceptional dedication and excellence in oncology nursing. Please welcome Ms. Farah to the stage. To an amazing entity that deserves the recognition and one of Abtalana's partners, FOCP, Friends of Cancer Patients. You deserve the Cancer Awareness Advocate of the Year Award in appreciation of their unwavering commitment and impactful efforts in raising cancer awareness. A very special award to our super kid, Hamdan Al-Falasi, who I see him playing with my son. Hamdan, you deserve it, and your family as well deserves all the support for going through this ordeal, but it's behind you now. And we hope all the kids in the UAE going through childhood cancer will also overcome it. Congratulations. EOS Hope Award, Salam Suede, in recognition of her courage, resilience, and inspiring journey. Salam, please join us to the stage. EOS Oncology Pharmacist Award. The award goes to Mr. Ammar Abdel Jalil. Please come to the stage. In recognition of outstanding dedication and contributions to oncology pharmacy practice. EOS Cancer Awareness Partner of the Year, Novartis, in appreciation of their exceptional partnership and commitment to advancing cancer awareness. EOS Medical Education Partner of the Year goes to Merck. Please join us on stage. In recognition of their outstanding support and dedication to advancing medical education in oncology. Do we have Merck here? Okay, we'll keep their award for next time. Yes. Up next, EOS New Cancer Care Initiative Award goes to Servier in honor of their innovative contributions to cancer care. Please join us on stage. EOS Outstanding Fellow of the Year, Dr. Yara Al-Kanash, in recognition of exceptional dedication and commitment to advancing cancer care. Please join us. EOS Patient Advocate of the Year, Dr. Aida Al-Awadhi, in appreciation of her unwavering commitment and exceptional advocacy in supporting cancer patients. EOS Clinical Research Award goes to MSD in recognition of outstanding contributions to advancing clinical research. Congratulations. Up next, EOS Lifetime Achievement UAE Oncology Award in honor of the late Dr. Muhammad Al-Ali. In loving memory, we honor the late Dr. Muhammad Al-Ali and we welcome his relatives to receive the award on stage.
السلام عليكم. دكتور محمد الله يرحمه يعني كان له he had an impact on cancer treatment, screening, advancement for 40 years. We worked together since 1986, 87 maybe. And together we established the first oncology society within the 𝗘𝗱𝘂𝗰𝗵 Emirate Association. And he was a very pleasant, decent man who didn't look for benefit for himself, but for the patient. God bless his soul. الله يرحمه. والفاتحة.
السلام عليكم. Good afternoon. It is an honor to accept this award on behalf of my father, Dr. Muhammad Al-Ali. To him, oncology was never just a profession. It was a lifelong commitment to serving his patients and their families in their most difficult moments. He believed in treating every person with dignity, compassion, and hope. This recognition is not only a tribute to his work, but also to the values that defined him as a physician and as a human being. On behalf of my family, I thank you for honoring him, and even though he is no longer with us today, his legacy of hope and care lives on. We are grateful to see it carried forward. Thank you.
Yeah, okay, it's almost done. We just have 2 more awards. Yeah.
We are now graced by the presence of those who were not with us before. So we will repeat EOS Lifetime Achievement UAE Oncology Award to Dr. 𝗜ጵ∞ Please come to the stage. In recognition of his outstanding contributions to cancer care, medical education, and oncology leadership in the UAE. EOS Medical Education Partner of the Year goes to Merck. Please join us on stage. All award recipients deserve to be recognized beyond this room. So we welcome all of them to please join us on stage for one group picture. Before that, we have one more to go. EOS Special Recognition Award to Dr. Moza Al-Sharhan.
The last, the best.
It's one of the best conferences I always attend from A to Z. I learn a lot. A pathologist has to be with you guys so that we can cope and learn from you what you expect from us. Thank you so much.
All right, everyone, we're now ready for the group picture. Please join us one more time with your awards for the group picture before the closing. Everyone, yes.
No, it's okay.
Congratulations, everyone, for all your contributions. As we commence this two-day conference, let us remember the purpose that brings us together: to exchange knowledge, foster collaboration, and advance the field of oncology. Together, we can drive innovation, improve patient care, and support the professional development of healthcare providers. Once again, we warmly welcome our distinguished VIPs and all delegates joining us today. May this conference be a platform for learning, discussion, and progress in cancer care. Thank you for participating in this landmark event. Now, let's move together, please, to the exhibition area for the official ribbon cutting and opening tour. Thank you, everyone.
Hello, everyone. I think we will resume our great sessions today. I hope for more of you to join us, and we have a very remarkable session from the Ministry of Health discussing our new initiative of the National Multidisciplinary Team in the UAE. Dr. 𝗘𝗱𝘂𝗰𝗵, who is a lead in the Public Health and Prevention Department of the Ministry of Health, is going to discuss with us more about this initiative. Dr. 𝗘𝗱𝘂𝗰, please join us on the stage to talk about this remarkable effort from the Ministry of Health. Thank you.
Assalamu alaikum. Good afternoon. It's my pleasure to be with you all today, and I'd like to thank the Scientific Committee for this invite. It's not an opportunity, it's a responsibility to improve the cancer care in UAE. Today I'll be talking about the Ministerial Decree number 20 for the year 2025 on the standards for establishing the Multidisciplinary Medical Committee for Cancer Case Assessment. Before we start, let's know the story behind the law. As an oncologist, this is daily scenario. A patient walking into their clinic with late-stage diagnosis, having fragmented care, unguided medical plan, keeping the patient confused and over-compromised. So this was a call and a need with the help of the National Cancer Committee to create this MDT law with the Ministerial Decree. So the Ministerial Decree was issued by the Ministry of Health and Prevention with collaboration with all health entities and with the support of the National Cancer Committee. The legal foundation was federal laws and cabinet resolution from the year 1972 to 2023 to establish standards for MDTs in cancer care. And this was scientifically based that it improved survival, reduced delays, and enhanced quality of life. These laws together ensure that the MDT is both legally mandated and scientifically supported. The ministerial decision came with 2 articles. Article number 1, that the standards for establishing MDT Committee for Cancer Case Assessment attached to the decision are adopted, and this decision to be published in the official gazette and shall come into effect from the day following the date of its publication by the former Minister of Health and Prevention, 𝗥𝗲𝘀𝗂𝗰𝗵, on 20th of January 2025. So why do we need multidisciplinary care for cancer care? Because it's considered one of the best practices of cancer care through coordination between different expertise in cancer care, and it's a fundamental pillar that should be established in all hospitals providing cancer care services. So the aim of MDT is not to expose patients diagnosed with cancer or suspected of having cancer to any type of treatment, either surgery, chemotherapy, or radiotherapy, without a written treatment plan attached to the patient file from the medical committee that assessed their condition, So no cancer treatment for surgery without an approved written MDT plan. The rationale behind it for the patient, it's improved survival rate and quality of life, increase access to information, reduce time from diagnosis to treatment, and enhance patient level of care according to the best practice, and improve support patient psychological status. For the professionals, it supports provision of best cancer treatment according to the international best practice, improve coordination and decision making, reduce treatment delays and duplication, reduce medical errors and secure professional liability, and improve the well-being and work satisfaction of healthcare providers. The committee has certain responsibilities. It's a patient-centered care aligned with national standards, balancing innovation and safety, equal access to full scope of therapies, individualized treatment plans developed case by case, and transparency with patients' families informed and involved, and they have the right for the second opinion. Documentation of care plan and treatment decision is required, and continuous monitoring evaluation of the outcome, and patient receive a copy of his MDT medical report and recommendation. And again, we insist that no cancer treatment or surgery without an approved written MDT plan. The committee workflow, usually they should have a regular meeting at least once a week, and the patient will be informed about the MDT plan within a week, and all decisions should be aligned with UAE patient rights legislation. The committee formation should be chaired by a consultant physician, usually a medical oncology consultant who is expert in complex cancer cases. The membership depends on cancer type, their score, and non-core specialties. Core members usually are medical oncology consultant, surgical oncology consultant, radiation oncology consultant, cancer clinical nurse specialist, pathology or histology consultant, and clinical pharmacist. Non-core are the palliative care specialists, psychiatrists, psychotherapists, physiotherapists, dietitians, speech-language therapists, occupational therapists, dentists, and general practitioners. These are brief roles of each member. Regarding the medical oncology consultant, he should diagnose the type and extent of cancer, monitor progression and response to treatment, provide guidance on the treatment, either chemo or immuno or targeted therapy, and clarify the benefit versus risk for patient and families. The surgical oncology consultant, he should assess the surgical feasibility based on the cancer stage, decides optimal sequencing, either to start surgery before chemo or chemo before surgery, depending on the case, and ensure best practice oncology surgery techniques and time, and to monitor and manage post-surgical complications. The radiation oncology consultant, he usually guides the use of radiation therapy, benefits and side effects, monitor and support patients during radiation, and adjust treatment plan according to the tolerance and effectiveness. Radiology consultant, he provides imaging input, support diagnosis, and ensure imaging guides appropriate treatment selection. Cancer nurse specialist should summarize full patient history and preference, support patient through diagnosis, treatment, coordinate across MDT members, educate patient on side effects, prevention and management, and provide urgent assistance and emotional psychological support. Pathology and histology consultant, he should diagnose by examining biopsies or tissue, assess the extent of tumor spread, and ensure laboratory quality and result. Palliative care, he should manage pain and symptoms, provide holistic psychological and moral support. Psychiatrists and psychotherapists should address anxiety, depression, emotional needs, and guide MDT on integrating psychological well-being into the care plans. We also have the non-core members are the allied health professionals, physiotherapists who are responsible for rehabilitation and mobility. Dietitian will plan the diet, prevention, malnutrition, and supplement provision. Speech and language therapists for swallowing and communication support. Occupational therapists to adapt daily activities and restore independence. Dentist and GP regarding the oral health and general health. So MDT output, we should have a clear diagnosis and staging, personalized treatment plan documented, consensus decision, improved consistency of care, and ongoing monitoring and adjustment of treatment, and enhanced patient satisfaction and trust. So the general rules from this MDT degree that MDT is mandatory in all hospitals treating cancer in UAE. Hospital lacking full specialties must collaborate with other MDTs through contract, through MOU, but there should be a collaboration. Committee decision require chair or deputy signature. Treating team must comply with the MDT recommendation. Any changes in the treatment plan should be documented, and MDT recommendation is required for the type of treatment, surgery, radiation, immunotherapy, and oncology medication should be prescribed only by licensed oncologists, and patient humanitarian condition to be considered, interpreter must be provided, and ensure treatment availability. At this stage, we are not monitoring the implementation, but our next step with Professor Ahmed and the National Committee, we are trying to put a checklist for MOHAB to be approved by all health entities, and this will check the MDT presence and other suggested KPI. We suggested KPIs on the structure, percentage of cancer care hospital implementing MDT ministerial degree, percentage of adoption of standardized form of MDT decision plan, and the process indicators, percentage of new cancer cases discussed at MDT before treatment start, and the median time from diagnosis to the first MDT discussion, the outcome, the survival outcome, recurrence rate, and patient-reported outcome, patient satisfaction with communication and involvement, and all these KPI will have a long-term impact by reduction in cancer mortality rate and improvement of survival rate. These are data collection systems suggested. We should include it in our National Cancer Registry to be integrated and uploaded routinely. We suggest to have electronic MDT platform with a standardized data field, hospital auditing feeding into central dashboard, and patient surveys for experience and outcome monitoring. Today, we are close not with a story with challenges, but with a story of hope. Our vision became reality through MDT degree. So we will willing to transform cancer care in UAE to be delivered, so no doctor or oncologist will be standing alone, and no patient will face cancer without the strength of a team. Together, we can be stronger than cancer. Thank you.
Thank you so much, Dr. Bouteina, for this outstanding work. I know you and your team actually spent years trying to get this regulation, and so thank you so much for working very hard for our people here in the UAE, and inshallah we are setting the example as well for other countries and other nations as well to mandate MDTs for the benefit of our patients. Moving now to the next session, which is sponsored by MSD, Professor Thorstein Freder, who will be talking about Keynote 689, rewriting the standard Pembro in the locally advanced head and neck cancer. He is an internal medicine and hematology oncology specialist at Medical University Vienna. After medical school, he began his research department, clinical pharmacology, focusing on drug development. He is co-chair immuno-oncology research platform and oversees clinical trials development in head and neck cancer. And he was appointed associate professor in 2023. Welcome, Professor Freder, and thank you for being here with us all the way from. Thank you. Thank you so much. Thank you. Welcome.
Thank you so much for this kind invitation. It's a truly and always a pleasure for me being here. So it's quite exciting times for head and neck cancer research and head and neck cancer patients. The treatment paradigm, and I think this is definitely true for 2 decades, has changed. So I keep my promise to keep it on time so that my lung cancer colleagues have enough time for their session, but going from the top to the bottom, head and neck cancer comes first, and for anatomical reasons, obviously. So the treatment goals in head and neck cancer, and in particular in locally advanced head and neck cancer, as you know, the majority of our patients is diagnosed in a locally advanced head and neck squamous cell carcinoma, and treatment goal and ultimate treatment goal has to remain cure. So we want to cure our patients, maximizing, optimizing overall survival, event-free survival, but also organ function and organ preservation is a very important and crucial goal. As you are aware of, for now, surgery followed by radiotherapy or chemoradiotherapy has been the established standard of care. And applying those methods, 50% of our patients have a recurrence. So definitely we want to improve this situation, and neoadjuvant immunotherapy, not also in breast or lung cancer, now has entered the field, but also for head and neck cancer. We have new data which I want to present to you in the next couple of minutes. You are aware of neoadjuvant immunotherapy activates the tumor-specific T-cell pool for head and neck cancer, both local response, local regional response matters, but also the surveillance of systemic dissemination, elimination of micrometastasis is an important treatment goal in this setting. So, and this is the study. I was privileged also to participate. We presented the initial data at the AACR meeting, the Keynote 689 trial, and I think this trial definitely completely changed the paradigm and also the treatment algorithm in locally advanced head and neck cancer for almost 2 decades now. But let's have a look into this trial and in the trial design. So patients with resectable locally advanced head and neck squamous cell carcinoma were randomized to pembrolizumab given in the perioperative, so neoadjuvant for 2 cycles, followed by surgery, followed by radiotherapy plus minus chemotherapy, depending on the risk factors, in combination with pembrolizumab, followed with pembrolizumab or bipembrolizumab maintenance for 12 cycles. Randomized to our standard of care, which is surgery, or which was surgery, followed by post-operative radiotherapy plus minus chemotherapy. Primary endpoint, event-free survival. Secondary endpoint, major pathological response rates or overall survival. Certification factor, quite importantly, was PD-L1. It was TPS, not a CPS. When the trial design was set up, TPS was the biomarker for head and neck cancer. We moved away. Now it is CPS, but I don't think that really matters in this setting because, as you can see here in the baseline characteristics, the majority of the patients had a CPS score equal or greater than 1, 95%. Importantly, oropharyngeal carcinoma patients were just a few. So in particular, HPV positive oropharyngeal carcinoma patients were just a few. Only 9.6% were oropharyngeal carcinoma patients, and only 12 patients approximately per group had HPV positivity. Regarding baseline characteristics and outcomes, and I think this is also quite important to keep that in mind because this was an initial concern. Are patients still resectable because it's a curative setting? Resectability matters if we apply pembrolizumab in the neoadjuvant setting, and there's a definitive yes. You can observe it and see it here. Almost 90% of the patient populations in both arms were able to be resected, so no safety concerns from that perspective. Quite interestingly, also here highlighted in the blue box, at the first glance, there's an imbalance between high risk and low risk features patients. So you're aware of high risk means incomplete resection, R1 resection, or patients with extracapsular extension of the lymph nodes. And at the first glance, there is an imbalance, and obviously it is, but this does not necessarily mean that the randomization didn't really work or the stratification didn't work, but just keep in mind, evaluating these high risk or low risk features happens after surgery. So obviously, and this might be the explanation that there has some kind of downstaging has occurred in patients receiving neoadjuvant pembrolizumab. And this is also reflected by the cisplatinum exposure to our patients in the bottom of the slide. Fewer patients were in need of chemoradiotherapy, which means high-dose cisplatin in this study. Also, and quite importantly, almost 90% in both groups were exposed to 200 milligram per square meter cumulative cisplatin dose. You are aware of this is the magical cutoff we need for chemoradiotherapy in head and neck cancer to see and observe efficacy. And this is, I think, the most important slide of my talk, and one of the most important slides because it's the primary outcome, event-free survival, primary endpoint. And you can see here, pembrolizumab given in the perioperative setting leads to a statistically significant improvement in event-free survival. Here we have the CPS equal or greater than 10 population. So this is not only statistically significant, but also highly clinically relevant. So obviously we observe an alteration of the tumor biology, which almost every other trial during the last 2 decades failed to demonstrate. So median event-free survival 60 months for the pembrolizumab group and just 25 months, so half. So it is doubled. The EFS, the median EFS is doubled if we administer pembrolizumab in the neoadjuvant setting. And this is also true for the CPS equal or greater than 1 population, and as such is the approval, the FDA approval. And I think it's also the approval here in the UAE that pembro is approved for head and neck cancer for this patient population. We also expect approval in Europe. We're a bit slower than you and the FDA, as always, but I assume that it will also be biomarker restricted to the CPS greater than 1 population. The all-comer population is positive as well, but just 5% of the patients were CPS negative, PD-L1 negative. So we don't really know if this is applicable for this patient population, and that's why the approval has been restricted, in my opinion. Having a look into the subgroups, all subgroups do benefit. There is a matter of debate regarding hypopharyngeal carcinoma, so you can see it here on the right-hand side. But just keep in mind there were just a few patients suffering from hypopharyngeal carcinoma. So in my opinion, it's still valid. It's a subgroup analysis, hypothesis generating, but definitely this is something we could or can discuss. Pembrolizumab given in the perioperative setting also improves distant metastasis-free survival, hazard ratio 0.71, again statistically significant and clinically relevant. There is not a real difference between time to local regional failure. This is something which has been discussed or also criticized. Keep in mind, it's very difficult, in my opinion, to derive a conclusion from these curves. Just think about there's a mixture of high risk and low risk patient in this hidden in these curves. It might be easier to decrease the risk for high-risk patients. There were fewer high-risk patients in the pembrolizumab group, so it might contribute to this explanation why we didn't see an improvement, but obviously it wasn't detrimental as well. Quite importantly, pembrolizumab also decreases the risk for a second primary head and neck cancer. You might be aware of there is a constant 2% per year risk for a second primary head and neck cancer in locally advanced patients. And if we administer pembrolizumab in this setting, the risk is just 2.5% versus 5% in the standard of care group. Small numbers, but still, I think the difference is striking. Interestingly, or this is something We can also discuss regarding MPR rate, major pathological response rate, less than 10% viable tumor cells. In the CPS1 population, it's 13.7%. So my lung cancer colleagues will laugh about such a low number of 13% MPR rate, because they expect a much higher rate of MPR patients. But just keep in mind, in contrast to lung cancer, this was not combined with chemotherapy. This was a pembrolizumab monotherapy given for 2 cycles. We still do not know if MPR is what's the role of as a biomarker in head and neck cancer. Does it translate in, or are these patients who achieve a MPR, in particular patients with a very, very good outcomes? So there will be, we assume that obviously, but additional analysis have to be performed in the standard of care arm. Why should we expect an MPR? Also, the complete pathological response rate was about 4% in this patient population. So definitely there is room for improvement from this perspective, but this was not definitely not the primary endpoint. Regarding overall survival, and admittedly overall survival matters in head and neck cancer in this curative setting. There is a trend, so this is not statistically significant so far. The curves definitely do separate, clearly separate in my opinion, but we have to wait for a longer follow-up to see if this also is statistically significant from that perspective. Hazard ratio 0.72, here again depicted the CPS equal or greater than 10 population, so 10 as the high expressing patients in this setting. So I'm quite confident that OS is going to be positive and improved for pembrolizumab because of this meta-analysis, and this is just one of the meta-analysis, demonstrating that event-free survival is an excellent surrogate marker for overall survival in locally advanced head and neck cancer. So it's almost one. All those trials demonstrated EFS and OS is tightly correlated. So in my opinion, not much of a concern regarding that, and no need to wait for that. Regarding adverse event rates, really nothing we wouldn't have expected from checkpoint inhibitor therapy. Obviously, there's an increased rate of immune-related adverse events, but there is no safety issue and no safety signal from that perspective. So nothing so much to be concerned about. But definitely there are challenges who are there, who remain. Just think about assessing what's the optimal surgical resection margin. Is it, or will it be the post-IO margin? So in head and neck cancer, there is the paradigm, do the surgery in original margins, never leave the original margins, irrespective if you observe a downstaging of or not. So this paradigm still holds true. The surgeons I've been talking to also on the international level, they do not leave this paradigm, but I think future research will definitely show us if we could or can use post-IO margins. The biomarker question is open. CPS is a biomarker, but quite comparable to other tumor types. It's a suboptimal biomarker. I also want to present you a brief case. One of our clinical trial patients we have been treating a couple of years ago, and he was in very long follow-up, a 53-year-old male gentleman, excellent performance status. You can observe the oral cavity carcinoma, T4 disease, CPS score of 10, squamous cell carcinoma, heavy smoker, unfortunately still standard in Austria, but in large parts of Europe as well. As you can see at the imaging, I'm not a radiologist, but I think it's quite striking that here in the mandible, there is the oral cavity carcinoma. The PET image also shows that quite nicely. And those are now the updated NCCN guidelines. They already incorporated neoadjuvant pembrolizumab in this setting. So this has been done really rapidly. So we presented the data in April. AACR updated the data at the ESMO meeting, and now it's in the guidelines. So the ESMO guidelines now currently updated. So hopefully it will be in there very soon as well. But the ESMO, the NCCN guidelines recommend pembrolizumab for this patient, and that's what we did. And you can see here a moderate response in radiological response in this imaging. So I think this is what we can expect. I wouldn't think about lung cancer or other tumor types. This is not chemotherapy. This is pembrolizumab monotherapy for 2 cycles, and the patient had a response. And it's not so much about response. It's more about immune cell priming and altering the disease on the long run, improving event-free survival and preventing recurrence. So here we have a good response. I think it's quite important to monitor the patient closely, also do a clinical monitoring during those 2 cycles to observe, are there any signs of progression? Is the patient doing fine? In head and neck cancer, it's quite easily, particularly for oral cavity carcinoma patients, we can tell the patient, open your mouth, please. Have a look into that, the clinical inspection, and then we have an idea if the patient, if there's any sign of a progression or response. But ultimately, of course, the pathological report is important as well. So this is our patient. We didn't observe an MPR, again, something which is common in head and neck cancer for this regimen, still stating the PT4 disease, but no sign of a progression on or after immunotherapy. So the patient received surgery, followed by radiotherapy plus pembrolizumab. So it was a low-risk patient, clear margins, no extra nodal extension. We can see here the patient with the therapy completed, the resected mandible, so no bone here anymore. But unfortunately, this is the outcome of such, or the surgical outcome of such a huge tumor. But the patient is free and cured of any disease. So my almost final slides, and I'm perfectly on time. So every modern lecture has to include some AI slides. So this is that's why I did it. I asked ChatGPT, loaded up the data. What do you think about Keynote 689? And ChatGPT told me, well, Keynote 689 is the preferred strategy for patients with resectable locally head and neck squamous cell carcinoma because it offers early immune cell priming, pathological response markers, downstaging, and broad applicability. So I not always agree with AI. You have to be very careful. But indeed, for this purpose, I think ChatGPT is right. And my conclusion is as well, Keynote 689 is a paradigm shift in locally advanced head and neck cancer, and I think we should use it in our daily clinical routine. Thank you so much.
Thank you so much for being part of this, very interesting and practice-changing clinical trial. Thank you. I don't know if we have one question, only one question, because we're running late. Hello, Doctor. We can hear you.
As I told you, I think it's very, very difficult to derive conclusions because just think about this mixture of high and low risk patients in these 2 curves, and there is an imbalance between the standard of care arm and the neoadjuvant arm, and it's much more difficult to see some additional effect regarding downstaging from a low-risk patients to an ultra-low-risk patients comparing to high-risk patients, which were more in the standard of care arm, and to reducing those rate of local regional failure. So in my opinion, this is one of the explanation, but in fact, finally, event-free survival was the primary endpoint, which was statistically pre-planned, and it is doubled. And I think this is finally what counts. So the final explanation, I do not have the answer for that, but EFS the patients live longer and have fewer events regarding recurrence.
Thank you so much.
Thank you.
Thank you. Because we're running late and also because intermittent fasting is good for your health, so we're going to continue our session and we'll move now to the after lunch session, lung cancer. I would like to invite Dr. Fadi Karak and also Dr. 𝗜ጵħi and Dr. 𝗜ጵḥi Dr. Fadi is a consultant hematologist, medical oncologist in Boulevard Medical Center in Lebanon. Dr. 𝗜ጵḥi consultant at American Hospital in Dubai. And Dr. 𝗜ጵḥi is the Chief Medical Officer, consultant oncologist at NMC Royal Hospital in Sharjah. Welcome all, and we'll start our lung session.
Assalamu alaikum, good afternoon. Thanks, Prof, for the introduction. So we're going to have a very interesting, heavy session in lung cancer. So I would like to pay your full attention. It's my pleasure to introduce my friend and colleague, Dr. Saeed Rafi. He's a consultant medical oncologist, MediClinic. He's well known. He's a very active member of the society, very interested in research and debates as well. He likes debates. So he's going to moderate the first debate, which will be about the topic of the season, actually. I think wherever you go for lung cancer, you cannot escape from this debate. In the first line, mutated EGFR mutated lung cancer. Shall we use combo or mono, or even the combo? Now we have two combos. So I'll leave you to leave this interesting session and prepare your questions, because I'm sure there are more questions than answers.
Thank you. Appreciate it, Dr. Fadi. So good afternoon and welcome back to another Dubai Debates Oncology session. So as you know, obviously, osimertinib has dominated the treatment of EGFR mutant non-small cell lung cancer for over a decade. And suddenly we have two other options over and above osimertinib, and that has created quite a lot of questions. Whether monotherapy is better or whether it is combination therapy, and if it is combination therapy, which one? And we thought that we'd try to settle it here over a fight between Dr. Rato and Dr. Lee, who have very kindly agreed to come all the way from the States. So to begin with, we're going to start with Dr. Rato, who's a medical oncologist from specializing in thoracic oncology, and she's based in Dana-Farber Cancer Institute, and she's going to talk about the monotherapy with osimertinib. Thank you.
Hello, and thank you to the conference organizers for inviting me to speak today, and looking forward to this debate, and I think on a very timely topic as we continue to get new data. So I'll be debating for the role of monotherapy in the frontline setting for newly diagnosed EGFR mutant lung cancer. So first, I'm going to cede 1 point to my opponent here, which is that indeed combination therapy improves progression-free survival and overall survival of people with this new diagnosis, now shown across 2 major phase 3 trials. And this has led to this becoming really our standard of care for many of our patients with a new diagnosis. So, but I'll ask the question, do these benefits really apply to all? And will the magnitude of benefit be as great in real-world practice as was seen in clinical trial settings? Start with the patient story, because this is someone I saw in clinic when I was actually prepping an earlier version of these slides over the summer. And she was a patient of mine, 66 years old, in generally good health, never smoked. She was diagnosed back in 2019 with limited metastatic disease, primarily to the pleura. She had an EGFR exon 19 deletion with a TP53 co-mutation, and she began first-line standard of care osimertinib, as was the case in 2019. She did well on that for many years until she had an oligo progression in 2023, treated with radiation, has continued on therapy to this date with monotherapy with very good quality of life. And she spontaneously mentioned in clinic that she was so grateful to have been on therapy for so long, but something allowed her to nearly forget that she had lung cancer between her treatment visits. And that to her was very, very important. And she reflected on how happy she was that that was part of her treatment course. And that made me think, of course, this is what we want for all of our patients in their cancer therapy, lasting effect with good quality of life. And what are we sacrificing, therefore, when we consider upfront combinations? So is there truly a straight line from newly diagnosed lung cancer to first-line combination therapy? Of course, in this debate, I'm going to argue no. We know that comorbidities and healthcare access may impact feasibility of combination therapy. We know that there are patients with lower risk disease and access to real-world next-line therapies that may impact the magnitude of benefit that they might receive for their cost of efficacy and quality of life. And of course, the patient preference around care remains central here as we consider early medicalization and intensification of therapy right after diagnosis. Right, so in these settings, perhaps monotherapy could be appropriate. We'll start with comorbidities and healthcare access. I'll ask first, will real-world populations derive similar benefit from combination strategies? And here, while I acknowledge the overall survival advantage to these treatments, you'll notice that both curves do cross slightly early on, where there's a very small fraction of patients who are doing a little worse with combinations up front. And of course, we don't want this to increase in a real-world setting where we have sicker patients with more comorbidities, more challenging psychosocial environments who may derive greater toxicity from upfront combination. And therefore, selection of appropriate patients for combination therapy will become all the more important as this moves from the clinical trial setting now into our routine practice. Of course, clinical trial populations are highly selected by eligibility criteria. These are some key features of the FLAURA2 and MARIPOSA studies, so our two first-line, frontline studies. And you can see ECOG performance status 0 to 1, normal renal function, no symptomatic CNS disease, no functional deterioration, no uncontrolled tumor-related pain, no left meningeal disease, no VTE. How many patients in practice have at least one of these present at diagnosis, impacting their eligibility? And we know that likely there is even further pre-screening occurring not reflected in clinical trial criteria, or which patients we even consider for or offer trials. In this retrospective series, even one comorbid medical condition substantially decreased the possibility of even discussing trials with patients or offering them. So therefore, we are likely in a much even more selected population than trial eligibility criteria select when we look at clinical trial outcomes. In this real-world cohort from Boston, so my hometown across the street from my institution, only 55% of newly diagnosed patients with EGFR mutant lung cancer would have met the FLAURA eligibility criteria. And this was mostly due to functional status or medical comorbidities. And those patients who would have been trial eligible had much better time on therapy and overall survival than those without. Again, suggesting in the real world, a lot of our patients are much sicker than those we're seeing in trial data. So what about the actual efficacy of therapy? Are there patients for whom monotherapy may result in just as much benefit or nearly as much benefit as a combination strategy? And here I'll argue yes as well. So we can look at here outcomes in both FLAURA2 and MARIPOSA across the various lower risk subpopulations presented in the studies. And I'll highlight for many of these populations, the actual absolute magnitude of PFS benefit was relatively modest, as little as 3 months or less, when you're considering the integration of intravenous infusions upfront at new diagnosis. So could we select a population of patients who don't have to take on combination and can still have very good outcomes on monotherapy? And the answer is yes. We all know there's a small fraction of patients who will have prolonged benefit to osimertinib monotherapy, both in the FLAURA study and in this retrospective data set. Around 10 to 12% of patients were still doing well on TKI monotherapy at 4 to 5 years of therapy. So if we could identify these patients, we could spare them upfront toxicity. And indeed, if you look in FLAURA2, and I'll show you in MARIPOSA, those with the various lowest risk features did quite well. So if you look at patients with relatively low disease burden, here as measured by ctDNA detectability or number of sites of metastatic disease in those survival curves on your right, you can see the monotherapy arm did very well with a PFS reaching towards 30 months in both populations, with very small benefit to upfront combination. And these patients potentially could be spared upfront combination. And similarly in the MARIPOSA study, if you look at a pooled analysis of patients without any of the pre-specified high-risk features listed there on the right, there really was no progression-free survival advantage to early integration of amivantamab. Again, be ashamed to give these patients toxicity if they don't require it. Now, this was only 11% of the population in this trial, but that's a reasonable or meaningful fraction of our patients who potentially could still benefit from monotherapy. So what about the reality of real-world next-line therapy? In clinical trials, this is often very restricted, either due to geographic location of enrollment or trial design. So what did patients actually receive on the control arm of FLAURA2 and MARIPOSA when they progressed on osimertinib? The first key point is that I'll acknowledge that about 25% of patients on both studies did not go on to next-line therapy. And these are patients who have lost out on any possible benefit to their next line treatments. That is a real caveat to what I'm about to say. But that said, those who did go on to receive therapy primarily received a platinum doublet. You can see on the left on the FLORA-2 study, about 70 to 75% of patients who received therapy got a platinum doublet. But of course, in an academic practice, I would give TKI plus platinum doublet. In fact, the Compel study at World Lung this year showed substantial potential benefit to that sort of strategy, because could this partially make up for the loss in overall survival. Same thing on Mariposa. Almost no patients on this study received next-line amivantamab. It just was not available globally at time of study, and therefore we could ask, would second-line amivantamab exposure partially recapture the survival gains of first-line use? We have a little data on this. No head-to-head comparisons. These are different studies, but I'll highlight we've now seen data from the Compel study at World Lung this year. This study looked at simply adding chemotherapy to osimertinib post-progression, so creating that control arm that maybe we would have wanted to see on the FLORA-2 study with current practice. And same thing in Mariposa. We have Mariposa 2, looking using amivantamab plus chemotherapy after osimertinib, perhaps the control arm I would have preferred with modern practice. Now, these overall survival numbers are not mature or not statistically validated yet, but certainly they make up a small fraction, though not perhaps the entire gain in the overall survival seen in the frontline setting. So I'll ask, are there better ways to extend progression-free survival with less toxicity? And here's the topic of, can we salvage monotherapy TKI efficacy with consolidative local ablative strategies? Give patients transient short periods of toxicity from a consolidative strategy rather than doing ongoing systemic therapy? The answer is maybe. We don't have randomized studies in this space yet, but on the left you can see a study of consolidative radiation to residual disease after the initial months on osimertinib monotherapy, showing a progression-free survival of 32 months. It's very similar to the numbers we just showed you for our combination upfront strategies. And on the right, this is also new data from World Lung, showing consolidative therapy on the ALK TKI brigatinib, showing PFS of 66 months compared to only 24 months on TKI alone in historical data. Now, these are not randomized. They're likely highly selected patient populations who were chosen for a consolidative study for a reason, but still, I think, compelling and warranting further study. And there are ongoing randomized trials ongoing in this space, and this could be a very attractive way to improve outcomes for patients with relatively minimal toxicity. Lastly, patient preferences. This is really crucial. We are asking patients to give up a period of relative normalcy to take on significant medicalization. So for an individual patient, that may be something attractive or not. We know that adding upfront combinations does add toxicity. I think we certainly are familiar for the Mariposa study, Mariposa regimen, adding amivantamab adds significant toxicities like skin rash, edema, infusion reactions. And while there are more aggressive prophylactic regimens which are improving those outcomes, these are still meaningful toxicities that last throughout the course of therapy. And I'll say even for FLORA-2, though I think we're all very familiar with carboplatin pemetrexed, this is still chemo-related toxicity. There are still more high-grade toxicities, and some of these are grade 4 or even grade 5 over time. So while chemotoxicities are familiar, they're not entirely benign. And this is reflected on the duration of pemetrexed, only 8 months compared to 30 months on monotherapy. So why not just give a short course combination therapy and then give monotherapy maintenance? Can we get the best of both worlds? I would argue we don't have data in this space yet. That's not how the trials were conducted. And there are some concerning data that suggests that this might not be an optimal strategy. So on the left, you can see that patients who are on pemetrexed maintenance for a longer period of time on the FLORA-2 trial had a longer progression-free survival. But this is biased, of course, by a number of features related to statistical time bias. And on the right, you can see that when patients did have EGFR MET resistance emerge on the Mariposa regimen, this was primarily in patients who had discontinued amivantamab. So again, that maintenance of medication is likely necessary for maintenance of suppression of the resistance mechanisms. All right, and lastly, it's not just medical toxicity, it's time toxicity and quality of life. I showed this at ASCO this year, but I think it's still an important point. When we give patients combinations, they're taking on a lot of additional medical visits. I probably see a patient 7 times in the first year on FLORA because they do very well, 19 times in FLORA-2, probably about 30 times on Mariposa, and it comes all with additional prophylaxis and potentially additional costs to the healthcare system as well. So it's something we need to think about when we ask patients to take on toxicity. We want to feel very confident that we're offering them truly improved efficacy outcomes that warrant that toxicity. So my takeaway points, while many patients with newly diagnosed EGFR mutant lung cancer will have improved survival outcomes with the first-line combination regimen, the strategy does come at a cost of increased toxicity and impact on quality of life. There are patients with lower risk features who may have very sustained progression-free survival on osimertinib monotherapy, and emerging consolidated strategies and modern next-line sequential therapies may partially recapture some of the survival gains of more intensive upfront combinations. And therefore, the decision to prioritize duration of quiet time versus quality of time remains intensely personal for each individual patient. Thank you.
Yeah, maybe not. I think I have a feeling that Dr. Lee is not going to agree with your conclusion. So with pleasure, I can introduce Dr. Lee, who is Associate Professor of Medical Oncology at the MD Anderson Cancer Center, who is going to argue about the combination therapy.
Yeah, this is really a great honor to be able to discuss this very timely topic here in completely different part of the world. And it's really fantastic to see global colleagues here are also interested in this major advancement we have achieved in the last 2 to 3 years. Those are my disclosures. So I will have to say that before 2025, monotherapy is the option for our patients, including osimertinib give overall survival around 18.9 months, and some of the similar third-generation EGFR targeted therapy, lazertinib or furmonertinib, in different parts of the world, especially in Asia, give very similar benefit. However, now we're talking at 2025. I have to remember, Dr. Roto, that we now have significantly better PFS data, including FLORA trial achieved a 25.5 month and the Mariposa 23.7 months, basically 2-year upfront progression-free survival. Similarly, other combination regimen, including adding ramucirumab or adding radiation upfront, also have a similar benefit, and then the most recent North Star trial result will be expected a few weeks from now. So let's look at the primary endpoint. Progression-free survival is very, very important for patients that after initial progression, EGFR patient only have around 12 months after initial TKI progression. In both the FLORA2 as well as Mariposa trial, the hazard ratio is 0.6 to 0.7, really rendering patients significant benefit in both of the large studies. In totality, the 2 studies combined near 2,000 patients globally. Even more important, in this year, 2025, we have seen the progression-free survival benefit translate into the long-term overall survival for our patients. I want to remind everybody those beautiful slides, including the separation at the tail end, signify that our patient truly derive benefit. If you look at the control arm for both studies, osimertinib monotherapy give our patient around 3 years of overall survival since initial metastatic diagnosis. However, both of the trials show that we're pushing the boundary around to 4 years, maybe even a little more beyond. The other reassuring part is the landmark analysis on those studies look quite similar, signifying that the combination truly gives the overall survival benefit. I do agree with Dr. Roto that upfront, there is a patient population have the intertwined overall survival curve, but you can't ignore the tail end. I think we're modulating the disease, not just offering upfront reduction of tumor burden. Side effects. With intensification, we also do see more side effects. However, those side effects, I think as an oncology society, we're learning how to serve our patient and how to mitigate so that the patient can both enjoy their longevity as well as quality of life. I want to highlight that most of the toxicities occur in the initial 3 to 4 months, meaning that after a stabilization stage, a lot of the toxicities are manageable. Both patients learn how to mitigate and also the side effect substitute. Continued optimization, especially the effort on the amivantamab side, also have increased the patient's quality of life significantly, including DVT prophylaxis, skin regimen, as well as a regimen to reduce infusion reaction. This also benefits patients significantly. I think with the above data, I'm pretty sure that we have seen the progression-free survival benefit since 23. And then now in 2025, both of the large study read out as overall survival significantly benefiting. And we are preserving patients' quality of life with continued optimization and learning. To me, combination or intensification is not really a question. The question is, how should we intensify? Who we intensify? Can we spare some patient from the intensification? From the subgroup analysis, we have learned that some of the risk features that in the initial diagnosis can really have a poor prognostic value. For example, as a society, we all know brain metastasis and the liver metastasis is not a good sign. And for not just lung cancer, but also solid tumor, TP53 co-occurrence oftentimes means a poor prognosis, as well as a large VAF in the detectable ctDNA. Patient with brain metastasis has a huge unmet need that they need better options. They need longer PFS and they need longer OS. In both of the studies, FLAURA2 as well as MARIPOSA, the MRI brain was designed for patients who have baseline brain metastasis, and for patients without baseline brain metastasis is also monitored throughout the time. I want to highlight that the PFS with osimertinib monotherapy in multiple big trials are around 13 months. So that's just a little over a year. Therefore, this group of patients definitely needs something stronger and better so they can live longer. This is the FLAURA2 seen as a progression-free survival curve with different cutoff as patients have more than one measurable. But you can see the curve nicely separate, signifying the benefit. Similarly, MARIPOSA also had a nice intracranial PFS for all patients. The next patient population I want to highlight is the liver metastasis. I circled in pink that without any intensification, osimertinib PFS in this population of patients is only 11 months. It's under a year. This is extremely high-risk patients. However, intensification do prolong the benefit and hazard ratio at 5.8, meaning that almost double the protection. I don't need to go through all the risk factors as all those are available through literature, but I do want to summarize in one table that both large trials, although the intensification method is different, signify that the brain metastasis patient, liver metastasis patient, A58R, TP53, as well as baseline detectable EGFR in the plasma, they all in those high-risk subgroups combination give benefit. If we put the patient population in totality, at the initial diagnosis, we only see about 10% of the patient without all the high-risk factors. The case that really Dr. Roto nicely presented was one of the few cases that have a deletion 19 without brain metastasis and many high-risk factors. Therefore, I will argue for majority of the patients, our default should be combination. But I'm not arguing that we should give everybody a combination. We still have to look at the patient risk factors, who we can really spare. I think this is the only population we have some form of confidence that we can spare in intensification. In both clinical trials, FLAURA2 and MARIPOSA, about a quarter of the patient has baseline ctDNA not detectable. That's a good thing. For MARIPOSA, for patients who have no ctDNA EGFR detectable, the progression-free survival with osimertinib is 30 months. So I think that's a patient population we can really think about offering monotherapy. and those oftentimes overlapping with not a lot of metastasis, relatively low tumor burden, and without liver metastasis. So I think for now, we kind of re-established the field in that combination should be the default because of the PFS benefit and OS benefit. And then we need to select the low-risk patients. Only for those we offer monotherapy. For the rest of the patient, we want to go for the OS benefit, aiming for 4 years, maybe 5 years in the future. And more study is coming on the way. For example, sub-Q amivantamab in TKI refractory population showed a significantly lower infusion reaction and the DVT. And we have seen recently in the last few months that the administration schedule for sub-Q amivantamab can be very flexible, either every 3 weeks or can be as flexible as every 4 weeks as a sub-Q regimen. Therefore, some of the visit burden will be decreased as well. So I think this is my conclusion slides. We have demonstrated that intensification with all the 4 different options listed on the top can have benefit, at least for PFS. And then now we see the major regimen have OS benefit, and we continue to optimize for patients' quality of life. For us, as a thoracic medical oncologist, when we're facing a stage 4 metastatic patients, really our goal is to prolong life and at the same time preserve the quality of life. Therefore, I argue that the combination is the default and the monotherapy should be only saved for very selected individuals. Thank you.
Opponent. We didn't have PFS as long as what we have now with combination. We did not have the OS2 data is showing. What else do you want?
Yeah, I think, no, I agree. I think in some ways, Dr. Lee and I are arguing the same thing where there's no one size fits all anymore for EGFR lung cancer. So, I think, and I agree, the field has moved very heavily, I think, towards deep combinations in many of our patients as a default. So I won't dispute either of those points, I think, in the spirit of not misleading our audience here for medical practice. But I think it's really important not to forget that there is that subpopulation potentially could do well on monotherapy. I think when we think about the feasibility of local ablative therapies for consolidation, a tool that really wasn't utilized across any of these studies, and all the modern next second line, third line regimens, as those strengthen, I think we're going to be able to offer our patients good outcomes, even if they elect to choose a quality of life focused choice. I'm thinking of our patients who've newly been diagnosed. They're facing this life-altering diagnosis and prognosis, and I think it's a real temptation for them to want to preserve a period of normalcy in their life, or as close to normalcy as possible for a period of time. So I never judge my patients for making that choice, I think, when they come to it.
Sure, definitely. I think, now that any question, Fatih?
All right, I'll sit here.
Thank you so much. Very interesting and I'm convinced with both presentations, actually. So I think the question is, I think the 10-15% who will be for monotherapy is probably we will agree on that. Elderly, frail, low risk, low burden, patient wishes. So there will be 1 or 2 cases but I think that I wish the debate was more actually which combo. That's the more difficult question we're going to face in clinic tomorrow. I think the default will be combo, not mono. So mono will be for those odd outliers, but the main bulk will be for the combination because there is no question the results were very impressive. So I think we need a bit of guide which one we shall use. Or I know there is no head-to-head comparison, but this is where we need to debate. Thank you.
Do you have anyone that is more close to your heart when you're coming and just giving an option to the patient?
I think probably the same thing for Dr. Roto. In our practice, mostly we're offering FLAURA2 as it's more convenient, and then also for thoracic medical oncologists, we know how to manage the hematological toxicity, and then the skin tox is not as significant. But I do see the field potentially shifting because of the sub-Q regimen becomes available. We'll have to see and wait to see how the dust will settle.
Yeah, I agree completely. I think actually the question I think was raised, should we change the debate once World Lung happened? We thought that would be an interesting topic, and the die was cast. We were already committed, but I agree that's the next interesting thing. Maybe next year we debate the two combinations. But I agree. I think I've been using more fluoro-2 in my practice, but I also agree that weekly subcutaneous dosing is appealing to patients as well. And I think again it may come down once more to a scenario where we're going to present our patients very similar efficacy data between these two regimens, and we'll be weighing different toxicity profiles and different logistics of administration. And I suspect there'll be patients who may have preferences in one way or the other. And the most challenging scenario in some ways may become the patient who needs intensification therapy, but once you make the decision for them, that's the hard scenario now when you don't know what your patient might want in the setting.
So with the available regimen that we have at the moment, which is IV with amivantamab, this is what we have to work right now at the moment until the sub-Q is going to become available. What is the selection of the criteria for the patient rather than just offering fluoro-2 to everybody? Is that something else that you can tease out from the data, whether there is molecular data or from the clinical data that you say that okay, this patient profile is going to be more kind of suitable for Mariposa, for instance?
For the Mariposa, I think the strongest subgroup analysis come from the liver metastasis patient. The separation of the curve and then the hazard ratio of 0.58 was really impressive. So for patients with liver mets, that's around 16% of all patients. I favor towards Mariposa because the data is very, very solid. The initial profiling also, to a certain degree, helped me in that if there's any hint of the MET amplification or any alteration occurring in the MET pathway, that will definitely tip me towards the Mariposa. And then the last but not actually least is that a lot of patients are not chemo eligible, but they could be Mariposa eligible because of the requirement for kidney function is much lower. So those are the patient population I will think towards Mariposa.
Thank you. And the last question to you, obviously when we developed osimertinib, it was to just prevent T790M mutation. And now we know that on osimertinib, MET amplification and obviously developing other rare mutation is going to be a resistant mechanism. So why not Mariposa for everybody?
Yeah, it's a great question, and we certainly know that using the Mariposa regimen reduces MET and EGFR-driven resistance. That makes sense based on the mechanism of action, and I agree, a patient with baseline MET alterations would tip me that direction, though it is a small fraction of our patients with newly diagnosed lung cancer. That said, we know that unlike in the frontline setting with T790M, what was the dominant, 50% of our patients would have this, the EGFR MET are still a small fraction of our patients when we do genomic profiling at acquired resistance. So that might be why we don't see such a difference in outcomes on the two studies, because they may not be the resistance mechanism identifiable in all of our patient populations. But if it's there, it's absolutely an argument, I think, both in the frontline and later line setting.
Thank you very much indeed. Yeah. I know that we are short of time, so I just want to thank you again for coming all the way from the US, and it was really, really nice discussion. Thank you.
Thank you.
Very interesting debate from big experts. So we move now to the next talk. I have the pleasure to introduce Professor Solange Peters, who is the past president of the European Society of Medical Oncology and the chairman of the Medical Oncology Department of the CHU de Lausanne, Switzerland. She will be talking about refining immunotherapy in non-oncogene addicted non-small cell lung cancer, the role of biomarkers, resistance, and real-world complexity.
Thanks so much. As usual, as almost every year, it's a great pleasure to be here. And I was given this title, which is a complex one. And as you know, as usual, I have lots of data to tell you. And my slides are your slides. You just drop me an email, I send you my slides, because I had biomarkers, resistance, real-world complexity. So it's a lot of things to cover in 15 to 20 minutes. But I will do that. And then you'll ask for my slide if I was too fast. This is my disclosure slide. So first of all, keep in mind, because in everything we discuss, that's when I started oncology. At the time of John Schiller publication comparing chemo to chemo, the only things that you could say is patients survived less than a year, median overall survival right 8 months, and whatever chemo you were choosing, slightly different toxicities, but the 5-year overall survival was simply 0 across all the TNM classifications, okay? Of course, we are developing many, many options, and I will just, it's a subjective choice, cover some of the prospects or initiatives that I still find promising because we've been failing some of them. This is a variety of things we developed from melanoma, renal, lung, head and neck, but I will cover just some of them, letting the room for other people to discuss the other ones during this meeting and maybe in another meeting. But let's start first with, of course, the basis of everything and the basis of most of the backbones, the 2 synapses, priming phase on the right, effector phase of the immune response on the left, the CTLA-4, PD-1, PD-L1 pathway with a real large number of drugs being developed. Remember that on the left, the anti-PD-1 and the anti-PD-L1, they probably perform perfectly the same. And we don't see any differentiator. Even if we try to identify some, it's not really the reality. But on the other hand, CTLA-4 might be very different. It's probably in the way they target the myeloid component and the Tregs. So the molecule on the right might be slightly different. But basically, biomarkers. You asked me to discuss biomarkers, and I will be very short into that to be able to deep dive into data. The only biomarker we strongly could confirm and verify after this ROC curve with the shoulder of the curve at 1%, but more visible at 50% of expression of PD-L1 on the tumor cell, which, for example, is not seen in melanoma, is this PD-L1 50%, what we call PD-L1 high. Again, in lung cancer is TPS, so it means the proportion of tumor cell expressing the tumor. So just a glimpse before I go into the subgroups and maybe the controversy of the evidence we have. High PD-L1, 50% monotherapy, very nice data. We give magnitude of clinical benefit scale score. 5 is the best for metastatic disease. And when you have 5 years data with a plateau of the curve, you can treat them like curative intent and give A, B, C, and A is the best. So for example, Pembro has A for meaning that you have some hopes for long-term cure. So atezolizumab, cemiplimab, pembrolizumab, with 5-year data of 30% in high PD-L1. This is what it looks like. You will admit that they more or less look the same, with some little divergence for atezolizumab, because remember the score, the PD-L1 slightly differently, blurring a bit the picture, but very consistent data. Importantly, keep in mind that the highest the best, your patient with 100% PD-L1, you're very happy because it's better than 80, and this has been shown in the Empower cemiplimab trial, but also independently by our colleagues investigators in the US. And maybe just a final word of caution, we like to give monotherapy, but look at the PFS curve. In the first CT scan, a third of the patients progress. So be sure that if the patient progresses, he will not die from the progression. So it's quite interesting to look that across clinical trials, the second line proportion of patients is quite low. It's 40 to 50%. So the choice of who for monotherapy is still a matter of concern. Probably not the never smoker, because in all of this trial, the never smokers do not benefit of monotherapy. So that's the first group you need to avoid. And of course, there's one question always, what to do with patient fragile, and maybe I will say here across various strata of PD-L1. So we built with Mingley this very difficult trial to conduct, and with Roche, trying to test atezolizumab in this patient elderly with comorbidity or with a PS of 3 or 2, meaning very fragile, to give atezo versus what we do usually, monotherapy, gemcitabine or vinorelbine. And it was interesting to see that atezolizumab is a good option in this patient for whom you struggle because you cannot give platinum tablets, and it's better regardless of the PD-L1 expression, and it's better for OS, PFS, and response rate. So if you really don't know what to do, monotherapy IO, I say atezo, but by the way, probably any of these PD-1, PD-L1 works in that setting as being better than nothing or better than monotherapy. So let's look at combinations. So any other PD-L1 expression, including high. So this is the non-squamous table. You know this data, but I just wanted to show you that we also have 5 years from 0 to 20%, and you always also have an A4 now for pembrolizumab in KEYNOTE-189. And as you know, we have new agents, gemcitabine, tislelizumab, so a variety of compounds you can use. This is a squamous table with a 4A for pembrolizumab, and similar 5-year survival of 18%, okay? The main question, of course, as I said before, is monotherapy versus chemo. On the left, a real-world analysis we did on Flatiron with our collaborative group 𝗜𝗍, which was showing that survival is exactly the same in high PD-L1, regardless of brain mets, regardless of most of the factors you can identify, except smoking. And never smoker need chemo. And if you look at the FDA analysis pulling all the data, they conclude the same in terms of OS, even if PFS and response rate is slightly better with chemo, IO, which is logical. So for high PD-1, provided the patient doesn't die if he progresses at the first CT scan, monotherapy is fine. The art of oncology, what is a risky disease? We know because we treat lots of patients. You know because you treat lots of patients. But trials are ongoing because subjective assessment is never very good in science. One on the US INSIGNA trial asking this question, monotherapy or chemo IO, and a per se trial, the equivalence in France. So this trial will give us the final scientific evidence-based answer to the question. Of course, there's always a question mark. The question mark is negative PD-L1. They really benefit from chemo IO? Well, we thought yes because of the data, but my answer is, look here, the overall survival on the left is not really hazard ratio 0.94. And when you look at all the trials in negative PD-L1, the benefit is very small. For example, in Europe, it limited the application of cemiplimab. We're not allowed to give cemiplimab chemo based on Empower Longo 3 in negative PD-L1 because EMA said 0.94. No. So that's where we are for this negative PD-L1. Why do I say that? If there are 3 topics I'd like to tell you about, for which I find there's a thought to have about CTLA-4. And the magnitude of my conviction goes from up to down. So first is negative PD-L1. These are the 3 trials we have with the CTLA-4. The 227 without chemo, it's nivo-ipi versus chemo, the comparison we use. Be careful, it was really made in a way which is strange. The primary endpoint was looking at positive PD-L1. So making conclusion on negative PD-L1 subgroup is a bit violating the rule of statistics, but I do. Then the 9LA with 2 cycles of chemo and the tremelimumab, durvalumab chemo, the Poseidon, which has the charm of having an arm without the CTLA-4. So it's very charming because then you can see the contribution of components. So all in all these trials are positive. They exactly look the same magnitude as without the CTLA-4. So why would you need a CTLA-4? It's really like the other ones, but for the negatives. But then when you look at negative PD-L1, you can really recover a hazard ratio, which is 0.75, 0.8 in the negative PD-L1. Would it be in Poseidon, in Checkmate 9LA, and in 227? And you can see here my 5-year Poseidon that I published in the JTO, where the hazard ratio in negative PD-L1 is 0.81. Not 0.94. So negative PD-L1, I think the whole community, again, violating a bit the rules of statistics because it's retrospective data, but in this retrospective data, we're all convinced, kind of strong conviction that a CTLA-4 might be useful. I go down a scale of my conviction, still quite convinced, STK11-KEAP1. So Skoulidis and colleague, I won't summarize nicely the data from MD Anderson because the colleague is here, so I will go very fast. But we know that in STK11 loss, for example, there is a very immunosuppressive environment, a recruitment of myeloid-derived suppressor cell, a repression of the STING pathway, very few infiltrating lymphocytes in the tumor. So a tumor with a very bad prognosis and a very bad response to IO, whatever you use, including the usual 189, the chemo pembro, and it was shown in retrospective data. And altogether, we've put our samples and our efforts to try to understand why, and by reprogramming probably the myeloid component, CTLA-4 might reverse this immunoresistance in the patient with STK11, but also KEAP1 mutants. And this is, for example, the Poseidon trial, where you can see that in STK11 also had a ratio of 0.97 in the other trials. When you have a CTLA-4, then your hazard ratio becomes again significant with something like 0.75. So STK11, KEAP1 are good groups, and it's also shown in 9LA and 227. So negative PD-L1, STK11, KEAP1. And of course, we need data, and we will have data because we do a phase 3B. It's just a confirmatory trial of CTLA-4, yes or no, in KRAS mutated, KEAP1, STK11, combined or not, because we need to dissociate them to understand the contribution of each mutation. Third question for CTLA-4, brain mets. If you are treating melanoma, no question, brain mets, CTLA-4. But is it the case in lung cancer? We don't know, but one thing which is quite impressive is in patients with baseline treated, that were all treated and brain mets, you see really an incremental of benefit of having a CTLA-4 as compared to the patient without brain mets. There might be confounders, but in all of the trials, you see really the most important benefits in patients with brain mets, as you can see with this hazard ratio in patients treated with CTLA-4. So this has to be proven prospectively. Not sure it will be the case. So that's a discussion to have with your patient. So this is the ESMO guidelines, high PD-L1, chemo IO, and just maybe the little nuance for the high PD-L1, not in never smoker for monotherapy, not in STK11 and KEAP1, and for the chemo IO, consider the 4-drug regimen in negative PD-L1 in brain mets and maybe in STK11 and KEAP1. And that's everything you need to know. But if you think about real-world data, it was in my title. So we made this correlate trial, it's now in press, comparing in greenish the randomized clinical trial patients, and in purple, the real-world data in fit, and in dark purple, in less fit patient, PS2, because we treat PS2 very often in the clinic. And look that you can divide everything, PFS and OS, by 2. So in your real life, don't expect you reach what 189 has been publishing in New England. Probably you divide it by something, maybe not 2, but it's not going to be so good in the non-selected patients groups that you have in the clinic. And we are publishing it. Of course, the reviewers are very tough with us because real-world data are difficult to publish, but I think it's important data. Okay? Then, how to move from there? So maybe the not so convincing thing for me because of the toxicity is potentially to consider that chemo PEMET, Hexed, Pembro could become platinum, ADC Pembro or just ADC Pembro. While I can accept the ADC Pembro, the platinum ADC Pembro is a bit difficult for me. But all of these are early trials to try to evaluate sacituzumab govitecan plus IO, datopotamab deruxtecan plus minus platinum plus IO, and this is a sacituzumab tirumotecan plus IO. So all of them show that ADC work well with IO. But are we ready to replace pemetrexed by datopotamab deruxtecan? I don't know if you have used datopotamab deruxtecan, but that's something, right? So it's a good drug, but it's more toxic than what we had. And this is leading to this kind of number. If you look at the response rate when you combine 2 or 3 drugs as compared to the backbone 189 and or 20 kilo 24 in high PD-L1, the numbers look slightly better. That's true in terms of response. But what the durability? How are you going to move? So this is something that will probably be answered. But before answering this question, I would have loved all these trials to be stratified for a biomarker. And remember this effort that Marina Garacino and the team of AstraZeneca and Daiichi Sankyo have done to try to understand what the biomarker for TROP2 ADCs, trying to understand also that probably having the molecule on the surface of the cell is one thing, but the most important thing is to have it endocytosed, internalized in order to release the payload, the warhead. So you can measure the internalization by making a ratio between inside cytoplasmic versus membrane presence of TROP2. And this is a scoring perfectly proprietary. You need to stain with Ventana. You need to have a WHSI, meaning a whole slide imaging in your house. Then you need to send to Foundation Medicine. There's still no price tag, and Foundation Medicine tells you if it's positive or negative. But so it's not completely democratic, but it might be the next score. And if I tell you that is, so this is positive, negative. If you see the proportion, it divides at the end more or less 50-50, which is not bad. And if you look at the TROP-lung-O2, meaning this triplet or doublet, datopotamab plus IO, based on the NMR, so the score positive or negative, it's amazing how the score is separating the curve. So I would like all the trials to use that. It's not going to be the case. The first one, Avanza, which we'll be reading, big one, it's not stratified by the score, but it will be reviewed retrospectively. But we all love stratification, right? So these are the huge amount of trial moving frontline, I'm still frontline, with an ADC plus minus platinum plus IO as compared to the usual 189 or 407, okay? And not all of them look at Avanza, for example. This is not stratified, but it will look at the NMR, okay? So 2 things maybe for the hopes that I have. First of all, I look at this review, it's a wonderful one, the opportunity of having 2 immune modulators for the price of 1, what we call the bispecifics. So you can imagine many things. For example, tarlatamab, it's the same thing. It's a bispecific CD3, DLL3. But so you can really combine 2 checkpoints, different targets, a tumor neoantigen, so everything you want to be able to have really a better specificity and maybe a better efficacy. So I would like to focus on the one I find promising, which is targeting VEGF and PD-1 or PD-L1. And here you have the development of many, probably more than in my table, particularly in Asia, in China. but 4 of them, 3 of them, at least 4 of them, you need to know. The 𝗂𝗂𝘂𝗃𝗁𝗵 that you've heard about. The new Merck, that Merck has bought one of them, that is now reaching the building of phase 3 trial. The Sunshine Gojon agent, which was bought by Pfizer, and you have seen data I will show you, and the BNT327 that I have the chance to develop, which is a VEGF-PD-L1, which is developed by BioNTech. Okay, and now BMS, BioNTech and BMS now. Okay, so the 4 you need to know because they will reach our markets. So basically, first of all, the harmony. So remember that John Heymack discussed wonderfully at the World Long that this PFS of giving ivonescimab versus pembrolizumab in positive PD-1 patients was absolutely amazing. 0.51. On the right-hand side, the catastrophe. Summit stock crashes as Akeso, so ivonescimab, shares that bispecific first overall survival data is negative. Okay, so why am I enthusiastic? It's negative survival. Okay, because the statistics are completely crappy for the European market. So if you think, I'm sure you're very aware of statistics, but you distribute your alpha. You can also recycle your alpha. So if you're convinced about your drug, you take 5% of your alpha for PFS and you recycle it if PFS is positive for OS. By the way, what does an OS benefit mean if the PFS is not positive? So you can do it safely. If they had done it, it would be strongly positive. But they have given 0.5 for 99% of the alpha to PFS, and they decided not to recycle it and to have 0.001% of the alpha to OS, which is 0.00001. And we are a statistician. We made the calculation that even with a hazard ratio of 0.34 for survival, it would have been negative. So statistics were done for the Chinese market and not for our market when Indian OS survival benefit. Reason why I still believe in the compound, not because I'm naive, it's just because the statistics were not good. This is a BioNTech compound, patients PD-1 treatment naive after IO failure. So both of them look very good in patients with non-small cell lung cancer and with positive PD-L1. And this is a Pfizer compound, which is quite nice, also monotherapy in patients with positive PD-L1 across histologies, across various strata of PD-L1. You will agree with me that it tends to look better than monotherapy checkpoints. So I really give a hint and a hope into that. So we have many trials in building, but at least Summit Therapeutics is doing 2 of them in patients with or without chemo in high PD-L1, with chemo in all comers across histologies. And the BNT327, I'm chairing this one, the Rosetta Long O2, we do across histologies with chemo. So we'll see what it gives next week, next year probably. So last table for you, that's what we have in ongoing frontline trials. So ongoing frontline trial, you have the ivonescimab BNT327 trial, and Pfizer will come, and Merck, MSD will come also with their trials. The niraparib is unfortunately negative. We have the ADC. You still have the volrustomig bispecific. Remember, the volrustomig is CTLA-4 PD-1 from AstraZeneca. Rilvegostomig, the remaining TIGIT, after all the failure, with PD-1 from AstraZeneca, and the relativity trial, the nivolumab relatlimab that I also chair from BMS. And with this, you might complete your picture. And if I had also in my title, the resistance, if you want to try to know what we have understood about resistance, which is very little in lung cancer, we just wrote with reviews with Martin Reck, Fabrice Barlesi, and Bernie Fox about the mechanism of resistance, all the failure. It's going to be published in Nature Review in Clinical Oncology, so just go into that. Nothing really that will help us guiding your treatment for second line and later down the road. So I just wanted you to be aware that if you need to teach, take these things, nice figure, but nothing really to use. And for this, I thank you for your kind attention.
Questions? Thank you, Dr. Professor Solange. I think we're going to keep the questions for later on. So thank you very much for that comprehensive and mind-opening talk. And I would like to welcome Dr. Osman Ahmed. He's the chair of the Department of Vascular Surgery at the Vascular and Thoracic Institute in Cleveland Clinic. He'll be presenting for us the role of the surgery in the new era of neoadjuvant immunotherapy in resectable non-small lung cancer. Please welcome Dr. Ahmed.
Thank you very much. Assalamu alaikum. Good afternoon. Pleasure to be here. Thank you for the invitation. It is great to see old friends and happy to make new friends. I've been here for about 3 years now trying to establish thoracic surgical oncology, robotic surgery, and lung transplantation in the country. And I think it is very important for me to say that for all the people I know in this room, every one of them have helped me establish this complex surgical care in the country. And I really cherish and appreciate the multidisciplinary care and collaborations that we have to help our patients. I have no disclosures pertinent to this talk. The one point I would like to make is that it warms my heart to learn that Dr. Ibrahim, who's a radiation oncologist, took the surgical arm this morning in the surgery versus SBRT debate. So I'm really thankful for him. But if any of the other radiation oncologists want to go for a duel again, I'm available. It's been exciting the last decade in lung cancer care. We've seen all the progresses that has been made. But for the last 40 or 50 years, the care of lung cancer has pretty much been the same, where we're dealing with the same agents, same surgical tools and therapies. So it's very exciting for us to talk about these newer modalities, which are bringing our patients into an era that was unheard of before, survival rates that we had never seen before. But despite that, there are some sobering realities. So these are ILC data, IASLC data that I'll share with you. So lung cancer remains in the top 2 or 3 topmost cancer accounts for the topmost cancer-related deaths. These are United States data, but they're applicable elsewhere also. We're thankful to Dr. Hamed, who's trying to collate the data from this part of the world. For those of you who've been here, this is the Mohammed bin Zayed football stadium in Abu Dhabi. And you'd have to fill this stadium about 10 times and empty it. And that would be the number of people who died of lung cancer in 1 year in the United States. And we don't think that that statistic or that proportion is much different in the rest of the world. If anything, it's probably worse in the rest of the world. So these are sobering realities, along with the treatment difficulties that our patients face, that we do need to account for and discuss as we discuss these excitements that we're also talking about. If you look at the 9th edition TNM stage distribution, we think we have a pretty good handle on early stage patients. We're now seeing patients reaching almost 100% 5-year survival in the very early stages, patients with ground glass lesions, patients who are caught, whose tumors are detected early. However, we continue to struggle with patients who have anything more than 1B disease, and the survival rates are nowhere close to what we're seeing for other tumors and other organs. We all know that the picture on the right side of the screen can be dealt with very easily. This is a pure ground glass lesion. Even if this is has a solid component, we can deal with this surgically quite easily, and these patients now will more likely die of cancer unrelated causes because we can treat their tumor so effectively with our ablative therapies and local therapies, be they surgical or non-surgical. The problem is that there's the scan on the left. All of you are familiar with this more than I am, and these are the patients who need our help and our attention more than anybody else. The problem is we can treat everything in the chest, but where we fail is outside the chest or in the region. And that is what we're here to discuss, how we come together and bring our multimodal therapies together to help our patients. So the middle of the staging map is where we need to focus most of our attention, as we discussed. Surgical therapies have been pivotal in management of lung cancer, and surgery has been sort of the central component and has played a pivotal role for the last 5 decades. This is the lung cancer study group, study by Bob Ginsberg that came out of Memorial in the early 90s, was done in the 80s and 90s, pre-PET scan era. However, established lobectomy as the standard of care for resectable lung cancer. Now, this has been going on unchanged all this time. And because of this, the surgeons sort of took on this role of superheroes in the management of early or resectable stage lung cancer. And that's sort of how I feel, despite my shortcomings. But the reality is that the superheroes rely on their superpowers and their tools. So, if you go take a superhero into a toy store, would they be happy with one superpower, a different superpower, or both of them? And that is really where you guys help us and our patients in trying to achieve the best possible survival. And really what this translates into is the discussion we're having about where to add therapies to prevent and decrease systemic recurrences, whether we do it before surgery, after surgery, or in the perioperative style. Dr. Solange Peter's list of drugs was much longer than mine. This is just the data that's published and the surgeons can sort of wrap their heads around. But this is an exciting time in lung cancer management. New data are coming out every day or week as we speak. But let's sort of sort through it from a surgeon's perspective. So if you look at early stage tumors that are node negative, now this is a relatively rare entity where you have a larger tumor with clearly clinically proven negative nodes. In most clinical trials, be they adjuvant or I'm talking about chemoimmuno trials, be they adjuvant perioperative, the number of these patients is relatively low. They're sort of mixed with the N1 patients, so it's hard to make sense of whether these patients benefit from neoadjuvant chemoimmunotherapy or neoadjuvant treatment per se as such. But we generally feel that there's a trend towards improvement in EFS. This is a meta-analysis that you're seeing here, where more or less the trend is that the patients do benefit from neoadjuvant therapies in stage 2. The immunologic arguments are much stronger, giving patient chemo IO when the tumor is still there for priming reasons. We get potentially useful prognostic data that we can use later on in the patient's treatment course are all useful aspects, which now make us feel that in general, I think most of us would lean towards giving these patients neoadjuvant therapies, be they chemo or chemo IO. Now, the problem we run into is discussions with patients. The occasional patient who will progress through it will not feel great about this treatment choice, but in general, the data would suggest that we will lean in that direction. The N1 patients, as we get into the nodal disease, is where the benefit of neoadjuvant therapy really shines through. And if you look at our N1 patients, again, lumped into the stage 2 in most of our analyses and most of the trials, but we do see that there's increased rate of nodal downstaging. And for me, presence of N1 nodal disease is really the strongest indicator of having occult N2 disease. So for any nodal disease in lung cancer, to me, is beginning of systemic disease. And I would err towards adding more systemic therapy to that patient's treatment regimen in whatever form we decide in a multidisciplinary fashion, whether it's perioperative, neoadjuvant, or adjuvant. As we get into more N2 disease, more central disease, the benefit becomes more clear. We've now seen in non-surgical trials, the PACIFIC data is very impressive. The NADIM2 data is very impressive, that patients of N2 disease can have significant downstaging. We can significantly prolong their overall survival. So definitely for single station N2 disease, I think most of us would agree. Most teams, most multidisciplinary groups would agree that these patients would benefit from neoadjuvant chemoimmuno, well, let's just say neoadjuvant therapy as part of their multimodal regimen. Again, some of these decisions are institutional based. There are institutions who think that N2 disease should not be treated with surgery and should just have definitive non-operative surgery. That can be debated, not the debate for today. However, I think we all agree that adding systemic therapy early on is helpful for these patients. We do think that these patients greatly benefit from multidisciplinary discussions, and we do think that lobectomy is very reasonable to consider in these patients. Now, the other big debate here is the bulky N2. See, where are my dots? There we go. Bulky N2 or multi-station N2 is where people back out even more. Now, I would argue that this is where we probably see the best effect or the most effect of our perioperative neoadjuvant or adjuvant systemic therapies, be they chemo or chemo IO, or particularly chemo IO. And we've seen the subset analyses from multiple trials to see the benefit in N2 patients. We've seen significant downstaging of N2 patients. And this historical bias about the nihilistic attitude towards treating N2 patients, I think, is no longer applicable. The morbidity of surgical treatment comes from lung resection, not from nodal dissection or nodal resection. The nodal component needs to be treated surgically along with systemic therapy. The systemic therapy is more important for the nodal component. And with that, addition of local therapy, I think, is a very valid combination of treatments. There was a recent survey in the NCCN centers where 16% of multidisciplinary groups thought that they would offer surgery in bulky N2 patients and 47% in non-bulky N2. The definition of bulky is also variable. However, in general, as we move forward, we can get better systemic control. with our newer agents, I think it is very reasonable to offer these patients trimodality therapy, including resection. For time's sake, I'll just move forward without asking the question. I think all of you know here, this is mostly for the surgeons, that in the presence of driver mutations, regardless of PD-L1 expression, the patients should get neoadjuvant chemoimmunotherapy, and they do benefit from it, as most trial data would suggest. So let's address some of the surgical issues that come up repeatedly when we give patients neoadjuvant immunotherapy or chemoimmunotherapy. And these myths or concepts that these treatments can delay resection, patients may miss an opportunity for resection, or the resection may be more difficult, need to be addressed very carefully. Most of the large trial data would suggest that there is no difference by adding neoadjuvant immunotherapy or chemoimmunotherapy in completion of resection, the number of patients who underwent resection safely, the minimally invasive approach if the surgeons decided to use so, and the R0 resection rates, in fact, are better by addition of neoadjuvant therapy. The best data that looks at the surgical complexity comes from the NeoStar group, I should say, with their Nivo and Ipi-Nivo, and then their local registry at MD Anderson that looks at patients who received either neoadjuvant chemo or had upfront surgery. And most of these numbers would suggest that there was really either no difference or improvement with the addition of neoadjuvant immunotherapy in resection rates and in downstaging. The time to resection, which is one of the concerns, was about a month across all the arms. The perioperative adverse event profile is quite similar between the groups, particularly with the addition of immunotherapy up front. The profile remains quite safe. And they also did this cool, unique thing where they asked the surgeons to rate the difficulty of surgery based on what sort of treatment the patient received. It does appear that there are some differences in operative time and blood loss. However, more or less, the quality of surgery, the complexity of the surgery, as well as the adverse event side, adverse event profile is more or less similar between the various arms, particularly the Nivo and the Nivo-Ipi arm. Now, 40% of these cases were deemed more difficult. However, they argue that this could have been because of tumor size. And 52% chemo IO cases were considered more difficult. But again, this is relatively subjective and surgeon dependent. The important thing that surgeons argue is that if there's hilar disease, if there's lymph nodes between the branches of the pulmonary artery and the bronchus that we have to dissect out, and there is pathologic response secondary to the neoadjuvant treatment, that dissection can be very difficult. However, in this study, that did not seem to be the case. So the pathologic response in the lymph nodes did not correlate with the difficulty of surgery. For people in this room or people who practice in this region, this becomes a bigger problem because we're not only dealing with just malignancy in the node, but a lot of granulomatous disease also, which with the addition of immunotherapy can get more riled up and can make surgeries more challenging. However, in our experience, our risk profile in these patients after chemoimmuno is quite acceptable. The AEGEAN data is very similar. So surgical exploration was very similar between the chemo IO and the chemo arms. Patients who had complete surgical resection were very similar. So really nothing to suggest increased morbidity or mortality by giving neoadjuvant chemo IO. Delay in surgery, time from surgery to first adjuvant dose, and mortality were also very, very similar. The CheckMate had similar, 816 had very similar AE profile in the perioperative period. Really no surgical delays, minimally invasive surgical techniques were used, and their adverse event profile did not really differ from the chemotherapy arm. Pneumonectomies is always a sore subject, but most of these trials have shown that they can be performed safely in the right settings for the right patients. And this is just a quick summary of what we discussed. So really no big differences among most of the trials in surgical cancellation after receiving neoadjuvant chemo or chemoimmunotherapy. The use of minimally invasive techniques appears to be quite similar between the various trials. And the extent of surgery also is fairly similar in terms of lobectomy and pneumonectomy. Now, along with our advancements in systemic therapies, our surgical tools and techniques are also evolving. We've gone from doing big open incisions for even small tumors to doing really keyhole, minimally invasive robotic surgeries for even advanced tumors, where we have to do airway reconstructions or vascular reconstructions. So taking that into account, adding that to our improved systemic therapies, particularly in the neoadjuvant setting, has really changed the game for our patients. I couldn't really pull the video for our post-induction lobe, but I'll share this video with you of a complex airway resection, which is very akin to what we see in post-chemo-IO neoadjuvant lobectomies. Can you guys play this, please? So this is a young girl who has a central carcinoid tumor at the hilum of the left lung. You can see the tumor here invading into the airway. This is the bronchoscopic view. She had large nodes around the airway also that had to be resected. This is a robotic resection of the lung, along with resection of the airway with reconstruction. So these surgeries are complex because the heart's beating, the other lung is breathing at the same time. But with our newer tools and technologies, we can do all this. So these are robotic arms holding the lung and dissecting the nodes. This is a stapling instrument that you just saw. These markers show you where the airway is and where the tumor is. This is the left mainstem airway open. You can see the tumor and the specimen that is being removed. Now this tumor was invading the airway, so we're going to resect part of the left mainstem bronchus and then sew it back together. And that is the left mainstem bronchus that is being removed, where you saw the tumor invading the airway on the bronchoscopic view. After that was removed, the margins are confirmed negative. We'll sew the two ends back together. And all of this is being done through 3 1-centimeter incisions. This patient wakes up 2 hours later, goes home in a couple of days. So the morbidity of these complex surgeries has now significantly decreased with our newer tools and tips and tricks. And that in combination with what all of you offer to our patients in terms of the immunological or the targeted therapies has really changed the game in management of lung cancer. So all these steps that would typically require for us to make a large incision, put our hands in the chest, can now all be done minimally invasively. So to summarize, complete resection remains a central tenet in multimodal therapy for locally advanced non-small cell lung cancer. These patients deserve to undergo multidisciplinary evaluation to decide their resectability, operability, which are again 2 different concepts, and the optimal multimodal approach. Neoadjuvant chemo-IO in patients who then undergo surgery are associated with higher R0 resection rates. We've seen higher nodal downstaging, and this carries an acceptable surgical risk profile in selected patients. Now, this concept of downstaging tumors to make them resectable is not really viable, and we should just avoid that completely. Patients who are not resectable up front should undergo definitive non-operative therapy, and surgery should just be off the table for them. And the last point that I'd like to make is minimally invasive surgery can also be considered in patients after chemo-IO. Hilar fibrosis is present, is more than what we see with chemo, but is not prohibitive to proceed with surgery in these patients. Thank you very much.
So as agreed, we will leave the question till the end. So we move now to the last talk of this session. Dr. 𝗜ļi Das, she's the Chief Oncology of Palo Alto Healthcare System, Stanford University. She will be talking about small cell lung cancer maintenance treatment.
Thank you so much. It's really wonderful to be here, and I wanted to thank the organizers for the invitation. So I'm very excited to speak about small cell lung cancer, and I'm going to be focusing today's talk on maintenance therapy in small cell, which is not something that we talk about that much. But I think there's been emerging data, and I think we are going to see some approvals in this space. These are my disclosures. So we know that combining platinum etoposide with immunotherapy has really changed the frontline treatment for our patients with extensive stage small cell lung cancer after many decades. So our standard of care now for a newly diagnosed patient with extensive stage disease is to add a PD-L1 inhibitor to chemotherapy, which is usually platinum etoposide. So first we have the IMpower133 trial, which looked at adding atezolizumab to platinum etoposide. It showed about a 2-month survival benefit with the addition of atezolizumab, leading to its US FDA approval in March of 2019. This was followed by the Caspian trial. So this was a very similar study where the checkpoint inhibitor here was durvalumab. Again, we saw about a 2-month survival benefit with the addition of durvalumab to platinum etoposide, leading to its US FDA approval about 1 year later in March of 2020. So you really have now 2 options of immunotherapy to add to platinum etoposide for our extensive stage small cell patients. I also wanted to point out that in the Caspian trial, there was a third treatment arm with the addition of tremelimumab. So this is the CTLA-4 inhibitor. So it's a four-drug treatment arm. And what we saw actually was that 4 drugs was not better than 2 drugs. And so you can see no statistically significant overall survival benefit with the 4-drug regimen. And so there's really no role for CTLA-4 inhibition in small cell lung cancer. We also now have longer-term follow-up from both the Empower 133 and Caspian trials. So the Umbrella A was the extension study from Empower 133, and what you can see is that at 5 years, there's 12% of patients who remain alive receiving maintenance atezolizumab. Similarly, in the Caspian study, we have the 3-year overall survival update where we see approximately 18% of patients continue to remain alive receiving maintenance durvalumab. This is compared to 6% in those patients getting chemotherapy alone at the 3-year mark. And so there is this subgroup of patients that are really benefiting from that maintenance immunotherapy. We also know that unlike in non-small cell lung cancer, as you heard from Dr. Peters, we use PD-L1 to really predict the patients who are most likely to respond to the checkpoint inhibitors. In small cell lung cancer, PD-L1 status does not predict benefit. Across randomized phase 3 studies, you can see that there's no correlation between PD-L1 expression and efficacy in terms of the addition of the checkpoint inhibitors. And so this is not something we're currently evaluating in our patients with small cell. So now I'm going to talk about lurbinectedin and maintenance, and just to start with a little bit of background with lurbinectedin, this was approved as a second-line treatment in small cell lung cancer back in 2020, so about 5 years ago. This drug is a selective inhibitor of oncogenic transcription. It was studied in an open-label phase 2 basket trial of a little over 100 patients, where we noted a response rate of 35%. Adverse events were felt to be manageable, mostly hematologic, and based upon this data, this drug did receive accelerated FDA approval in June of 2020. So now we have the IMforte trial, and this was presented just a few months ago at ASCO this year, and this was a study I had open at my institution. So these are extensive stage patients with no prior systemic therapy, no brain metastases, and good performance status. They went on to receive standard of care induction with platinum etoposide with the addition of atezolizumab. This was given for 4 cycles every 3 weeks, after which time a second screening took place. So provided these patients did not have disease progression and maintain good performance status, they went on to get randomized into the maintenance phase of receiving lurbinectedin plus atezolizumab versus the standard of care of atezolizumab alone. And treatment was to continue until disease progression or unacceptable toxicity, and you can see that the primary endpoints were PFS and OS. And these were the results that were shared at ASCO. You can see here clear separation of the curves in favor of patients receiving lurbinectedin added to maintenance atezolizumab. The hazard ratio here was 0.54. Remember that the PFS assessment started from randomization into the maintenance phase, and so you have to add 3.2 months to account for the induction phase here. So you can see in the lurbi atezo arm PFS 5.4 months, and the atezo alone arm 2.1 months. Similarly, we're seeing an overall survival benefit with the addition of lurbinectedin to maintenance therapy, median OS 13.2 months in the lurbi atezo arm versus 10.6 months in the atezo alone arm, with a stratified hazard ratio of 0.73. Again, you have to take into account that induction phase of treatment, which is 3.2 months. So we are seeing a survival benefit, and I do expect that this will likely receive US FDA approval in the upcoming months. As far as safety goes, as you can imagine, when you're adding chemotherapy, you're adding toxicity. So grade 3 and 4 adverse events were higher in patients getting lurbinectedin plus atezolizumab maintenance, 38% versus 22% in the atezo alone arm. So it's just something to be aware of. Moving on now to tarlatamab. I'll be discussing it again in the context of maintenance therapy in small cell, but first, again, this was approved as a second-line treatment in small cell. This is a bispecific T-cell engager that targets DLL3 and CD3. It was studied in the phase 2 𝗘𝗱-301 study of 100 patients who received the 10 milligrams per kilogram dose, where we saw an overall response rate of 40%. Adverse events here were manageable and were a little bit different. So the toxicities that we see with the bispecific T-cell engagers are mostly cytokine release syndrome and thankfully mostly low grade with tarlatamab. And based upon this encouraging data, tarlatamab received accelerated FDA approval in May of 2024. And then just a few weeks ago at World Lung, that took place in Barcelona, the 𝗘𝗱-303 study was presented. So this was a phase 1b study of tarlatamab with anti-PD-L1 as first-line maintenance for extensive stage small cell lung cancer. So you can see patients in the first line all received platinum etoposide plus an anti-PD-L1 antibody given for 4 to 6 cycles, after which time you can see patients were enrolled onto the study, assuming they did not have disease progression and maintain good performance status. You can see that patients with treated and asymptomatic brain mets were permitted, but no active autoimmune disease was allowed or patients who had disease requiring any immunosuppressive therapy. So this was a non-randomized study. Patients went on to receive either tarlatamab plus atezolizumab or tarlatamab plus durvalumab. And the primary endpoints here were dose-limiting toxicities, treatment emergent, and treatment-related adverse events. What you can see here as far as safety goes, all grade tarlatamab-related adverse events are listed here. So grade 3 to 4 noted in 27% of patients. With longer follow-up, so more than a year, we could see that tarlatamab with anti-PD-L1 as first-line maintenance therapy had a manageable safety profile with no dose-limiting toxicities and no fatal treatment-related adverse events. Immune-related adverse events were actually overall very low, and this is excluding the CRS and ICANS. Again, when you delve a little bit more deeply into the safety, you can see that the incidence of treatment-emergent adverse events really decreased over time, supporting the long-term tolerability of tarlatamab. ICANS, which is the neurologic syndrome associated with cytokine release, occurred in 6% of patients, all with early onset, and all events were grade 1 to 2 and resolved with supportive care. So overall, it seems that the combination of tarlatamab and anti-PD-L1 had a manageable safety profile. And this was the preliminary overall survival. Of course, we don't do phase 1 studies to look at overall survival, but I think encouragingly what you can see in the overall treatment population here, a median OS of 25 months was reported. So this is really unprecedented overall survival in extensive stage small cell lung cancer patients. So we do have the ongoing Delphi 305 study. So this is the randomized phase 3 trial that's ongoing, randomizing patients to receiving tarlatamab plus durvalumab maintenance versus durvalumab maintenance alone. Primary endpoint is overall survival, and we expect to see results from this hopefully soon, and I think this will really inform our maintenance treatment strategies in this disease. I also wanted to mention a few other, I think, important biomarker-specific studies in small cell lung cancer. We talk about biomarkers all the time in non-small cell lung cancer, and I'll say we don't think about it that much in small cell, but I do think that that may change. So the SWOG 1929 study, this was presented at ASCO a few years ago. This was a phase 2 study of maintenance atezolizumab compared to atezolizumab plus talazoparib, which is a PARP inhibitor, in patients with SLFN11 positive extensive stage small cell lung cancer. We know that SLFN11 positivity tends to predict responsiveness to PARP inhibitors. So in this study, patients all received standard of care platinum etoposide plus atezolizumab for 4 cycles. They had to have SLFN11 IHC performed on an archival specimen, and if this was positive, they went on to get randomized to either arm A, which was atezolizumab alone, or arm B, which was atezolizumab plus talazoparib. And treatment was to continue until disease progression. And the hypothesis here was that the addition of talazoparib to maintenance atezolizumab would improve progression-free survival, specifically in these SLFN11 positive small cell lung cancer patients. So this is really a biomarker-directed study in small cell. And the primary endpoint was progression-free survival. So this is the SLFN11 test summary. You can see here that 79% of patients were actually positive for SLFN11, which was higher than predicted, and the median testing time was about 1 week. And these are the PFS and OS curves. PFS was, you can see some separation of the curves. Overall numbers are quite low, but you can numerically, you can see that the patients receiving atezolizumab plus talazoparib had a median PFS of 4.2 months compared to 2.8 months in the atezo alone arm. OS was not different between the 2 treatment arms. So that provides the context for this new study. This was just activated, I think, in the last week or so. This is the SWOG 2409 PRISM study. So this is a multi-cohort precision small cell lung cancer subtype maintenance phase 2 trial of immunotherapy versus biomarker-directed novel agents in combination with immunotherapy in extensive stage small cell lung cancer. So step 1 involves screening of over 800 patients. So these are extensive stage patients. Again, asymptomatic or stable treated brain mets are allowed, and the study does allow for consent after the initial cycle for tissue screening. And then you can see here, step 2 is the randomization, where patients are allocated to different treatments based upon their molecular subtypes. So you can see for subtypes A and N, who are Schleppen-11 positive. So these are patients who are specifically predicted to respond well to the PARP inhibitor, or those patients who have subtype P, again, thought to predict responsiveness to PARP inhibitors. You can see randomization to either immunotherapy alone or immunotherapy with the PARP inhibitor. Subtypes A and N who are Schleppen-11 negative, we're looking at novel combinations. So here it's IO versus IO plus an ATR inhibitor. In subtype I, we're looking at IO versus IO plus an NK activator. And the primary endpoint here is progression-free survival. So this, again, study just began enrollment, and I think it's quite exciting to be able to think about these potential biomarkers in our patients with small cell. So key takeaways: platinum etoposide plus a PD-L1 inhibitor, either atezolizumab or durvalumab, is now standard frontline therapy for our extensive stage patients. There's no added benefit of a CTLA-4 inhibitor. We know PD-L1 status does not predict benefit in small cell. We do need to try to come up with predictive biomarkers here. First-line maintenance, lurbinectedin with atezolizumab is a new option for select extensive stage small cell lung cancer patients based upon the positive data that was presented at ASCO this year from the IMforte trial. The addition of tarlatamab to anti-PD-L1 as a first-line maintenance appears to be safe and demonstrates unprecedented overall survival in this phase 1 𝗘𝗱-303 study, and we do have the ongoing phase 3 𝗘𝗱-305 study with tarlatamab maintenance. The goal ultimately is to perform prospective trials with the selection of biomarkers, and I do think that we have this ongoing PRISM study and other studies that hopefully will continue to take shape in small cell lung cancer so that we can really select the best patients for some of these novel therapies that we're exploring in this very difficult to treat disease. Thank you very much for your attention.
You can, yeah, please, Dr. Peters. We'll move now to question. Dr. Aida.
And most of the patients, unfortunately, like we lose a patient when they progress in the first line therapy. So this is very intriguing to me. Last week, unfortunately, I lost a patient on first line therapy. So I immediately thought about maintenance strategy. So how you would best choose maintenance strategy for the patient, and which option would you do?
Right, that's a great question. Right now, we don't have any approvals for any of these maintenance strategies. I do expect the lurbinectedin to gain approval first, based upon the IMforte study. But I think many of us are excited about the tarlatamab, so the bispecific T-cell engager, and we expect to see 𝗘𝗱-305 be a positive study. Of course, we need to wait for those results. But I think that's what I'm most excited about, is using as maintenance therapy, especially with that high overall survival that we're seeing. Lurbinectedin, in my experience, it's tougher. It's a chemo drug, and I think patients have a tougher time with it, and I don't think you're going to achieve that same level of survival benefit.
So for those patients who we started in Durva, and now we want to do maintenance strategy with lurbinectedin, for example, would you actually consider it, or would you just do it with atezolizumab?
Oh, that's a nice question. No, I really consider these checkpoint inhibitors as interchangeable. Of course, IMforte was done with atezolizumab, but I wouldn't necessarily switch someone to atezolizumab if I were to consider the lurbinectedin. So yeah.
Just one comment on that. You know, many times when we do these trials, we have to be careful. So to me, this is early second line introduction, and with all the bias of that, and the placebo arm, how many were exposed to lurbinectedin afterwards? They were not high percentage. So how do you rectify those arguments versus providing this? Because these patients are sick, they are tired, they had 4 cycles at least of chemotherapy. The last thing they want to hear is go back on another chemo altogether, like lurbinectedin.
I 100% agree with that. And I think one of the challenges in small cell lung cancer is after patients progress on first line therapy, there's about a 50% drop off into second line therapy. So that really, I think, begs that question of bringing second line therapy into the maintenance phase, because you're going to have a number of patients who are going to progress and die before they can even get their second line therapy. So I think that's why we're seeing a lot of these second line treatments now getting moved up. It's not for every patient. Right. You're right. Absolutely not. And I think it is a conversation. You know, I had the IMforte study open at my institution, and it was a hard one. You know, these patients, you're getting them through that first induction phase of chemotherapy. They don't want to be on a maintenance chemotherapy drug. That's why, again, I think I'm more excited about the tarlatamab. I think there's a lot of work being done to try to make this more manageable for patients in terms of outpatient monitoring. And so, I think we'll see. I think we'll see in the upcoming year.
They make it cheaper a little bit.
And they need to make it cheaper.
In our area, every patient has a cap, and when you use drugs like tarlatamab, you make it a dose or two, and you are capped for the year.
Yeah, maybe just a remark about this tarlatamab data, which I was in. It was difficult to build the IMforte trial. I was in the steering committee, and it was indeed not easy because we know the hematotoxicity of platinum etoposide, and then you pile up with another. But I was surprised that it's not so badly tolerated. But the most important thing, and you're right, will be probably to move tarlatamab the earliest possible, meaning that what is amazing with tarlatamab is there is a discrepancy between the progression-free survival and the survival. Of course, a little bit because it was allowed to continue beyond progression, some radiation, whatever, but more probably because of the biological, I would say, mechanism that you induce by giving tarlatamab. So will it be frontline with the first cycle of platinum etoposide, atezolizumab or durvalumab? We present data, they present data, tarlatamab at ESMO. I present the same with obrixtamig. I'm leading the phase 1. It's perfectly doable, but is it better with chemo? I'm not so sure. But in maintenance, 100% convinced. So everything is moving up, right? So you have platinum etoposide checkpoint, tarlatamab immediately or in maintenance. So of course, IMforte is a transient opportunity. It will exist for 3 years. And then we'll have to shape the second line. And then the ADCs, there are 8 phase 3 trials in second line with ADC, B7H3, DLL3, C6, and TROP2. So will they also go into a higher maintenance? I'm not convinced neither, giving an ADC in maintenance, like you said, right? It's a bit tough and a bit early second line. So I think tarlatamab will move up, and then we'll have lots of second line options.
Okay, good.
I have a question for Dr. Peters. One highlight in your presentation is about immunotherapy have brain metastasis efficacy, no longer restricted to the PD-1. And you made the point that we can learn from our melanoma colleagues. So I want to hear your opinion on, we have a lot of bispecific entering the clinic. Do you think that will be an area that we need to either stratify or design trials? Do you think in lung cancer we'll also see promising efficacy just like melanoma?
So to answer to that, first of all, yes, absolutely. I think we need, and it's going to always be subgroups, but the more they're stratified, the more you create evidence. For example, for the BNT 327, we stratify for brain mets untreated, of course, yes or no, because you'd like to obtain these ideas that maybe, and we believe in that, the VEGF pathway also has some sense to inhibit in the brain, old days French data, and we'd like to see if you can improve something. We think better than CTLA-4, I don't know. But we need to increase our knowledge about brain metastatic treatment. The main problem we'll have, if at the end it will always be a little bit subjective, because, for example, you've seen the NIVO-EP brain study presented recently at the World Lung. People found it disappointing because the response rate in the brain was 40+%, but the PFS only 6 months. Right, in 227, 9LA, you expect 7 months of PFS. But nobody knows what a subgroup of initial brain metastatic non-small cell lung cancer patients, how they perform under whichever regimen. So the problem is whatever you do, you don't have the comparator baseline to tell that is the expected PFS, OS, and so on. So whatever you do, you should imagine to randomize brain metastatic patients, and no pharma industry wants to do that. Maybe some academic groups. So I mean, it's going to be this data cumulative, but I would give a big attention, a large attention to this VEGF PD-1 because of their mechanistic potential opportunities in the brain. We have passed the time it was forbidden to give VEGF inhibitors in brain metastasis, because it's interesting. When Pfizer started to develop their drug and BioNTech, I saw the second life of this old days exclusion criteria, brain mets, tumor abutting large vessel, central tumor. What does it mean? You exclude all your squamous patients, right? So what I mean, at some point, we will need to think about addressing these tumors.
And interestingly, those drugs are also being explored in small cell, where we see, of course, a very high incidence of brain metastases. And I think hopefully we'll get some data there as well.
Just to clarify, going back into the choice of immunotherapy in the first line, as we have so many options and more coming through as well. I think for PD-L1 negative, do you agree that probably we should use the combo, including anti-CTLA-4 and avoid monotherapy even with chemotherapy? And the other question is, even for PD-L1 positive ones, if you look into the curves and durability, always the anti-CTLA-4 gives that kind of edge of some durability and the duration of response. So is there any guide where we use mono and combo in PD-L1 positive?
Yeah, so for negatives, I think we're all more or less convinced that it's very difficult to treat these negative PD-L1 tumors. Whatever you do, chemo, IO, whatever checkpoint you choose, you have a very marginal benefit. I wouldn't say none because we have some data, but very marginal. So you need a CTLA-4. So 227 data have been, I would say, kind of not leading to registration, for example, at EMA level, because it's right, I was in the trial, the endpoint has been changed many times. So in terms of statistics, they still kind of give rise to some suspicion that the data might be taken with caution. I like them when a patient tells, I don't want chemo, doctor, and it happens to me. I'm in Switzerland, our patients no chemo, negative PD-L1, I'm fine to try. But if not, if the patient accepts, I prefer to do 2 cycles of chemo, just because of, two things. This strange first CT scan where you will like to see a progression, to avoid the early progression, the pseudo progression too with inflammatory lesions. So it makes the thing safer. And honestly, with pemetrexed 2 cycles, it's absolutely fine. But so I prefer the 9LA or even the Poseidon, but both are nice regimen. Absolutely convinced for negative PD-L1. I was yesterday in an international meeting, and some people were telling they don't do that because they have seen this Nippon data, the trial, showing lots of deaths related to CTLA-4. Let's be very clear, I don't remember the last death I had on CTLA-4. Maybe when melanoma had 10 mg/kg of EP, and that was very difficult to deal with. But I mean, no, if you know how to handle, it's fine, it's manageable. For positive, it's very discrepant results. I mean, they do not all converge, but altogether, the benefit of CTLA-4 is very limited. It might be existing in STK level in KEAP1, maybe that's what we see, or maybe the brain metastatic patients, but I would probably not use it apart from the exception of these 2 subgroups, STK11, KEAP1, and brain mets. The KRAS mutant, if they don't have STK11, KEAP1, respond very well to pembro. So it's really STK11, KEAP1, and brain mets. For the other subgroups, the benefit is very marginal. And here you have the toxicity connecting.
Just a comment, if I can. If you look at if what you are saying is true, again, we don't have prospective comparison, unfortunately. But when you look at the 5 years, the difference in those PD-L1 0 is not really striking, whether using anti-CTLA-4 or not. I agree there may be a slight push on the curve a little bit early on, but really by 5 years, you are talking about single digits, whether you look at the pembro chemo or the 9LA4. So I'm not sure that's the final answer we're looking for. We need to do better.
Well, the negative PD-L1, you go from 8% to 19%, so it's not so bad. But of course, the Poseidon data are troublesome because you have this squamous subgroup, which is underperforming. So, I mean, this makes that the 5-year survival of Poseidon is not good because this squamous do, and we still haven't understood if it's a gemcitabine background or it's because of just the trial conduct and the smaller subgroup. It's really a mystery for me, and I'm happy if you can explain to me. I don't know why this subgroup is, for the only time in all the trial conducts, underperforming.
And squamous, that's what brings me to my next comment. Squamous cell, high PD-L1, they are mostly smokers. As you mentioned, smoking is a good one. But we know if you don't give chemo, they don't do well at all. So is there different really cancer types here we're talking about between the non-squamous and squamous?
And remember, in the other trials using EP or tremelimumab, the squamous do not differ so much from non-squamous. So that's the only trial where you have this differential by histology. And on the other way around, usually squamous respond quite well to CTLA-4. So the only hypothesis we had was the backbone of chemo, because in that trial there were lots of gemcitabine, which is supposed to create a wonderful immunogenic cell death. If you go to the Gustave Roussy data, but maybe it's not the case. So probably something with the chemo backbone or just spurious data. But I would not be taking squamous differently, apart that Poseidon is really a question mark.
Well, but if you have PD-L1 60%, would you be comfortable giving single agent, what I'm getting at? Because that's this data I'm looked at, that it was disturbing that the progression was quicker if you don't give chemo, even if your PD-L1 is high in squamous.
Well, squamous, non-squamous, if you compile the data of Empower Longo 1, Keynote 24, Keynote 42 in this subgroup, and Empower 110, squamous, non-squamous have the same hazard ratio. So that's fine. But be careful about what we said is about the risk of early detrimental progression.
Right.
In squamous, probably you have way more early death at progression or incapacity of giving a second line in real life. The real life difference because of central tumor. So I would have another word of caution for squamous because of where they localize. Right?
One last question for Dr. Osman, who's part of the panel. So when you look at studies of neoadjuvant and perioperative treatment, almost 20% of the patients won't go for surgery. So what's the reason a patient with good performance status going into this trial would change his mind and don't go into surgery, knowing that only 5% of these patients have progressive disease?
Thank you, great question. I think that question is really more for you than it is for me, because you guys are the ones who deal with these situations. If we delve deep into the trial data, most of these cancellations are either attributed to progression or adverse profile from the administration of the drugs. There's very few patients who would willingly not agree to proceed with surgical therapy. I think the trend psychologically around the world is that the patients want their tumors removed. And in fact, most patients would argue against neoadjuvant treatment, and people want to rush to surgery as soon as possible. And this is where all of us have to work on guiding them into on the right path. To answer your question, to the best of our knowledge, all the trial data, it gets divided into those three categories, either progression or side effects. Does that answer your question?
Maybe I can add something on that. Do you feel like, because you are the surgeon, that our enthusiasm as medical oncologists to enroll in the trials, because we've been seeing so much failure of whatever we're doing, might have pushed 10% of these patients roughly into the trial being marginally resectable or even slightly unresectable, which would mean that at the time of surgery, the oncologist has failed the bet, right? Bet but missed, and potentially the patients or the circumstances made this kind of risky challenge being unsuccessful. That was more my feeling, that we've been so enthusiastic that we have pushed patients who were, let's say, ineligible initially, hoping for the best. And when you reach surgery, then you have to give up, central T4. So that's what you think it's possible, because we were so enthusiastic pushing patients in IO since now 10 years that it might be the reason why.
So I would say the opposite. I mean, the enthusiasm that we are seeing now is very pleasantly refreshing, right? So N2 has been a death sentence for around the world. Anybody hears N2 and everybody looks away that, okay, this guy is going to be gone in a few months, right? So, but now the sentiment has completely changed. These patients are, especially with downstaging and good PAT-CR, patients are living a long time. So we're open to push. So to answer your question, I would say that if it is a team decision, then I think we have to respect it. So if the surgeon, oncologist, and radiation oncologist made that decision together, then I think that's a very viable decision to proceed.
We have the MDT bridge study presented at ESMO, just the feasibility. It's a nice trial of Martin Reck and colleague, AstraZeneca. When you take these patients with marginally resectable, try to convert them to fully resectable, but they also evaluate what happens if not, because what to do. So it's quite interesting to see, because it might completely move the borders of surgery.
Absolutely, absolutely. And then I didn't have enough time, but there's a very nice study done by Mara Antonoff from MD Anderson that looks at our biases. So if you ask a medical oncologist how to treat an N2, if they had N2 disease, how would they want to be treated? Versus if a surgeon had N2 disease, how would they want to be treated? The results are polar opposite. So I do think we need to sit together more to discuss these patients. Thank you.
Well, thank you so much. Thank you so much, Dr. Osman and everybody. It has been a very interesting session, and as always, lung cancer is very, very hot when it comes to immunotherapy across the board. And I think we are witnessing very interesting era of more and more options for our patients and transformation of their outcome. With this, I would say thanks again, and we will close the session.
Okay, so we'll start our satellite symposium. We'll start with one of the best, Dr. 𝗜ļģis Hamza, who's a consultant medical oncologist at Dubai Hospital. She's going to talk to us about the breaking new grounds in hormone receptor positive, HER2 negative early breast cancer. Welcome, Dr. 𝗜ļģis.
Thank you, Dr. Aida, for the nice introduction. Thanks, Professor Hamid, for the invitation, Novartis for allowing me to present the next symposium. Dear colleagues and friends, we're going to talk about the early breast cancer and the breaking news which worth sharing. So to start with, we're talking about the risk of recurrence of hormone receptor positive, HER2 negative early breast cancer, which is the most common type of breast cancer we see in our clinics. So although it's the most common type, and although there have been lots of advances in the treatment, and although the hormonal therapy is the backbone of such patients, yet we can see that there is a huge risk of recurrence for these patients, which will render them from being curative to non-curative treatment. And if we look at these curves, we will find out that this recurrence starts even with the beginning of the treatment. And as you can see, at 3 years, the curves are being increasing with the even with while the patient is under adjuvant therapy, and this can go even up to 20 years. So looking at the subtypes of patients whom we tell them every time that your disease is being curative, we can see that in stage 2 up to 3 years, 12% of our patients. It means like almost 1 patient or 2 patients whom we see in the clinic are going to recur. Stage 3, we're talking about 20%, and this incidence increases and there is nothing to stop it. So these patients, once they become recurrent, this recurrent disease is incurable. And this, although their patients are being put on hormonal therapy, you put tamoxifen, put Femara, put ovarian function suppression, but still this is an unmet need which needs an interference from us. And that's why we have the evolution of CDK4/6. So the CDK4/6 inhibitors over the last 10 years have an established role in the metastatic setting. We have seen it quite well, and it had changed the landscape and being evolved in the first-line setting. But what about the early breast cancer? So lots of trials have been evolving over that. We have seen the PALLAS, the PENELOPE, we have seen the monarchE and the NATALY trial, different lines of patients, whether stage 2, stage 3, advanced stage, whether being post-neoadjuvant like the PENELOPE or being for 2 years like the monarchE, 3 years like the NATALY. All of them have been looking at the risk of recurrence. And if we combine the control arms of these studies, we can find out that the invasive disease-free survival in the control arms of these patients have shown an increased risk of recurrence, even for the trials which did not make it, like the PALLAS at 4 years was 15%, the PENELOPE was 27.6%, the NATALY 16%, and the monarchE was 20%. So what about the PALLAS and the PENELOPE and the palbociclib? As we all know that there was no benefit seen in these patients in the adjuvant setting, so our data is being restricted to the monarchE and to the NATALY trial. So the monarchE was presented in October. This is the OS data. This is the OS data presented in October 2023 by Professor Nadia Herbek. And this is the first trial to show a benefit from adding a CDK4/6 inhibitor to the adjuvant setting. So it was quite a distinct study design. We know quite well that it has 2 cohorts. We're talking mainly about cohort B, and this cohort, 90% of the patients, they looked at quite high risk, not positive, not even all the not positive. They look at not positive high risk patients, which included clinical pathological features having 4 axillary lymph nodes or more, or having 1 to 3 with one at least, which is a grade 3 or a tumor size more than 5 centimeters. All of us know the randomization, 1-to-1, abemaciclib for 2 years or, with the endocrine therapy or endocrine therapy alone. Just small points to be highlighted that they allowed both types of hormonal therapy, tamoxifen or aromatase inhibitor, and they did not specify to have ovarian function suppression. So this trial, the primary endpoint was invasive disease-free survival, and as you can see, it was quite a positive trial which showed the benefit of CDK4/6 inhibitor in such cohort of high-risk patients, and this benefit was taken over the years, up to 5 years, with the delta has increased to 7.6. Distant recurrent-free survival in the intention to treat population again was positive, and at 5 years it was 6.7. Safety findings, what we know with the abemaciclib quite well, which was mainly the GI findings, which is the diarrhea, and this usually happens at the beginning of the cycles, and of course some hematological toxicity and fatigue. But what about the patients who were not included in this trial? There is a group of patients who were not included in the trial. First of all, we have a group of node-positive patients. They were not included in this trial. These node-positive patients who were 1 positive lymph nodes, and they did not have any of the factors of the higher risk. How is this being translated into the real-world setting? So this was published in 2022, one poster, and they looked at the real-world data, looking at the SEER analysis for the patients who were not included in the monarchy. Specifically, stage 2 to 3 not positive were not included. These are more than 30,000 as per the SEER data. These patients still recur, so how can we prevent that? As you can see, these are the node positive, which are not in monarchy. And as you can see, these patients with the survival, up to an 18 months of survival, there had been a risk of recurrence. So this is an unmet need, or actually a gap, which has to be covered by another trial. What about the high-risk node negative, which were not involved in this trial at all? So any data about that? This is a poster presented by Professor Giuseppe just last ASCO. And he was looking at the short-term risk of recurrence in patients of hormone receptor positive, HER2 negative. This was like a meta-analysis looking at the trials of the CDK4/6 inhibitors. And as you can see, the number of the patients were 711, and there were only 2 trials which included these patients. And looking at these patients are going to recur. So what is, how can we cover that? What about Kamel Javari? Again, Kamel Javari presented another poster in the ESMO in 2024, looking at the real-world evidence for these patients who were not involved in the monarchy, and they looked at the incidence of the 3-year and 5-year and 7-year, and you can see that this incidence of patients, there is an incidence of recurrence. So here comes the answer for the question, which was presented in Barcelona 2024, which is the NATALY trial, looking at adjuvant ribociclib plus non-steroidal, not only hormonal therapy, non-steroidal aromatase inhibitors in a wider group of patients, hormone receptor positive, HER2 negative. So the difference here that, first of all, we included a more patients whom we thought that these patients require intensification of treatment. The primary endpoint was invasive disease-free survival. So we included stage 2 and stage 3, any N1, N2, N3, and they included N node if they have a tumor T3 and T4, or if they have a T2 with grade 2 and high genomic risk, or a Ki-67 more than 20%, or grade 3 randomized to non-steroidal aromatase inhibitor with Kisqali, without Kisqali, for 100 milligram, 3 weeks on, 1 week off, a different dose, and for 3 years. So these are the points which are unique. First of all, we're looking at a broader population. Second, a prior endocrine therapy allowed for 1 year prior, and we have a lower ribociclib dose. We have 3 years of ribociclib. Ovarian function suppression was mandatory. This did not allow the use of tamoxifen. It's only non-steroidal aromatase inhibitor. So again, yes, we have the N1 positive older patient. We have the N2 and N3. We have any T3 or T4 regardless of the node. And we have a T2 N node provided they have a grade 3 or grade 2 with a genomic profile high risk or a Ki-67 more than 20%. And yes, there was a reduction, relative risk of reduction over 4 years by 28.5%, as you can see with the addition of Kisqali. 28.5% means quarter of the patient. If I have, for example, 100 patients, we're talking about quarter of them, 2 to 3 patients, you are avoiding the recurrence in these patients. Which group of patients had benefited? All the subgroup analysis had benefited from the addition of 𝗘𝗱𝘂𝗰𝗵. And as you can see, the majority of the invasive disease-free survival in the intention to treat were distant recurrences. And as you can see, the difference between 6.9 and 9.6% for the control arm. There was an increase in the magnitude of invasive disease-free survival. If we look at going into the data of stage 2 and stage 3, there was a benefit with the delta 4.3 for stage 2, 5.9 for stage 3. What about the end node, the big elephant in the room, the end node? There is a benefit of 5% increment at 48 months. And again, in N1 to 3, it was the same increment with increase in the delta. So what about patients who are menopausal or premenopausal or postmenopausal? We have the data from the RIBO, from the MONALEESA 7, the first trial to show an OS benefit in such cohort of patients. Again, in the IDFS, in the premenopausal patients, there was a benefit of 5.3% at 48 months, and in the postmenopausal was 4.6%. There is a consistent efficacy in the premenopausal, as you can see, with a hazard ratio for the patients specifically young, less than 40 years, for the invasive disease-free survival, 6.3%, for the distant disease-free survival, 7%, for the recurrent-free survival, 5.5%. So at 4 years, we have a broader population, whether we look into the subgroup analysis group by group, or whether we look in the whole group population, there was a benefit in the distant disease-free survival by 28.5%. And in the disease recurrent-free survival, we can see in almost 30% improvement in the disease recurrence. So this is like a sum up or a wrap up for the whole trial. We have more than 5,000 patients. We have 44 median invasive disease-free survival follow-up. There is a hazard ratio for the IDFS of 0.7, for the distant disease-free survival 0.7, for the distant recurrent-free survival 0.7. And as we can see, the curves are very nice separating, and they are maintaining the separation up till now. We have a follow-up of 48 months. What about the safety profile? Because we reduce here the dose for a reason. So the safety profile, we can see that we have a very manageable and reversible safety profile. The hematological toxicity, as we know, with the CDK4/6, some data about ALT increment, which is totally reduced. We're talking about grade 1 and grade 2, and whatever the side effects are, they are all laboratory based. This is what about the QT proliferation. As you can see, with the 400 milligram, it went down to 0.2% in comparison to 1.2% for the 600 milligram. What about the lower rates of diarrhea and fatigue? Diarrhea is not the main side effects of 𝗘𝗂𝘂𝗃 in comparison to other CDK4/6, and the fatigue was much reduced with the 400 milligram. Liver enzyme elevation, yes, there have been some sort of liver enzyme elevation, which we have seen actually as per the MONALEESA, yet was much lower and yet was reversible and was not considered like dose interruption or dose stopping. So they were very manageable adverse events. We're talking about the rate of dose adjustment was less than 25%, and the discontinuation was less than 20%. So yes, we included a high risk node negative, we included node positive, and is being present is in the early breast cancer guidelines as per the NCCN and ESMO and ASCO. So what about the use of optimizing the use of CDK4/6 inhibitor? Yes, we have to balance between the safety and tolerability with a goal to reduce the risk of recurrence to avoid converting these patients from a curable disease to a disseminated disease. We know quite well the comparison and the inclusion criteria between both trials. We have a trial with a broader population. We have another trial with a limited population, yet we can see that in the node negative and in the node positive N1 with the lower risk factors, all of them have been involved in the NATALY, and all of them have benefited in the NATALY, reducing the risk of recurrence and more eligible patient, and at the same time, not on the price of toxicity. We have a manageable and reversible safety profile. I finished 6 seconds before the time, on time exactly.
Good afternoon to all. Thank you for staying, and thank you for the society for arranging. This is really very interesting and informative meeting. So my task for today is just to speak again for the symposium of Novartis, and this is about the stage 4 disease of breast cancer. As you all know, that CDK4/6 inhibitors has been changed the practice and the landscape of management of patients with metastatic breast cancer, as well as the early disease, as we heard from Dr. Adina. If you look into the milestone of breast cancer, we see that this was started in the 19th centuries when George Bitson discovered the correlation between the ovaries and the breast cancer, and when he conducted an oophorectomy in a patient with advanced breast cancer, showed some responses. And it took them almost a century before they discovered the receptors, the estrogen receptors, and even tamoxifen, when was produced for all breast cancer. And in 1983, we know that 1983 was approved for those with hormonal positive disease. Then we see that the aromatase inhibitors, followed by the SERD, followed by the mTOR inhibitors, the PARP inhibitors, till 2015, when we had the 3 CDK4/6 inhibitors, where it was a landmark in the management of metastatic breast cancer. If we see the data for tamoxifen followed by aromatase inhibitors, and we see this is a phase 3 trials showing the differences between tamoxifen and aromatase inhibitors in the first-line setting, we see that if we use aromatase inhibitors, we can gain like 3.4 months in the progression-free survival, but this did not really impact in the overall survival. And if you see these meta-analysis for patient between 2003 and 2013, we see that the survival did not really affected by all this improvement, by all these endocrine treatment, although probably the toxicity profile, the management, the progression-free survival involved, but at the end, the median overall survival for those patients with the hormonal positive disease did not really improve. Mainly, we see that the improvement were limited to the HER2 positive, with the significant improvement and impact on the overall survival. But for those who are hormonal positive, all these advances did not really impact on the management till we have the CDK4/6 inhibitors. And we have the data for the second line, and we know these 3 clinical trials for the 3 CDK4/6 inhibitors. Probably the population are different. It is not homogeneous between the two. Some of them, the resistant population higher than the sensitive population, but we see that all of them, they improve the overall survival in a way. You see it that gaining between 7 to 9 months. 2 of these studies reached the statistical significance, and this is the Monarch 2 and the Mona Lisa 3, where it works with a very good improvement in this overall survival. It is not the only progression-free survival to move this drug into the first-line treatment, and we have these 3 main clinical trials in the postmenopausal population, the Paloma, the Mona Lisa, and the Monarch. And we have also the premenopausal, which is the Mona Lisa 7, for those cohort of those population. We see the population is more or less similar in these. It is in the first-line setting. And if you see the primary endpoint, which is the progression-free survival, was significantly impacted with almost double the progression-free survival of those population, and the hazard ratio in the range of 50 to 55, which is very significant in reducing the risk of progression for those patients. And this is also, if you look for the survival, we see the survival for the first time, it is past the border of 5 years. So we achieved the median survival for those patients of 5 years with CDK4/6 inhibitors in the first line setting. And even if you look into the premenopausal, was also significant, and in the Mona Lisa was significant, although there was almost 13-month gain in the Monarch, but did not reach the significant. But this is really a 1-year gain for those patients on CDK4/6 inhibitors. If we see the statistical significance, we see it for the 3 Mona Lisa in the first line setting. We know that Mona Lisa 3, it was a mix between first line and second line, but all of them, when you use it in the first line, we see that we hit the significance of improvement in survival. Monarch T in the second line also reach the significant value. So it is to improve the border of 20% improvement to be statistically significant, and this is why we see all the ribociclib data reach that statistical significance for these. And as we know that the gold standard is overall survival, so whenever we achieve it, this is really evidence-based medicine, and this pushes us almost to use these medication. Again, if we look the baseline characteristic between all these trials, it is almost similar between these trials, although cross-comparison, we should not use it, but it is almost. There was also some talk that probably the sensitivity and the interval between the progression and the completion of the treatment in the adjuvant setting and the progression, whether this is a disease-free interval or intention treatment-free interval or disease-free interval. And if you look, it's almost similar between the Paloma and the Mona Lisa, which is around 17 to 20%. This is the study of Mona Lisa 2 study. You know, all the this is the schema of the trial. Those patients have hormonal positive, HER2 negative disease, no prior therapy for the advanced disease, and they received the neoadjuvant or adjuvant hormonal therapy, including tamoxifen, and the group was 668. They randomized either to aromatase inhibitors versus ribociclib plus letrozole. And if we see the primary endpoint, there was a significant improvement, as we mentioned, with overall survival. It is almost 1 year advantage, and if you look over years, the differences between and the gain of this treatment is almost increasing. So from 5.7 at 4 years to 8.4 to almost 12.2% in 72 months. Again, if we see that this is an exploratory analysis, we know that sometimes de novo, they harbor some of those resistant and can be more difficult to treat in those than those with sensitive relapses. We see also with de novo metastatic disease, the magnitude of benefit, it's still there, and the gain is almost similar to what we see. Again, delaying the subsequent line of therapy, which is chemotherapy, it is very significant, and those patients is almost 1 year delay for treatment. So in summary, we see that all the Mona Lisa trial in the first line setting, it reached the statistical significance. We know the Paloma, whether it's first line or second line, we did not reach, although it is probably limited for certain patients where the safety profile, it is probably more target than the efficacy of the treatment. And we know with the Monarch trial, we have positive data, statistically significant in the second line. We have a magnitude of 1 year, but this did not reach a statistical significance for a reason or another. It's not only this, it is also the quality of life. So adding CDK4/6 inhibitors to the hormonal therapy improve the quality of life, the global health quality of life. Also, the time to progression of pain, more than 10%, was significantly delayed, and the work and the productivity was maintained. So it is not only the efficacy of the treatment, it's also the quality by delaying the symptoms and the deterioration of the symptoms. And this led to the guidelines and the NCCN guidelines. If you see the preferred regimen in the first line setting, to put the ribociclib plus aromatase inhibitors as category 1 because of the statistical significance of these data. And those patients, if they are resistant to the first line setting, you see the fulvestrant ribociclib and fulvestrant abemaciclib is category 1. I think this is a very good news for patients with CDK4/6 inhibitors. So they have a better and almost 1 gain overall survival. It is a breakthrough in the hormonal sensitive or hormonal positive advanced breast cancer. And this will not impact on the quality of life. In fact, it's improved the quality of life, and the safety was maintained. And this is, in general, it is really heightened the bar of any treatment, and we know subsequent line of therapy is really very limited, and most of us, the expectation did not met the expectation because of the shorter duration of response. So by this, I finish my presentation, and thank you very much for listening. I think if we don't have any question, we can move to the other. I think there will be, we did a lot of discussion on these things. Yeah, so I think to move to the.
So I think my talk will be a continuation or a different strategy than what Dr. Hassan Ja'far has demonstrated. I would like to do a deep dive into the SERENA-6 and the ESR1 guided switch treatment strategy in hormone receptor positive, HER2 negative metastatic breast cancer. I'd like to thank AstraZeneca for allowing me to give this talk. So, my disclosures. So there's a huge unmet medical need in hormone receptor positive, HER2 negative advanced breast cancer, and we know that following first-line treatment, efficacy outcomes and even quality of life worsen in subsequent lines of therapy. So as you can see in the left-sided graph is that with no prior CDK4/6 inhibitor, when we do CDK4/6 inhibitor plus endocrine therapy, the median PFS can be up to 28.2 months, if not more. But when we go into the second-line setting, whether we re-challenge with CDK4/6 inhibitor, add targeted therapy to endocrine therapy, or even do endocrine therapy alone, the PFS is shorter, and the patient quality of life tend to be worse, as you can see in the right-sided graph. And the iteration rate following first-line therapy is usually 16.5 to 18.4%. So some real-world studies have also shown an iteration rate again of 16.5 to 18.4%, emphasizing the need for improved treatment continuation strategy. So, for example, in the French study, post-CDK4/6 inhibitor plus AI in the first-line setting, only 25.7% of the patients received second-line therapy, and 16.5% did not end up receiving second-line therapy. And in the German study, post-first-line study, 18.4% did not receive second-line therapy due to progression or other causes as well. So in general, the real-world evidence reveal high discontinuation rate for CDK4/6 inhibitor plus AI, primarily due to disease progression with treatment duration around 16 to 20 months, highlighting the need for more durable therapies. And in a retrospective study that has been conducted in the United States, 50% of patients who discontinued treatment with first-line CDK4/6 inhibitor was by 12 months. So we have a plethora of evidence saying that we need to do better in the first-line setting and stretch the patient and the control of the disease as much as we can in the first-line setting. Now, again, up to 40% of non-responder to endocrine therapy in the second-line setting, and across novel endocrine therapy, mostly with oral SERD, up to 40% again do not respond to second-line, progressing within the first 2 months, as you can see clearly with the crossover early in the Kaplan-Meier curve and the EMERALD, EMBER-3, and the VERITAC-2 study. So although approximately 85% of patients with hormone receptor positive, HER2 negative advanced breast cancer are initially endocrine therapy sensitive, for most this decreases over time, impacting treatment benefit and treatment selection. So endocrine resistance is a key driver to disease progression in patients with ER-positive breast cancer, and that is basically attributed to mutation in ESR1 mutation. This gene basically encodes ER-alpha, which is a well-established mechanism considered to drive resistance to endocrine therapy in up to 40% of patients with ER-positive breast cancer, meaning that approximately 60% of patients develop resistance that is not associated with detectable ESR1 mutation. So approximately 5% of patients will have detectable ESR1 mutation at the time of first-line treatment, but then 40% of patients would have detectable ESR1 mutation after 1 year of first-line treatment. So that's very important to note. And again, the ESR1, once mutated, it basically leads to ligand-independent activation of the estrogen receptor, allowing cancer cells to proliferate in the absence of estrogen, causing resistance to AIs and potentially enhancing metastatic spread. Now, here's a list of the most prevalent ESR1 mutation that we see in the clinic that we detect, and we're able to add medications to improve these patients' outcome, and most commonly it's a D538G mutation. Now, also high levels of ctDNA and or detection of an ESR1 mutation are associated with greater risk of progression compared to low level of ctDNA. or ESR1 wild type. And this has been demonstrated in many studies. So really the point of try to prevent the disease from going from a low-level ctDNA status or ESR wild type to the high-level or ESR1 mutation, regardless of radiographic progression. So camizestrant is one of the next generation oral SERD that has been implicated in ER-dependent resistant, and we're gonna talk more about it. Camizestrant again is a next generation SERD and complete ER antagonist, which was designed to inhibit and degrade mutant as well as wild type estrogen receptor, impeding tumor growth and delaying the emergence of resistant mechanism. So just to highlight that it can work in both ESR1 mutant versus wild, as well as wild type diseases. So again, camizestrant it's a complete ER antagonism and ER degradation to suppress ER signaling, and active against both wild type and most prevalent ESR1 resistant mutation. So really the key home message is just that it can work in both ESR1 wild type or a mutant disease. So we learn also from our experience in PADA-1 and SERENA-2 study. For example, in the PADA-1 study, we know that the overall incidence of approximately 40% of ESR1 mutation before or at progression, but the incidence is uneven over time, and factors associated with more ESR1 mutation, including age, bone metastasis, ER percentage and baseline LDH, and interception of ESR1 mutation before progression disease is easier in metastatic breast cancer with bone mets and low proliferation. So then we can tease out the population that we actually can try to pick this ESR1 mutation before progression and do something about them so they can have longer PFS. And these results, again, may inform how to customize ESR1 mutation monitoring in the first-line setting. Again, in SERENA-2, in a pre-specified analysis, a treatment with CAMI, whether it was 75 or 150 milligram, reduced the level of ESR1 mutation ctDNA to undetectable or near undetectable level, with reductions being seen as early as day 1 of cycle 2, and when compared to fulvestrant. So this basically demonstrates its superiority in this context. So let's do a deep dive into the SERENA-6 study. Basically, the take-home messages from the SERENA-6 study is that switching AI to CAMI with continuation of CDK4/6 inhibitors guided by the emergence of ESR1 mutations during first-line therapy ahead of disease progression significantly improved PFS in patients with hormone receptor-positive, HER2-negative advanced breast cancer. It's the first global registration phase 3 trial that actually looked into the utility of ctDNA monitoring to detect and treat emergent resistant and breast cancer before the radiographic progression, and the finding may have a potential to become the new standard of care for these patients. So again, just to look into the surveillance monitoring pathway that was utilized in SERENA-6 study. So they screened about 3,325 patients, and those patients were on first-line AI plus CDK4/6 inhibitor for more than or equal to 6 months. ESR1 testing was actually done in 3,256 patients and detected in 548 patients, of which 51% had the mutation from the first test, 38% from the second to fifth test, and 11% after more than 5 tests. So they ended up randomizing 315 patients. And patients were tested for ESR in circulating tumor DNA with a companion test of Guardant360 every 2 to 3 months at the time of routine staging scans. And it's worth to mention that the crude estimate of proportion of patients with emergent ESR1 during the study period was about 42%, calculated from the 548 patients with a positive test. So again, they randomized the patient to CAMI plus continuing CDK4/6 inhibitor plus placebo for AI versus AI plus CDK4/6 inhibitor plus placebo for Cami. They stratified the patient according to visceral mets, detection of ESR1 mutation at first test versus at subsequent test, time from initiation of AI plus CDK4/6 inhibitor to randomization, and the type of CDK4/6 inhibitor utilized. The primary endpoint was PFS by investigator assessment, secondary endpoints including PFS2, OS, safety, and patient-reported outcome. So in terms of baseline characteristics, very well balanced between both arms. Median age was about 60s in both arms. Majority of the patient had visceral metastasis at the time of enrollment, and the majority of the patient had positive test at first test done, and majority of the patients were on palbociclib as the CDK4/6 inhibitor utilized. So as you can clearly see that it met its primary endpoint, which is investigator-assessed PFS, with median PFS of 16 for the Cami arm versus 9.2 for the AI arm with adjusted hazard ratio of 0.44. You can clearly see early separation of the curve, and then clear, consistent separation through different time points. Again, at 12 months, you can see that the median PFS is 60% in the Cami or the switch arm versus 33.4% in the AI plus CDK4/6 inhibitor. So it's impressive separation of the curve. So in terms of the pre-specified group analysis, it all favored the switch arm, regardless of the age, menopausal status, disease site, type of CDK4/6 used, and the type of ESR1 mutation, and time of ESR1 mutation detection as well. And in terms of patient-reported outcome or the quality of life, Cami plus CDK4/6 inhibitor delayed time to deterioration in quality of life versus continuing AI plus CDK4/6 inhibitor, and it also delayed the time of deterioration and pain compared with the standard arm. And in terms of subsequent treatment, it's worth to note that in the AI arm, they did not allow crossover to oral SERD, so that's very important to note in there. And you can see that higher number of patients received chemotherapy in the Cami arm versus AI arm, and that's something, I thought it's interesting. We don't know why, but I think with more data, we're gonna try to learn why more patients ended up getting chemotherapy in subsequent line setting in the Cami. But most of the patients went ahead with getting endocrine therapy plus targeted therapy or endocrine therapy monotherapy in both arms. And in terms of safety, it's very well tolerated. Cami is usually very well tolerated with very low rate of treatment discontinuation due to adverse event, as you can see clearly in the safety summary. Now, in terms of adverse event that happened in more than or equal to 10% of patients, you can see neutropenia is the most predominant one, and it seems to be higher in the Cami arm versus AI arm, and probably because they lingered longer on CDK4/6 inhibitor. Now, when they've done the exposure-adjusted incidence rate, you can now see that neutropenia is very similar between both arms, but it's worth to mention that there is a unique side effect with Cami, which is photopsia, which is defined as brief flashes of light in the peripheral vision that basically did not impact the patient's daily activity. In most cases, it did not lead to treatment discontinuation. So to conclude, switching AI to Cami with continuation of CDK4/6 inhibited guided by the emergence of ESR1 mutations during first-line therapy ahead of disease progression significantly improved PFS in patients with hormone receptor-positive, HER2-negative advanced breast cancer. The benefit was consistent across the CDK4/6 inhibitor and clinically relevant subgroups. Cami plus CDK4/6 inhibitor delayed time to deterioration in quality of life versus continuing AI plus CDK4/6 inhibitor, and was well tolerated with very low rate of treatment discontinuation due to adverse event. Again, SERENA-6 is the first global registrational phase 3 study to demonstrate the clinical utility of ctDNA monitoring to detect and treat emerging resistant in breast cancer. So this has led to a publication simultaneously with the presentation at ASCO at New England Journal of Medicine. And right now we do have a possible option to treat a patient with hormone receptor positive, HER2 negative advanced breast cancer. So we all very familiar with this, and we have now plethora of options, but possibly in the future, we may be able also to act on certain mutation before we see radiographic progression, as we saw in the SERENA-6 study, to prolong the patient median PFS and maintain also their quality of life as much as possible. So thank you so much, and I welcome any questions. Is Hassan Ghazal there? Because I'm sure he'll have a couple of questions. Okay, okay. So yeah, we'll move on to the next presentation. It's going to be abemaciclib across breast cancer stages by Dr. 𝗜ጵ, and then we have another talk by Dr. Syed Tarmazi. Thank you.
Assalamu alaikum. Thank you, Dr. Aida, for the introduction, and congratulations to Dr. Hamid for the great meeting, and thanks to Eli Lilly for the invitation. So, as you can see, I'm going to talk about understanding high risk and early breast cancer. And from the different presentations we saw today, we can say that we have come a long way in the management of ER positive, HER2 negative breast cancer, both in the metastatic and in the early setting. And in fact, there's still a long way to go. And we see that despite the introduction of the endocrine therapy in the adjuvant setting for early breast cancer, we still see patients recurring. And recently we have seen the introduction of CDK4/6 inhibitors to be combined with hormonal therapy with some success. So is this an option for every single patient? I would say no, this is for those who are having higher risk for recurrence. And when we talk about the risk, this should be stratified. There are some patients who are having high risk, some other patients are having intermediate, and some other patients are having a lower risk. So we already heard by from Dr. Dina that patients who are having 4 or more positive lymph nodes are having a high risk of recurrence, but also we saw that patients who are having lower number of lymph nodes, talking here about 1 to 3 lymph nodes, they are also at higher risk of recurrence, mainly if they have the tumor size 5 centimeter and above, or if they have the histological grade. You can see that 1 in 3 patients will have recurrence with time within 5 years with endocrine therapy alone. Now, looking at the data in patients who are having 1 to 3 lymph nodes, so as I said, the risk is not the same, and those who are having high-risk features as compared to those without high-risk features, and I already mentioned that it is the tumor size and the grade of the tumor, we see that patients who are having the high-risk features are having a 5-year invasive disease-free survival of 74% as compared to 89%. So huge difference, and 7 out of 10 patients present with 1 to 3 positive lymph nodes. So a lot of work has to be done in order to improve the outcome of our patients and give them the best chance for the cancer not to recur. We heard about the Monarch A study about the use of abemaciclib in high-risk early breast cancer. This is a study which included 2 cohorts of patients. Cohort 1, those are patients with 4 positive lymph nodes and above, or 1 to 3 positive lymph nodes, and at least one of these following factors, either tumor size 5 centimeter and above, or a tumor grade of 3. And there was a second cohort, we'll not talk about it, and this is the patients who are having 1 to 3 positive lymph nodes and Ki-67 more than 20. So these patients were randomized to endocrine therapy, which could have been aromatase inhibitors or tamoxifen, and we'll combine this with abemaciclib, or in this case, they will be just the endocrine therapy alone. The key endpoint is the primary endpoint is the invasive disease-free survival, and secondary endpoints are the distant relapse-free survival, overall survival, and patient-reported outcomes. Looking at the baseline characteristics, and we see that this was well balanced between the experimental arm abemaciclib plus endocrine therapy and the endocrine therapy in terms of the number of the lymph nodes, 1 to 3 lymph nodes, or more than 4 lymph nodes, in terms of the histological grade, and in terms of the pathological tumor size. This was well balanced between both arms of the study. So looking at the invasive disease-free survival, and we see there is separation in the curves between those who had the abemaciclib added to endocrine therapy versus those who had the endocrine therapy alone. And this benefit, this magnitude of benefit continues across the year to the extent that at 5 years, we see that the difference between the abema plus endocrine therapy as compared to endocrine therapy alone, the difference is around 8%, 7.9%. So 83.2% versus 75.3%. And this is with the use of abemaciclib for 2 years, and with a significant hazard ratio 0.67 and reduction in the rate of recurrence by 33%. Looking at the distant relapse-free survival, this is not different from the invasive disease-free survival. Again, at 5 years, we see difference of 7.1, and we see that year after year, this magnitude of benefit gets really larger and larger. If we look at the rate of metastasis or patients who developed metastasis across these years, we see that patients who had endocrine therapy alone, they had almost doubling of the number of metastases as compared to endocrine therapy alone. If you look at the last bars and look at the light blue one, we see 256 metastasis developed in those who had endocrine therapy alone versus 129 for those who had the endocrine therapy plus abemaciclib, reflecting the success with the use of abemaciclib added to endocrine therapy alone. And if we look at both the invasive disease-free survival and distant relapse-free survival in the forest plot, we see that this benefit is there, whether we talk about patients having 1 to 3 positive lymph nodes, 4 to 9 positive lymph nodes, or 10 and higher. If we look at the oncotype DX and see if there's any difference between those who are having the oncotype DX at higher than 25 or lower than 25, there is no benefit. The benefit is there regardless of the oncotype DX, regardless of the recurrence score. And again, if we look at the genomic subgroups, we can see that the benefit is there. We can highlight here 2 issues. One is the mutation in the retinoblastoma and in the BRCA2, but remember, these are small numbers and we cannot derive conclusion from these small numbers. Recently, the data was reported in patients according to their age, more than 40 or lower than 40, and the benefit is there to the same extent, I can say, whether patients are 40 or more in age or 40 or less in the age. And we can see that the magnitude of benefit along the years is almost similar. In case of those who are less than 40, even the benefit is a little bit higher, 9.8 the difference versus 7.5 for those who are more than 40 years in age. And this is also not only for invasive disease-free survival, but also for the distant relapse-free survival. We see the same extent of benefit, even it's a little bit higher when it comes to patients aging 40 and less. we know that our patients might develop side effects and toxicity from the use of treatment, and the way to handle this is to try to adjust the dose according to the symptoms related to side effects when it comes to these patients. And we can see from this that regardless of the dose we are going to, so reducing the dose from 150 to 100 to 50 milligram, the benefit is still there in favor of the abemaciclib plus endocrine therapy. So, which means that we have really to monitor our patients very carefully and not to hesitate at all if they develop toxicity to reduce the dose, because we are sure, according to the studies, that we are going to gain the same benefit from the combination of abemaciclib plus endocrine therapy. With this, I will stop here and I will hand over to my colleague and friend, Dr. Hamad, to continue the second part of the presentation. Thank you.
Thank you very much. So it's a dual act. So let me just carry on from here. So thank you very much, Dr. Trad. Thank you very much, EOS and Lily, to invite me today. So adherence to the treatment, I think, is really important, because we're concerned that some patient may not be able to continue therapy, and because of side effects, they may want to stop the therapy. So it's really important that we educate our patients. How can we improve their adherence? And we look at the data, what happens if we were to reduce the dose. So this is an ad hoc analysis looking at impact of the dose reduction in the adjuvant setting for patients with this high-risk early breast cancer, with Dr. Dia presented. So these are my disclosures. So in this analysis, up to when they looked at the data, up to 43% of patients required a dose reduction, but the problem was identified that 50% discontinued early without having any prior dose reductions. I think that's a worry, so that without dose reduction, 50% stop. So that is something that we need to avoid, because if you dose reduce, only 9% will discontinue therapy as per this analysis. So this was a study design. I'm not going to details of this. We already seen it. So this was the analysis. They looked at relative dose intensity. They divided it into three. Less than 66%, 66 to 93%, and more than 93%, and to compare the efficacy between those three dose intensities. And look at this here clearly. So any patient who required dose reduction was 43%, one dose reduction was 29 to 30%, and two dose reductions in 13%. And what was the main reason for dose reductions? Mainly diarrhea, as we know, 17%, followed by neutropenia and fatigue. So that's what we see in the clinic. So let's look at the outcomes of these patients. So when we look at the data closely, which patients actually ended up having dose reductions or dose interruptions? These are the patients who are elderly, more than 65, and especially those with up to 4 or more comorbidities. So these are the patients that really need to be looked after in the clinic. And hence the likelihood of having a dose reduction is up 55% higher for these patients, and especially if they have more than 4 comorbidities. So this is the outcome. So look at the dose reductions by age. So less than 65 versus more than 65. Higher the age, more than 65, you have higher dose reductions. So and as you have higher number of comorbidities, you have higher dose reductions. So you can identify these patients in the clinic very easily, and then think about the strategy, whether you're going to manage their toxicity, dose reduce early, make sure they adhere to the treatment rather than discontinue the therapy. And what about these patients when they have 1 or 2 dose reductions? Actually, they completed the first 6 months. So if you dose reduce, you complete the first 6 months, means adherence to the therapy is better. However, if you did not dose reduce, your adherence was worse. So it's actually okay to dose reduce. It's actually okay for them to continue the therapy rather than discontinue the therapy because of the side effects. And let's look at the outcomes between the different dose intensities. You reduce the dose. Are you worried about the outcomes? No. Between 3 dose relative dose intensity, you look at the outcomes exactly similar. So there is no reduction in the risk for these patients when you dose reduce. So that's the message from this data. And regardless of the age, region, performance status, menopausal status, you see very similar outcome for all of those subgroups which are reported clinically. When we look at the IDFS and DRFS, again, very similar to your outcome, regardless of the dose, 150, 100, or 50. Okay, so let's move on to a short case. So this lady, 54, had a breast cancer, which was heavily node positive, very high risk disease, had mastectomy, surgery, adjuvant chemoradiotherapy, and then she had hormone and then switched to AI. Almost she was coming to the end of her adjuvant therapy when she presented with back pain in November 2021, shortness of breath, large pleural effusion on the chest X-ray, and MRI of the spine unfortunately showed she had metastatic bone disease. And this is a PET scan, as you can see, extensive lung disease, bone metastasis, and liver metastasis. Really, this lady had secondary hormone. Okay, so we drained the fluid from her chest, and it turned out to be same breast cancer, unfortunately, which is ER positive, HER2 equivocal, but FISH was negative. So same biology as she had before. So I commenced her on Faslodex along with the abemaciclib. She had a good tolerance, some on and off fatigue, however, no recurrence of the pleural effusion after we drained initially, and her back pain improved. She was on a lot of morphine, and that requirement quickly decreased. And this is her scan shortly after. You can see a significant improvement. On the follow-up, she had some lung nodules. She had come back from Umrah. She had some cold and flu. I thought this just could be an infection, and so we did not change the therapy. She continued the same therapy. She had anemia, MCV is high. We investigated, nothing remarkable. This is her last PET scan. She remains in remission. So that's a really good outcome for that patient with hormone refractory disease. Okay, so coming to patients with endocrine resistance, I'll just present briefly for you the Monarch 2 study. So we are aware of this study just for to go through the data again, as we have with other studies as well. So these are the patients who are endocrine resistance, either relapsed or within the 1 year of adjuvant therapy, randomized to receive Verzenio plus fulvestrant versus fulvestrant alone, and the primary endpoint was progression-free survival. And clearly positive results, reminding you again with hazard ratio 0.53, significantly in favor of the investigational drug. And the overall survival, obviously, very significantly better. Hazard ratio 0.78, statistically significant. So clearly, abemaciclib works in patients with hormone refractory disease. This is the exploratory analysis in intention to treat population. Again, very positive. Look at the numbers 50 versus 22 months in terms of event-free survival. What about patients with endocrine sensitive disease? So across the spectrum of our patients that we treat. Again, Monarch 3 study, as you're well aware, these are patients with recurrent disease with no prior systemic therapy. And if any endocrine therapy was administered neoadjuvant, it should have been at least more than 12 months. Again, these patients were randomized to abema versus anastrozole versus anastrozole. And the primary endpoint here is progression-free survival, and the key secondary endpoint is overall survival. And these are the results. To refresh our memories, this is the updated PFS outcomes, very clear delta, 14.5 months almost in favor of the abemaciclib for these patients with endocrine sensitive disease. And we also saw similar outcomes in terms of overall survival. Although the p-value here is not significant, but numerically very significant improvement in overall survival, 13 months again. So clearly these patients are living longer and better. And these are the final overall results, again confirming the initial analysis that these patients are living longer. So with this, I will conclude my presentation, and thank you very much for your attention. Let me now invite Dr. Hussam Marashi, Consultant Medical College from Tawam Hospital. He'll be talking about checkpoint inhibitors management in non-small cell lung cancer. Dr. Marashi.
Good afternoon, all. And I'm so glad to be here. Thanks for being here. I know it's coming late. All I'm going to say is that my presentation is much easier because all the work has been discussed earlier on. I really enjoyed it, and I thought I don't have to say much, and you will believe me now. My presentation is very simple. It's about where we are in terms of using immunotherapy in the early lung cancer. And I hope we cover a number of points. We do the summary in the end, and I'm very happy to hear the feedback. Unfortunately, the international speaker is not here in the room. These are my disclosure. It's sponsored by MSD. The problem of lung cancer, the magnitude of the problem is massive. I'm fully aware that all you are aware of it, really. I come from the UK. Believe me, the UK, the lung cancer is pandemic, and its magnitude of what we call the disaster we're dealing with lung cancer is much more obvious than the Emirates. So in a way, that was a pleasant surprise to know that lung cancer is not a major one. Having said that, now all Europe, almost all Europe, have a big issue with smoking. So hopefully the numbers will go down. And I will say, like everything else, the outcome or the improvement in the outcome in lung cancer is not going to be better just by presenting data. Is about every single member in our MDT has to do better. And it's not just us. I think the surgeon did very well in terms of talking about doing the surgery really after a new adjuvant treatment. What's the point of having perioperative treatment if there was no operation or if someone have a bad complication? So every single member of the MDT has to do better, as you're aware. And as you know, going to the data, if we don't move into the staging, what we call make the staging earlier, these numbers on the screen are not going to be better. I'm so delighted, maybe Dr. Ed Black, one of the surgeons here, informed me that the screening program in the Emirate has started, and hopefully that will improve the outcome clearly, because people presenting with a stage, as you can see, stage 3A, they're going to have a worse outcome whatever we do. So surveillance is quite good. This is the sad story I have to do my training through. If you look at meta-analysis 2016, they have really to squeeze every single data coming out on the adjuvant chemotherapy. So that's what we used to have. We used to wait the patient coming out, and we have to tell him what we have is chemotherapy. And we will tell him 95, if you look at those above the yellow line and those below the blue line did not benefit whatsoever. So the number of treats to benefit was really sad. And thankfully we moved on. And the cut down for the discussion, so what we call the division is divided between the adjuvant, the new adjuvant, and then the perioperative. And you know already that the practice has changed. It took a long time for these approval to go from here into the second line to things to improve. And that's what will tell me that it's coming early and early. And what will tell me is that the immune checkpoint is doing the trick. It's about biology. It's not about, so you bring the treatment early, you're going to see the benefits. And you will see the data. I hope we'll have eventually no patients coming to metastatic disease. As I said, there's 3 groups, the adjuvant, the new adjuvant. Bear with me, I'm really sorry. I know the data presented, there's a lot of details, but I'll try to summarize it as much as I can, as quick as I can, and then we'll go to the details. Okay, so Empower 010, atezolizumab, I think it's a good study. Put all, anyone who have complete resected, anything from what we call the staging 7, 1B into 3 resection, then let's give them any chemotherapy. Choose whatever you want, including carboplatin, and give them atezolizumab. And of course, the end point was DFS. And just looking at this, the study, it was positive in some way. So if you have the TC signal more than 50%, you can see on the forest plot that is going to the left, and that is significantly positive. But the message here is that this is not going to work for those who are PD-L1 negative. So remember this. We came to the next one, 091. You would think this is even braver because the chemotherapy was optional. You have to give pembrolizumab after any resection, again, stage 1B to stage 3A. And it was, again, a positive study in terms of the outcome. If you look at the disease-free survival, there was a good positive signal. The improvement hazard ratio 0.76. But what was bizarre and what we learned is on the right-hand side is those who have PD-L1 more than 50 is negative. So I don't know what's going on. They didn't know what's going on, but because the whole set of statistics, ITT and what we call the good design of the study, the approval came along for the study. And that's famous to me, that when I did my training again, or what we learning, this is a famous slide from Georgie Raymond about what we have available. So the Americans, both the European approved the Empower 10 and the Keynote 091. The European always a little bit more looking into the details, only approve it for more than 50%, but the Empower 091, it's for all comers. Of course, because I mentioned the chemotherapy was optional, when they looked at the data, they insisted to have chemotherapy. The European was just very, what we call, worthy. The BR31 did not follow on. I don't want to go into details, but this did not have registration approval. We don't practice it. So that's a little bit confusing in a way, but at least we have access to it in case someone went to have, for example, the surgery up front. So what happened to the neoadjuvant? I think so many speakers came out and said the neoadjuvant, any neoadjuvant immunotherapy, it makes sense. Priming the tumor, reducing micrometastasis, it's better, for sure, you have better tolerability. Believe me, there's nothing more difficult in our clinic is that someone coming out of the clinic, missing a lobe, missing lumpectomy, and you have to tell them you are just about to start chemotherapy and immunotherapy, and you will have to hide half of what we call the consent information, because you need to have really big motivation about it. So the new adjuvant is always easier to sell. I know there is a lot of people, including the patient, want to move on with surgery as quick as possible. The surgeon wants to move on with surgery as soon as possible. And that is one minor effect, is that any study is going to show here, we need to remember the people that has progressed. And if there is one number that jumped into my head, I need to remember with the new adjuvant immunotherapy will be 1 out of 5, unfortunately, as a biology, that they will be inoperable. So that's just worth remembering it. But when I go through is just look at the primary endpoint. What is the main objective here? Because I think there's one have the what we call the advantage on the other. So the 816 is a brilliant study, came out and said we were going to give 3 cycles of chemotherapy. We're going to have as you can see, we're going to have nivolumab as well coming out. The new adjuvant also was looking at the TNM7 at the time. So 1B to 3A, and allowed to give as I said, 3 cycles with chemotherapy, and then you complete it as to the surgery. So there's nothing after that. That's very clear. And the objective, the primary endpoint was it's a what we call co-primary endpoint, the event-free survival and the PCR. Yep. It's quite, you need to know that it's really balanced. You need to make sure that there's no one have more nodal than the other. It's allowed both cisplatin and carboplatin. I think at that point, I don't have any preference between cisplatin and carboplatin, but the study allowed both. To me, it's surprising you have more or far more cisplatin than what we wanted to do, but that's what we were practicing at the time. And the first what we call signals coming out from the trial is that you have pathological complete response. That's quite impressive, 24%. So in a way, I think that's now changed completely the paradigm now into what it's worth giving something beforehand. And the event-free survival, as you can see, is quite significant. It's more than doubled in a way from 21 months from what we call the control arm into 59 months. So that is good. The hazard ratio is impressive as well. And in terms of the final analysis, it just came out positive. So you can see the current the hazard ratio 0.72. The confirmed interval, the CI is up to just less than 1%. But again, that was what we call proof of principles. That's the new adjuvant is there, and we are very delighted to see it, and that has changed the practice in a way. You might, some people will say, of course, you can see even with more chemotherapy and more treatment coming after the new adjuvant treatment of the control arm, but I don't think that will change my mind, is that if you have nothing else to do, I think the new adjuvant is the way to go. If you're looking at the forest plot, it's raised, it's not about this study alone, but it's raised the principle about where's the PD-L1 negative in terms of new adjuvant treatment, how much benefit will driving from this. But I think in general, it's positive for all comers. And the paradigm keeps moving, because I think we clearly, still the question is not answered. Some of things has improved, but still the outcome has to be better, and that has led to preoperative what we call trials. I'm afraid, and I'm sorry to say, I'm not going to include some of the what we call the studies done in China, because unfortunately they will not have approval in Europe. That's to me, but it's worth still talking about the others, as you're aware of. And the CheckMate 77T is all what I mentioned about 816, a little bit few changes, is that we're going to give 4 cycles of chemotherapy, and then we're going to back it up with adjuvant treatment for 1 year. EFS, again, the same point, and event-free survival. So to me, I thought, well, let's look at these groups, because we're going to give preoperative. Is it the same balance? Yes, it was balanced. Are there people that are negative in PD-L1? It was included, and even the N2. I think most of the patients will talk about the operative. The N2 was well represented in this study. And again, cisplatin and carboplatin involved. The PCR hasn't changed. It's like the 816, but again, it's reassuring that whatever there has been translated the same to us. And that is worth thinking about, is that some patient, or what we call quarter of the patient, they will have no residual disease. Then it was worth to look at these subgroups, who have residual disease, who has not. So EFS, it looks very similar to the previous one. Hopefully convinced you that the same trend you see in 816, again, it's interesting, it's positive, it's reassuring, hazard ratio 0.61. So again, that looks like we are expecting a very hopefully good result from this study. The event-free survival is impressive. Again, more noticeable benefit for PD-L1 positive. But still there's expecting overall. This has raised another question. It was good to know or to see what happened to those who have less than PCR. Someone have residual disease. So the 816 did not address it, but I think in a way that will say if someone have residual disease, it's crucial and it's must to go for adjuvant phase. And then see the separation in these what we call these two groups, and those you look at the bottom of the 2 lines was great. So that question was answered very clearly. But that again raised the question is what happened to those who have just achieved that PCR? If I show you PCR 25%, so what's the benefit from it? So that's something for us to address in the clinic. And the overall survival, there might be trends, it's not mature enough, we will see. Leave it at there, and that is to me, or the main point is 671. 671, if you think about it, is the same principle, is about using perioperative immunotherapy, using the pembrolizumab. The mandated cisplatin, carboplatin was not allowed, and again, you complete adjuvant for 1 year. I think what was brave about the study, and I hope you agree with me, is that the overall survival was upfront as a primary endpoint, which means in terms of number of events, I thought initially it may take a longer time to be published, or to be presented, although this was done a little bit earlier. But I thought that was courageous for the study. You can see its overall survival, but again, EFS is its co-primary endpoint, and the other are secondary endpoints. This study, again, is not short from any other study. They look at those who N2 disease, with the concern that if I know that all the studies answer this, but if someone has progressed on new adjuvant treatment, will be in trouble in terms of OS. So again, I thought that was courageous, because if people dropping off, that will affect the study badly. But we know that it's going to be positive from the metastatic data in a way. And that's the EFS, again, a very clear signal, hazard ratio 0.59, and the pathological complete response, the signal is there. It's anything from neoadjuvant you expect to be between the 15 to 25%, but the signal is there. And all what we call subgroups were well balanced. As I don't need to be a statistician to see all the green lights moving to the left of the what we call the line 1. When these studies come out, we have to make sure that the surgery is balanced. We have to make sure there's not a lot of people dropping out because of the because of immunotherapy. So you can see the number of R0 resection has increased, and those who complete the study has increased. And again, you want to make sure that no extra people having pneumonectomy. So you don't want to have, because of better surgery, they will have a better outcome. It's actually there. So it's balanced. If anything, the pneumonectomy is slightly less in that arm. And that what we call in all different groups, you can see it's well balanced, and we have what we call that's the difference. That's the summary and points what we want to say from the key what we call this the 671. If we looked at the NIVO study earlier, look at the one here in terms of the Pembro. Again, the same signal is that those who did not achieve PCR, they will have great benefit from continuing with immunotherapy or immune checkpoint in adjuvant setting. And possibly that signal possibly still a little bit better for those who have PCR. And to me, if I move on because of the time, to me, as I said, the main point of all this discussion is that our patient will live longer. I know event-free survival, it's meaningful, but if the study doesn't show that these people will live longer, even within that shorter time of the follow-up, it's not there. And to me, the number of events was positive, and even if the extended what we call the follow-up and the median follow-up of 40 months, the separation overall survival is quite noticeable. And doesn't matter if the node is the node 0 or not, that signal, that's what I'm talking about, is still there. In terms of, I think that's been raised earlier, the never smoker, other than that, everything else was there. The Pembro study 671, they were allowed to have a little bit of EGFR at the time, but you look at the numbers, 15 patients, so it's very small. I cannot draw any conclusion from this, but everything else in terms of OS, it's positive. So that's the message we want all to talk about. And again, for the side effects time, I think it's all what we know about immunotherapy profile. The agents seem to be promising. It's the same, in a way, same pattern of presentation, allowed both drugs. If anything, I was going to say different, is that this is for higher risk patients. So they have higher risk group of patients. So you expect to have more immunotherapy benefits. And again, that's updated the EFS. And we talked about it earlier today, I think, from the surgical data, our surgical colleague who presented it. It's positive for almost all the group. We're waiting for overall survival for it. I'm not sure what the DFS, this is why they brought it back to the perioperative point, but again, it's good to know that it's there. The overall survival is not mature. So to conclude here, is the question of neoadjuvant or perioperative is there. Thankfully, I think the question is answered. Dr. Peters, Professor Peters was here earlier on. Maybe it would have been better to hear it from her. She's the main author of this paper to compare. And to me, the question about adjuvant treatment or not, in a way, for the 75% of the patients that did not achieve PCR, I think this is deal done. You don't need me to talk about it anymore. For those who have complete PCR, I would say these studies are not designed to answer if the question about the adjuvant. I think there's that study, there are more studies coming out to answer this question. But to me, I think if the patient have no financial toxicity, no real toxicity from the treatment, is no brainer to continue with a perioperative treatment. Yeah, that's what we talked about. Now, the next question, what we do with PD-L1. Dr. Hussam just repeated the message you heard 3 million times, is that, you know, there are some signals it's not as effective as before. Thankfully, this meta-analysis, the one in JAMA, the one that present ESMO Open, everything suggested that if you put everyone together, even for that particular 2 studies, there is a signal for perioperative treatment. So maybe the 8-116 is not everyone. And I believe that's Dr. Peter said she's happy to share the slide. I think this is circulated in so many meetings I attended, and it's in ESMO, what we call the Oncology Pro education session. If you look at the comparison of all these studies, I would say it's brilliant. We have, thankfully, we live in this era. But to me, as I said, when you look at study, we push for overall survival as a primary endpoint. Believe me, this is very clear messages. And that is one good thing for the 671. So I've covered a lot, and I know I'm running time is up some time ago. The last question is, there is any patient still benefit from neoadjuvant treatment? There is possibly, but I said for only to exclude them from perioperative treatment, for my opinion, it's worth considering it for all comers. And the bottom line is, we don't do horrific treatment. It's not downstaging. If the surgeon from the start saying, I'm not going to operate, I think to me it's better to go for primary chemoradiotherapy followed by adjuvant immunotherapy. There's a lot of data. Apologies for running over time, but thank you so much for listening. Thank you. I think we're ready to move. Yeah. So let me introduce Dr. Roto, who joined us earlier today with a lovely debate. But simply, she will talk about the advances in the EGFR, what we call mutated non-small cell lung cancer. So please welcome Dr. Roto. Thank you.
Thank you. Now, I know you just heard me, if you're at the debate earlier, speak on the subject of first-line EGFR lung cancer, but of course, that was in a debate where I was tied to one opinion, which was monotherapy was the way to go. But here I have free latitude to simply talk about first-line treatment selection. So I'll try to take us through the data a little more broadly in this space, talk about what it might mean when deciding among therapies for patients. And I know on the agenda, we have a talk right after this on the Mariposa trial, so I will slide past some of the Mariposa data in my slides a little more quickly just to make space for that presentation as well. So without further ado, thank you again for having me back here to speak about this. So first-line treatment selection in EGFR lung cancer. And we keep talking about this, here's my disclosures, of course, because it's become complicated. So I'm going to start with a hypothetical patient case to set the stage. So if you're seeing this patient in clinic, 45-year-old woman, no history of tobacco use, she has metastatic EGFR L858R mutated lung adenocarcinoma. She has multifocal metastatic lesions in the bones, liver, bilateral lungs. She has no CNS metastases, and she's generally feeling well. She has a mild persistent cough and fatigue, but mostly doing her usual activities. And I would ask you, what would you recommend to her as her first-line therapy? Of course, that might be a reasonable, straightforward answer, but I'll add some additional wrinkles on this. What if she had brain metastases? What if she actually had an EGFR exon 19 deletion? What if she was 75 years old with an ECOG PS of 0 or a PS of 2? What if she was a 75-year-old athlete? And what if the disease was limited to just a pleural effusion as her only site of distant disease? These are all different permutations on, I think, a familiar case that all impact how we think about what we recommend to our patients when they ask us, well, what do you recommend that I do? I think that's the most common answer I get after going through all this data. They ask me, what do you recommend that I do? So without that stage, first I'll ask, what was her probability of having an EGFR mutation at diagnosis? This is a 40-something-year-old, never smoking woman. Of course, the chances were very, very high. So if you look at this nice series on the left by age, you can see almost 30% of patients who are in the age 40 to 50 have an EGFR mutation if you profile them. And on the right, for patients with no history of tobacco use, about half will have a mutation. And this just emphasizes how critical a really thoughtful approach and careful approach to getting appropriate biomarker testing in all of these patients is, because they have really striking high rates of actionable drivers if you go looking for them. I'll ask also, what was her survival like? We can ask, what would it have been like 15 years ago before advances in personalized targeted therapy? The answer is PFS on platinum doublet was about 6 months, and past there, we know the PFS on single agent chemotherapy subsequently is very low indeed, in a few month range for things like docetaxel. That's really changed, of course, with the advent of EGFR as a biomarker, going from survival rates around 9 months with first generation TKIs, about 1.5 years with third generation TKIs like osimertinib, and with combinations now reaching past 2 years. Of course, we hope to continue to improve upon that as the field continues to move forward with novel therapeutics. So we're glad we've moved here from the start of this arrow to the far side of this arrow with modern treatment modalities. So weighing first-line treatment options. And here I will acknowledge, of course, there are the 3 strategies we've been talking about: Mariposa, amivantamab plus lazertinib; FLAURA2, osimertinib plus platinum doublet; and FLAURA, osimertinib monotherapy. This has led to a paradigm of risk stratification where we tend to offer combination regimens in patients with higher risk disease and more likely to offer monotherapy with low risk disease. Though, contrary to my discussion earlier today, I'll make some points where I would suggest that even some low-risk patients, really as a default, if they're fit and healthy, should be given a combination and should be encouraged to consider a combination in light of all this recent data. All right, so first, why did we use osimertinib? We've been using this frontline since 2018. At least I'm going to cite US timelines here because they're the ones that I'm most familiar with. So I apologize if they're a little bit off. But this was based on improvement in progression-free survival and overall survival compared to early generation TKIs. This also went along with better CNS activity and a better toxicity profile. So this transition from later line to frontline was really easy and happened very quickly upon availability of this agent with its new approvals in that setting. But of course, now we have subsequent combination regimens in the frontline setting. We're looking at not just better efficacy, but also more challenging toxicity. And that's what's underlined how complicated this conversation has been. So we'll spend some time on the FLAURA2 data here, looking at it in a little more detail than I had time to cover earlier this morning. So FLAURA2 may be a very familiar study to you by now, but to summarize, this was patients with advanced metastatic lung cancer with one of the classical activating mutations. Patients could have stable CNS metastases and were randomized to osimertinib as their control arm or osimertinib plus the platinum pemetrexed doublet. And here the design was the 4 cycles of platinum doublet, followed by indefinite maintenance pemetrexed along with the osimertinib until disease progression or toxicity. And I will highlight that indefinite maintenance piece because we'll talk about it in a moment. Your primary endpoint was progression-free survival. This is the PFS data. This is now old data from end of 2023, but of course, you saw improvements in progression-free survival about 8 months with the upfront integration of chemotherapy, replicated across really all subgroups which were assessed. And this is why we began using this regimen in many settings, even as far back to 2023, before we had survival data. I will highlight the forest plot at the bottom there, CNS metastases, because when we think about integrating more complicated upfront therapies, we're thinking about either subgroups who benefit more, subgroups who benefit less. We've talked a lot about this. And here I will highlight CNS metastases as a population who seem to be deriving particular benefit from early integration of chemotherapy. You can see that there in their hazard ratio, which trends more favorably. I can pull out those Kaplan-Meier plots, looking at on the left there, patients with CNS involvement at baseline. On the right, those without. You can see patients with CNS disease are deriving almost a 1-year advantage in outcomes compared to those who get osimertinib alone. This likely reflects CNS activity, both of TKI and of platinum doublet chemotherapy. Now, there was still an advantage, at least a trend towards advantage in patients without CNS involvement of about 6 months, though it was a little more modest. You can also look at CNS responses by depth of response. This is one that's compelling, where you can see that there was a higher CNS response rate and better CNS depth of response with upfront combination therapy. And this matters in a setting where these patients have high rates of CNS involvement at baseline, and you're often deferring local ablative therapy like radiation, relying upon systemic activity. And the stakes are very high if patients experience a disease progression within the CNS while awaiting this sorts of upfront initial scan assessment. So I think these sorts of response rates matter when thinking about CNS disease. This was the new data from World Lung from just a few weeks ago now. So we have finally the FLAURA2 overall survival data available. And this showed, as you probably heard, improved overall survival with the osimertinib chemotherapy combination compared to osimertinib alone, with an overall survival gain of approximately 10 months. And this, again, is important. We're asking patients to add therapy up front rather than sequencing therapy. So we want patients not just to delay progression, but actually to live longer. And we saw that here in the OS data. All right, so we're talking about delaying therapy versus upfront therapy. Of course, then it matters, are you giving it sequentially? Really want to test OC plus chemo versus OC followed by chemo, not just versus OC alone. And I'll highlight the blue chart, which are the outcomes in the control arm for first subsequent therapy. There was no crossover on this study. This is all just per investigator choice off trial. You can see, as I mentioned before, about a quarter of patients don't get any second-line therapy at all. I think that, again, is replicated across multiple different frontline EGFR studies. I've always found that number very sobering because I'd like to think my patients do better and get more second-line therapy than that, but it comes up again and again and again in trials. I think we tend to forget how often patients don't go on. And of patients who got second-line therapy, about 3/4, 72%, did get platinum doublet as their next line therapy. It's standard of care generally globally. It's available in most places and therefore makes sense. And most patients would have received this. And it makes the overall survival data more powerful because you're looking at upfront chemo versus sequencing chemo. And that's really the question we want to ask here. All right, toxicities. I'm not going to spend a lot of time on these because I think we're all very familiar with carboplatin pemetrexed toxicity profile. It was greatest in the first 3 months during the period of carboplatin induction, and then was less so in terms of onset of toxicity during maintenance. And this was consistent with, I think, prior data with these sort of treatment regimens. Now, interesting data, this is new from World Lung as well. I would ask the question, I mentioned before, the plan was for indefinite maintenance therapy, but what did patients actually receive on treatment? What was feasible? And the answer is that almost all patients got their 4 cycles of carboplatin. You can see that purple bar there. If you look at the pemetrexed maintenance, patients on average got only 8.3 months of pemetrexed maintenance compared to 30.5 months of osimertinib maintenance or duration of exposure on the combination arm. So that suggests, one, that maintenance pemetrexed is harder than we think because even in a clinical trial and a fit population, a lot of patients dropped off therapy, though it was in a setting of not knowing whether this is going to lead to improved survival. And two, it also suggests that many patients will have a prolonged chemotherapy-free period, even with upfront chemotherapy, where they're on TKI maintenance alone. Right, mechanism of acquired resistance. This comes up a lot as well. When you give chemo up front, does it change the resistance profile? What's happening? The answer is here that the resistance profile as measured by plasma was really very similar between osimertinib alone or osimertinib plus chemo, with the same spectrum of resistance mutations that we expect to see for this patient population, including EGFR second site mutations, metrophin resistance, and others. We don't yet know about histologic transformation, but at least there was not a higher rate of things like RB1 loss in the plasma. I'm going to spend a few minutes on Mariposa, but you have a whole other talk on Mariposa, so I'm not going to steal our next speaker's thunder, though I apologize for a few overlapping slides, but I do think it's important to talk about in the context of frontline therapy. So Mariposa, this is also now likely familiar to you, very same patient population, classical EGFR mutated lung cancer, 3 arms, amivantamab plus lazertinib versus osimertinib versus lazertinib alone. Now all the statistical endpoints are powered to the amivantamab lazertinib versus osimertinib. Lazertinib is just there for contribution of components. This was the PFS numbers, again, about an 8-month gain in progression-free survival with an upfront combination. And again, this was sustained across patients with various high-risk features here. The ones that were pre-specified are shown on this forest plot. And we already have the overall survival as well. This came out almost a year ago in March of 2025. Again, with upfront combination, better overall survival. Here, hazard ratio of 0.75. If you give more intensive upfront therapy in EGFR mutant lung cancer, here the median difference is not yet known because it's not yet reached on the combination arm, but it's predicted to be about a year. Now I will highlight first subsequent therapy because I think this is a difference between the trials, which is important. So again, very similar rates of patients got next line therapy, 75%. If you look in the control arm, when the study was run, amivantamab was not available as a standard second line regimen in the various sites where the trials were run, and therefore getting amivantamab was very unlikely. Approximately 1% or so of patients on the control arm got this as a next line therapy. So I do think that this study does look primarily at amivantamab first versus amivantamab never, which is a limitation. I will be fair and say that MARIPOSA-2, there's not a significant overall survival advantage developing in those curves. So I don't know if this can be made up in a later line setting, but we don't have the data here in the frontline setting. I'm going to skip resistance because I believe our next speaker is going to talk about resistance mechanisms, but I'll simply say that there was indeed less MET and EGFR-driven resistance on the amivantamab regimen, which makes sense given the mechanism of action of the drugs. It's sort of doing what we expect it to do genomically. Right, safety profiles, I think this is important to talk about because we know that amivantamab does have a more complex safety profile and requires attention to prophylaxis to administer safely. Most common toxicities are consistent with the mechanism of action, including EGFR wild-type toxicities like paronychia or skin rash, peripheral edema related to MET inhibition, and infusion reactions, which happen in about 2/3 of patients, most on cycle 1, most allowing for rechallenge, but still I think requiring attention to education both for clinic staff and patients to navigate successfully. And I will mention a higher rate of VTE as well, which came out in the combination on the clinical trial, resulting in a requirement for anticoagulation prophylaxis in the initial months of therapy. So prophylaxis, I think this is a good slide. I like this figure. It's from the ELCC presentation of this data. It highlights a few things. One, there is an enhanced dexamethasone prophylactic regimen, which can reduce rates of, but not eliminate infusion-related reactions. And there is enhanced dermatologic prophylaxis, which can be done to help to reduce some of the cutaneous toxicities like skin and scalp rash, though not fully eliminate them. But it is really important if you're going to use this regimen to treat patients with all appropriate prophylactic mediators so that they can have the best outcomes possible if they're going to be on therapy. All right, I will highlight the subcutaneous data. We talked about infusion reactions. I think this is also important. I think this is likely going to be coming in the near future. It's already available in Europe. And you can see this does reduce rates of infusion reactions, which is certainly nice for both our patients and clinicians if they're going to be using this regimen, but it does not reduce rates of cutaneous toxicity like skin rash, so other prophylactic measures are still required. So sequencing therapy, picking frontline therapy matters, but of course our patients are going to be on therapy for hopefully many lines of treatment. So I need first line, second line, third line, and beyond. And what you choose for frontline certainly impacts what you might use in the second line setting. I've highlighted some thoughts here about how I tend to sequence therapies in these patient populations. So post-FLAURA2, which is what I think where I'm talking about the most here, certainly second line we've been using docetaxel. I think globally that's generally available. I've switched to using Dato-DXd in my own practice after its approval within the United States. But certainly we're also sequencing after osimertinib monotherapy. I think we're now deciding between MARIPOSA-2, which is Ami-platinum doublet, or platinum doublet plus osimertinib on the Compel regimen. And after amivantamab lazertinib, we're probably going to be going to platinum doublet plus TKI as our next line therapy at this time. So how do you decide? I think it's pretty straightforward for high-risk non-small cell lung cancer. You're going to be using a combination regimen if the patient is fit and willing to undergo a combination therapy. You see across the board, these patients are benefiting by up to a year or more by adding an upfront more intensive regimen. More complex is, are we leaving out lower risk patients who could benefit from combination therapy? And this is something that I dwell upon a lot when I'm seeing young, fit, healthy patients in clinic, desiring aggressive therapy, desiring prolongation of life to the greatest extent possible. They have small children, they have active lifestyles. And even in these low risk patients, look at EGFR exon 19 deletion. Their hazard ratio of 0.6 is the same essentially as the hazard ratio for L858R of 0.63. These patients are benefiting from a combination as well. Even though they're starting from a better place, they're getting further by doing a combination. So I've become progressively more likely to offer a combination to my patients, even with some of these low risk features. Now, as I mentioned earlier, there are some patients with the lowest risk profile who potentially could do well in monotherapy. And I do indeed talk about this with them. I'm upfront with them about this. Patients with very low volume disease, limited extrathoracic metastases, undetectable ctDNA, lacking all these high-risk features, we do see these patients and they likely do very well on a TKI alone, and I tend to recommend monotherapy unless the patient truly desires a highly aggressive treatment strategy. So I showed this slide earlier, but just want to highlight the increased what we're asking of patients. We ask them to do a combination. We are asking them to come to clinic more often, spend more time in clinic, spend more time at home managing toxicities of therapy. So we are asking quite a lot of our patients. And I spoke about a patient earlier who did well on monotherapy for many years, 4 or 5 years onwards. And this is what I think about when I'm seeing these patients. What about the super responders? Are we taking away their period of good quality of life? And I do feel that, I do think that when you think about median durations of the combination regimen, A patient who's destined to have a 4 or 5 year TKI response is not going to be on pemetrexed for 4 or 5 years. They're eventually going to drop off therapy and have a prolonged chemo-free period. And it's what our data shows us thus far. If we could predict upfront who that super responder would be, of course we just give them monotherapy. But since we don't know, an upfront combination I think is a hedge about the uncertainty when we think about risk in oncology treatment selection. That's my editorial take on why combination therapy first is likely a reasonable option. Improves overall survival in the overall population, even appearing in many lower risk subgroups. First-line therapy is the last line of therapy that many patients will receive, and most patients on combination therapy will indeed have a prolonged TKI monotherapy maintenance phase, and therefore a super responder can still benefit from good quality of life. And I'll highlight again my monotherapy first arguments that I mentioned earlier. There are patients who can do well, who can defer toxicities of therapy. We don't know what the future will hold in terms of advances in next line therapy that our patients may benefit from. So I think it still is very much a shared conversation about risk benefit and about what the risk means for the future when deciding on therapy with a patient. And with that, I will thank everyone and happy to take any questions.
Thank you so much for this outstanding review. My questions regarding the anticoagulation, I think we are underestimating the risk with Mariposa protocol. My first ever patient had life-threatening PE despite being anticoagulated. Can we just highlight this as a risk that we have to be aware of, and also be aware of the symptoms so we don't fall into the same mistake? I mean, up to almost 40% risk of VTE in this population with this regimen.
Yeah, it's a great point. And I think it's actually such a nice example of why phase 3 randomized trials are so important, not just from an efficacy perspective, but from catching toxicity. I think individually, if we see a VT in our patient with metastatic lung cancer, it looks expected. We see VTs in this population, so it required that kind of large study to see that there was a difference in rates. So I think that was very important data that came out of the trial. A couple points. One, you're right, VT prophylaxis does substantially reduce rate of clot, but it doesn't completely eliminate it. Sub-Q has some trends towards maybe reducing a little bit further, so I hope that will be helpful. And the prophylaxis is prophylactic dosing, not therapeutic dosing. And that comes up sometimes. There are patients with hemorrhagic CNS mets, large central cavitary lesions, hemoptysis, where that would tip me away from the Mariposa regimen. So I think there are some features in the end for patients that absolutely is an important consideration.
Yes. So since you are more, I guess, pro Flora too, we can sense, which patient would you think, absolutely, this is a Mariposa patient? We have seen some data on RBU1 loss or TP53, perhaps, although we don't know in Flora 2 how really the detail on how they did. Would those be ones in your mind that are more Mariposa at this point, or which patient would you offer Mariposa?
Yeah, I think that's fair. And I skipped over a little quickly, trying to not completely steal the thunder of our next speaker. But I do think both regimens have very similar efficacy data. I think it's a fair statement to make, and I think both are reasonable. So it may in the end come down to the relative toxicity profiles, how the physician and the patient feels about the two relative profiles, and about logistics of treatment. It is very tempting, and I certainly dissect the subgroups and try to think about, well, who seems to do better in which subgroup. I will say what tips me more towards Flora 2 would be patients with CNS involvement, maybe L858R, hemorrhagic lesions when worried about anticoagulation, significant VTE history. On the other hand, for Mariposa, there is a patient population I would think of for that. So the patient with exon 19 deletions, liver mets, TP53 co-mutations, patients where I'm worried about chemo for some reason or have renal function issues for chemo. I really think there is a population who could get Mariposa as well. And so I don't want to give the impression that either is not a reasonable choice here.
If you look at the Flora 2 study, when you add chemotherapy, there is, in intent to treat population, there is better survival. If you focus on the CNS metastasis curve, you see better result with patient or population who have CNS, but those without CNS, which is the majority of the patient at the presentation, there is no statistical significant difference. So why to give the combination if I can start osimertinib, and especially they don't have CNS? So how do you comment? How do you look at it in clinical practice? Thank you.
That's a good question. You know, the CNS, no CNS Mets PFS curves, they do show about a 6-month difference in PFS. The hazard ratio crosses 1 there, but it is a subgroup, so it's not powered to detect that. So I think the trend goes the right direction. But you are right, the benefit is a little more modest there. I will say then I may look at other features. So they have other high-risk features that might tip me. They don't always all travel together in terms of the various high, low-risk subgroups. But it's true, a patient with very low burden disease, no CNS Mets, nothing else pointing to its high risk. You know, like I said earlier, I think monotherapy can be really reasonable for those patients. We certainly have a lot of patients who are still reeling from the diagnosis where I'll start monotherapy alone for a short period and then reassess once there's been more time to process, once we see how monotherapy tolerability goes. Sometimes that can be a successful strategy with patients to help them, you know, feel more comfortable thinking about, we've had the conversation about a diagnosis, we've processed for a few weeks, now let's have the conversation about should we do combination therapy, and that sometimes is more manageable.
Thank you very much. Outstanding talk, and thank you very much indeed for clarifying everything very nicely. So what's your take on the scan for the brain between FLAURA2 and MARIPOSA?
Yeah, that's a fair distinction. So the studies do have, I feel like you're right, studies do have different designs. So the FLAURA2 study required baseline brain MRIs only in patients with known CNS metastases, but did not do serial imaging if there were no CNS involvement at baseline. The MARIPOSA study actually do appreciate that they did serial brain MRIs for all patients regardless of baseline CNS status. And that is nice because then they get intracranial PFS data that is very robust. So it means that for the overall populations and the non-CNS involved populations, there is likely a slight PFS advantage going to the FLAURA study in the study design because they're not going to catch asymptomatic CNS lesions. That said, the CNS disease did have more similar treatment, so there I think it's more fair where we do cross-trial comparisons to be looking because they all got serial MRIs in some form. But you are right, it is a key difference, and I do applaud the MARIPOSA trial for doing those serial imaging. All right, thank you. I think I'm going to introduce our next speaker. Let's see, there we go. So Dr. 𝗂𝗂𝗂 will return and after questioning me, speak about frontline treatment with MARIPOSA.
Feels like a Groundhog Day, you know, just talking about it over and over. So again, thank you so much indeed for the outstanding presentation, Eduardo. So basically, I've been asked to talk about MARIPOSA trial, and of course, you know, we've been discussing about it since this morning, and everybody knows that the story started from gefitinib versus chemotherapy, and then afatinib versus chemotherapy. Then we had FLAURA data, osimertinib came and basically changed the whole story, and then now FLAURA2 and MARIPOSA. And you can see that, you know, throughout this time, we have absolutely improved the PFS, and then we have been improving the overall survival as well. Nonetheless, if you look at some of these curves, there are different shape of the curves as well. You know, of course, it is important to mention that the overall survival data from FLAURA2 is the final overall survival data. We do not still have the final overall survival data for MARIPOSA, and the curve, the tail end of the curve seems to be continue to separate as well in MARIPOSA 2, and it looks like that there is a little bit of approach at the tail end of the curve for FLAURA2 as well. The design of MARIPOSA trial was mentioned a couple of times, so I'm not going to mention this one. This is a forum that everyone knows this trial very well, and of course it did show that over the time it is continuously things are improving, and like I said, at the tail end, it seems that they continue to separate. So we just have to wait and see what is the actual final overall analysis is going to show. Another one is obviously the kind of mutation landscape between osimertinib and MARIPOSA, and you can see that obviously patients who are on MARIPOSA, they do have less mutations, and you know the whole mutational burden seems to be really under control more with MARIPOSA compared with osimertinib. And of course, you know, Dr. Rodum mentioned about the MET amplification. So as you can see, certainly less MET amplification and less in number of mutations in EGFR to make resistance to osimertinib. So that's certainly something that's very, very noticeable. And if you look at it actually, although that the MET amplification is only around, I don't know, 15–20% of the patients, but continuously the patient that they do progress rapidly on the treatment, like rapid progression on 6 months, 9 months, and 12 months, we do see more MET amplification. So it is really very important to address this issue by reducing the MET amplification, which is one of the mechanisms of resistance to osimertinib as well. And as such, of course, recently ESMO has given Mariposa data a score 4 of magnitude of importance as well. Now, I think, the data was dissected very, very nicely by Dr. Rato. I'm not going to just go through all the differences and everything. I think, we've mentioned a couple of times since this morning, but I wanted to give my experience. We had this patient that was actually one of the first patients that was treated here in the UAE. She's actually a 39-year-old lady, one of our staff in our hospital. She presented to a pulmonologist with left-sided chest pain and reported some occasional headaches from 2 months ago as well. She had a shortness of breathing on exertion and speaking, and found to have a pleural effusion on the chest X-ray. Nothing really important in the past medical history, no medication, no allergies or anything, no family history of significant. She's married, she has 4 children, and as Dr. Rato mentioned recently, really, I mean, some of the patients, they have young families. Youngest is 1.5 years, and it is really important to make sure that she has the best treatment to give her the best chance of survival as well. Non-smoker, and she does not drink alcohol. CT scan of the thorax showed some left-sided pleural effusion, some pleurally based nodules, and then a small paraaortic lymph node. I'm sorry, it was done in another hospital. I couldn't actually find the X-rays. So we did a tap of the pleural effusion, and it came back as consistent with the adenocarcinoma, TTF1 positive. Core biopsy was done, again, the same thing, TTF1 positive, NAPTIN positive, primary lung adenocarcinoma discussed at the MDT meeting, and then, staging, obviously, including MRI of brain and molecular profiling. So PET-CT scan was done. I will show you the pictures in the next slide. And MRI brain was negative for any brain metastasis. Molecular profiling was also done, and it did show that there was an exon 19 deletion in her case. There was no co-mutation for her. So this is her PET-CT scan baseline. You can see that she has a significant amount of pleural effusion, a FDG avid pleural-based nodule as well, and basically we wanted to actually start her on Mariposa 2 trial because it was approved in the UAE, but lazertinib was not available in the country, and it took a little bit of time for us to get hold of lazertinib. In the meantime, in fact, I started her on Flora 2 regimen. So she received 2 cycles of chemotherapy and osimertinib. She felt quite fatigued with the first cycle of chemotherapy. With the second cycle of chemotherapy, despite having prophylactic GCSF, she ended up being in hospital with a grade 3 neutropenia as well. And once lazertinib became available, she was switched to lazertinib and amivantamab. I know that this probably is not a kosher thing to do, but this was meant actually to be done from the beginning. But there was not availability of the drug, and also she did not tolerate the regimen very well. So you can see that after 8 weeks, the pleural effusion pretty much cleared completely. The lung nodules are gone, and the pleural effusion is no longer visible. We know that pleural effusion is particularly really something really difficult in this group of patients. Not every patient with pleural effusion, they do very well. It is really, some of them, they have quite a resistant pleural effusion to the treatment as well. So as you can see, she responded extremely well to 8 weeks of treatment and almost complete clearance of the pleural-based nodules and pleural effusion as well. You can see here a small sliver of the disease, a large amount of FDG avid lesion at the base of the left lung, which is pretty much completely disappeared as well. So in terms of the toxicity, everybody mentioned about toxicity, of course, the tolerability of the treatment and obviously infusional reaction. We did use a 𝗘𝗱𝘂𝗰𝗵 protocol, and so far she's around 10 cycles into the treatment. She has not had any infusional reactions, and it's been well tolerated from her case. Skin toxicity obviously is an issue, and you can see that she, at the peak that is on that side, you can see that she developed a pretty significant problem. But the current state is actually, it's on Thursday when I saw her in clinic, so it's 2 days ago. You can see that it's pretty much completely thick. So the skin toxicity does seem to be an early event, and as we go along with the treatment, it does settle down. In fact, one problem with her was that she did not actually take doxycycline and any prophylactic treatment because she felt that she had a little bit of GI upset with that one. So, the skin toxicity seems to be something that can be well controlled. It is an early event, and it settles down later on. Obviously, we know about cocoon trial and the cocoon protocol at the moment. A lot of us will use this one as we go along, and hopefully it can control some of the side effects as well. Again, we have discussed how the cocoon regimen is. I'm not going to go through this one as well. So the question that I have for the audience, I know that you are meant to actually ask me a question, but I'm going to ask you this question. Why would you not use Mariposa for your newly diagnosed EGFR mutant non-small cell lung cancer? I'm sure that, Hassan is...
After the picture you showed us, that's right. Enough reason.
But, that also I showed you the improvement as well.
But I'll tell you what I hear from many experts even, that, well, we are used to our chemotherapy regimen. In terms of sequencing, they would like to maybe have something still effective to be used afterwards. Because obviously, if you are on lazertinib, you don't get much from osimertinib afterwards. But it's really choice for the physician and the patient. You have to discuss with them. We mentioned few points. In my mind, I think if you have TP53 or RB1 loss, in theory, it's relative resistance to chemotherapy. So those group, I think, where I would definitely willing to take the DVT issues. We talked about for up to 40% risk of thromboembolism, and this rash that can be, and paronychia, by the way, not just the rash. When you see patient with bad paronychia, this is it can be painful also. So that's why I think the preemptive treatment may be necessary.
Well, I mean, yes, of course, we do understand that patient to patients, they have a variety of different, side effects, and, it's impossible to generalize things. She actually is a person who has received 2 cycles of chemotherapy, and of course, had Mariposa as well. I did ask her yesterday again, and she said that, I said, look, if you feel that you need to go back to chemotherapy or whatever, she felt that it was actually much more convenient for her to stay on Mariposa despite the skin toxicities as well. So
no,
again,
we
have choice for the patient.
Right, it's good to have a choice. I think at least from efficacy, you're not giving her an inferior treatment, certainly. But I'm just worried about. Remind me of cetuximab, bevacizumab fight in colon cancer. Would you like to have the bev with no much side effect on the skin versus the cetuximab or the anti-EGFR, which in a way, this reminds us of anti-EGFR therapy, obviously.
Yeah, certainly. I think, now we have, I'm glad that, we settled it that, for majority of patients, probably we're going to consider combination therapy. And I guess, now it is case by case basis. And I guess, we have differences in trials population, different in the way that the brain metastasis was assessed, and different in terms of tolerability as well. So I think it gives us the opportunity to basically discuss with the patient.
And if the projected survival, as you mentioned, it's still ongoing, if the projection could be 55, 60 months, that may change things afterwards. Stay tuned.
Right. Well, thank you so much. I know that it's been a very long day, so thank you so much indeed for your attention. Thank you.
Assalamu alaikum, and still good afternoon. So I know it's the end of the day, and it's like a long session, so I'm going to talk about a very interesting topic with the ALK fusion positive non-small cell lung cancer and the role of alectinib. So, disclosures, disclaimer. So we know that non-small cell lung cancer is a very complicated disease where there are many factors to guide the selection of the treatment. Even for immunotherapy, the PD-L1 expression is one of the biomarkers to select which immunotherapy, combination, monotherapy. But the problem with the patient with driver mutations, where we have at least now up to 10 targets can use a driver target therapy. ALK fusion positive tumors around 5%. This is global, but in our data, this is from Tawam Hospital. We reported very high prevalence of ALK fusion positive, around 15% of our patient populations. Patients with ALK fusion, they tend to be young, present with an aggressive disease, never or light smokers, and very high incidence of brain metastasis. That's why we have to test for the ALK, and the beauty about ALK is you can test by immunohistochemistry, by FISH, by NGS. So I believe every center, they have an access to test for ALK when it comes to the non-small cell lung cancer. One of the challenges, most of the patients with ALK fusion, they present with advanced stage, probably stage 4, where the outcome is very poor. And if you're looking for before the era of the TKI, the median overall survival at 20 months. And this is a data from Profile trial with regard to 𝗘𝗱𝘂𝗰𝗵, the first in class with the first generation TKI that's showing improvement in median progression-free survival from 7 months up to 11 months, but we don't have overall survival data. But after that, we have a plethora of trials. We have many TKIs in this setting. We have alectinib, 𝗘𝗱𝘂𝗰𝗵, brigatinib, and the third generation lorlatinib. So Alecensa or alectinib, it's the second generation tyrosine kinase inhibitor. It has a wide spectrum of inhibiting most of the ALK alterations, has a potency in its activity, and since approval in 2018 in non-small cell lung cancer becomes one of the widely accepted, tolerated tyrosine kinase inhibitors for ALK fusion positive tumors. It reported CNS response rate is quite high, 81%. And this has been proved in the phase 3 trial, the ALEX trial, which is randomized patient to alectinib versus 𝗘𝗱𝘂𝗰𝗵, looking for the progression-free survival as a primary endpoint, where overall survival is a secondary endpoint. To highlight it that almost 42% of patient population in ALEX trial presented with the brain metastasis. So this reflecting how the disease is aggressive and how the patient population in this trial. When it comes to the progression-free survival, we have significant improvement in the progression-free survival. The trial is positive, approximately 35-month median progression-free survival in favor of alectinib compared to 11 months for the 𝗘𝗱𝘂𝗰𝗵. Overall survival at 5 years of follow-up was not yet reached, but we have strong signals of 0.67 hazard ratio. The most important, it has a protective effect on the CNS, so the rate of CNS metastasis is quite low in alectinib compared to 𝗘𝗱𝘂𝗰𝗵, whether a patient with the CNS or no CNS metastasis at time of progression. What is more important is the safety profile. Alectinib is very well tolerated drug, and compared to 𝗘𝗱𝘂𝗰𝗵, the safety profile it's better. We have less dose reduction, interruption, or discontinuation. The second is brigatinib. We have the ALTA trial, and brigatinib compared to 𝗘𝗱𝘂𝗰𝗵 for advanced non-small cell lung cancer, ALK positive tumors. Crossover was allowed in this trial, and again, brigatinib did improve progression-free survival by independent committee review as well as by investigator assessment. Median progression-free survival around 30 months. but we don't have yet an overall survival benefit because it's still immature. It seems brigatinib a little bit toxic drug compared to 𝗓𝗃𝗃, and as an interest, we have like 5% of the patient, they develop interstitial lung disease. Moving to lorlatinib, and this is a CROWN trial where has been presented last year. This is a 5 years follow-up by investigator assessment. And if you're looking for the design of the trial, so they compare lorlatinib to 𝗓𝗃𝗃 in patients with advanced stage, looking for progression-free survival as a primary endpoint and overall survival as secondary endpoint. And just to highlight it, that crossover was not allowed in these patient populations. This, the PFS at 5 years, one of the longest reported PFS up till now. 60% of the patient at 5 years still progression-free, and 8% for 𝗓𝗃𝗃. If you're looking for the subgroup analysis, the benefit was across all the subgroup of patients, including those with CNS metastasis. And here they're looking for the superiority of the PFS irrespective of the baseline patient with the brain metastasis or no brain metastasis. And looking for the intracranial progression, also it was significantly in favor of lorlatinib. Time to intracranial progression also was significant in favor of lorlatinib compared to 𝗓𝗃𝗃, but we're struggling a little bit with the safety profile of the lorlatinib. Probably most of the toxicity are laboratory, high triglycerides and cholesterolemia. But the problem with the cognitive function of the lorlatinib, which is reported in 28%, knowing that most of our patients are younger population, working age group, so probably cognitive function affection, it's one of the limitations of lorlatinib. So we have a higher incidence of dose interruption. 60% of the patient, they have dose interruption and dose modifications in almost 23%, but it has no impact on the outcome. And also looking for the patient with poor prognostic factors, such as those with P53 mutation or variant 1 alteration, still there is a significant improvement. So probably those group of patients who might really need lorlatinib. They're looking also for the type of resistance, if there is any developing any secondary ALK mutations, and actually there is no reported any ALK mutation upon progression. So in absence of head-to-head comparison between alectinib, which is a commonly used accepted ALK inhibitor, and the newcomers, which is the lorlatinib now based on the CROWN data, how to compare between both. So this is indirect comparison, and I don't like to compare trial to trial, but just to highlight it that the baseline patient characteristic in CROWN study, they included very small number of patients with brain metastasis. It's almost 26%, which is different when looking for the ALEX trial, 42%. So it's almost doubling the number of patients with brain metastasis, which is reflecting the patient population and the outcome in this trial. If you're looking for the progression-free survival, the trial was designed to show the overall survival at 3 years, but the extension to 5 years, this is by investigator assessment. But again, we have significant improvement in progression-free survival in both trials. Probably we have a longer PFS in the CROWN trial, but I would like to highlight it that the performance of the 𝗓𝗃𝗃 in this group of patients is very underperforming. If you're looking for the at 3 years, for example, 10% only in the 𝗓𝗃𝗃 progression-free, which is 20% in the ALEX trial. Overall survival was not mature in both trials, but probably expecting longer median overall survival in CROWN trial, because from phase 2 trial, after 72 months of follow-up, still 76% of patients are survivors. In ALEX trial, still immature also, we didn't reach the median at 5 years of follow-up. What about the brain metastasis? I mentioned before that we have almost double the number of patients with brain metastasis in ALEX compared to the CROWN, but we have improvement in progression-free survival in both trials, as well as patients without brain metastasis. If coming to the safety profile, and this is one of the strongest points in favor of alectinib, you can see that the dose interruption, it was only 26% with alectinib, it was 62% with the lorlatinib, which is quite significant. That's mean there is a lot needs for the patients to maintain on the drug. And again, dose reduction has no impact on the outcome. What is the most common toxicity? Hyperglycemia, hyperlipidemia, and increase of the cholesterol level. But lower limb edema, it's quite significant if you use lorlatinib. Weight gain, which is a concern for the females. But the most important is the cognitive function, which is reported in 28% of this patient. I know most of these toxicities are grade 1 and grade 2, but it's really need an extra layer of taking care for the patient. And as an oncologist, I don't know how to manage cognitive function affection for the patients. Have to do dose reduction or dose interruption. Was it works? My experience with the patient, we go from 100 to 75 to 50, and still it did not control the cognitive function affection. This is even worse if the patient received prior radiation therapy. Cardiotoxicity, however, it was equal in both group, crizotinib and lorlatinib, but there is a concern with the hyperlipidemia in such a group of patients with cardiac disease, so we have to take care about this part. phase 2 also was in favor of lorlatinib, and here just to show the rate of discontinuation between the both groups and dose interruption, it was higher in Crown. At the end of the day, the guidelines did not differentiate between all of them. So all are preferred options or are level 1 recommendation. So probably safety profile will make a difference among all these TKIs. So in conclusion, alectinib has become the standard of care for the first-line treatment of patients with advanced ALK fusion positive non-small cell lung cancer. Compared with crizotinib, alectinib significantly prolongs progression-free survival, reduced risk of central nervous system progression, and achieves a higher intracranial response rate. Its favorable tolerability profile, together with durable systemic and CNS disease control, it differentiated alectinib from other TKIs and translated into meaningful improvement in both survival as well as quality of life. Thank you. Who's coming next to introduce? But yeah. I think the mic's not working, but I can hear you.
Yeah, I say thank you for this extensive presentation. Just a question, because of the, we don't have comparison arm to arm between the alectinib and lorlatinib in first-line ALK inhibitor patient, isn't it? Yes. So I agree that this was the comparison between alectinib and crizotinib. If we go for the adverse events, I think any drug can have adverse events, even paracetamol. Now, I got a patient on lorlatinib almost 4 years. He's doing well, although he's 74 years old. And the only adverse event that I've seen with him is the hypercholesterolemia, which is easily manageable when you assess your patients with cardiology or internal medicine. Regarding the cognitive dysfunction, it's true that it's described, but it happened to this patient specifically for the first few weeks. But when you explain to the patient and to the family that this can happen, and it is actually transitory, it's not like something that will sustain, I think that for me, both can be considered. And also, we need to look for the adverse events of the alectinib, because both has been approved for the first line as per NCCN guidelines. Just a comment because of the cognitive dysfunction.
Thank you, Dr. Sonia.
Thank you.
So I'm not here to tell you to use all patients for alectinib or all patients for lorlatinib. One size will not fit all. The point is, if I have a young working woman, should I give her lorlatinib, which is 28% risk of cognitive function, taking care? It will be difficult. So I have to think about why I will give lorlatinib. If I have old patients with the cardiac disease, already hypercholesterolemia, should I give lorlatinib to expose to more hypercholesterolemia, hyperlipidemia, and risk the cardiac toxicity? probably I have to think. The beauty of alectinib, it's very well tolerated. We have been using for many years. It's very well tolerated, and I have patients for more than 5-6 years, 0 side effects. I have been using lorlatinib. I have patients no toxicity. I have patients struggling with the cognitive function impairment because of lorlatinib. So probably I might use it for patients with high-risk features, such as those with the P53, patients with variant 1 or variant 3. This is very aggressive, so I will go with lorlatinib rather than alectinib. But other than that, patients will stay on this medication for a long time. So I cannot expose my patient with cognitive function affection for 5-6 years. This is also difficult here.
So we have to balance between the patients and the choice of treatment, discuss with the family. Yes, thank you.
Comment just to be fair, I think early recognition is the key here for these side effects. So as Sonia mentioned, if you do good education to the family member and the patient, and you can do your mini mental exam, or you have to be a neurologist now, but not really. I mean, it's an easy thing you can do, because if you detect early changes in terms of the cognitive dysfunction, you can easily lower the dose before you reach significant dysfunction in the cognition. Because what's at stake, you showed the curve, 60% at 5 years. I don't think any other metastatic disease have first line going that long. So we cannot ignore that as well. Granted, I think alectinib may be more tolerable when you give it, you relax a little bit, you sleep well, as we say, than when you're giving lorlatinib. But I think when you think of delta PFS, or if you're giving first line, second line, third line, there is no question lorlatinib does not do as well when you give it as second or third line. The median PFS become 9-10 months, at the most 1 year. So you never catch up with that longer PFS. What's your thought?
Yeah, thank you, Dr. Ghazal, for this comment. But don't forget that in Crown study, they relatively choose the patients with less aggressive disease. So the number of patients with brain metastasis, the lowest in the Crown study, 26 only, where it's double in other trials. So probably this is reflecting why this surviving that so long. This is number one. Exposing the patient for a drug which is causing toxicity. I mean, something cognitive function, it's a new toxicity for us as an oncologist. I have a patient, because of good response, she's maintained on full dose of lorlatinib, but she really suffered. Other patients will reduce the dose, but still also suffer. But other patients tolerating well. So which patient to give lorlatinib? I think those with very high and aggressive disease that I mentioned, B53 and variant 1. Thank you.
Well, good evening, everyone, and thank you for staying till the very end. I have the honorable and difficult task of being the person between you and your dinner. Let's go ahead and get started. I'm going to be speaking about an important unmet need in patients with hormone receptor positive, HER2 negative breast cancer. As you know, this is the most common subset. And while patients generally do well on first-line therapy with 2 years now from the best data that we have, following progression on this therapy, and ultimately patients do progress, the options are limited to either endocrine therapy and targeted therapies, which we commonly look for opportunities to do, although the times to progression are short in second and third line, as you can see here. So clearly an area of unmet need. We do look for opportunities to put patients on trials or on treatment that avoids chemotherapy. However, the availability of more targeted chemotherapy is starting to change that equation. Antibody drug conjugates, and specifically trastuzumab deruxtecan, which I'm going to be talking about today, allow greater delivery of chemotherapy to the cells. In this case, trastuzumab deruxtecan targets HER2 expressing cells, initially approved in HER2 positive and then in HER2 low, and more recently in HER2 ultra low. And again, on the basis of the antibody affinity and internalization and the bystander effect, has shown remarkable efficacy in HER2 positive and HER2 low disease. HER2 low and ultra low disease are defined by being patients who have tumors that express the HER2 at low levels, but are not amplified by FISH. HER2 ultra low specifically refers to essentially negative membrane staining, except for faint staining, or what we call 0+. The DESTINY-Breast06 study was designed specifically to look at this group, HER2 low and including HER2 ultra low, the first study to do that, enrolling patients with hormone receptor positive breast cancer who were chemotherapy naive in the metastatic breast cancer setting and had received two or fewer endocrine therapy targeted or two or more endocrine targeted therapies or first-line therapy for metastatic breast cancer and had progressed in less than 6 months after starting endocrine therapy or CDK4 inhibitor, or had a recurrence of less than 24 months after adjuvant therapy, endocrine therapy. And the primary endpoint was progression-free survival by independent review, and secondary endpoints were overall survival and quality of life studies. Patients were randomized to either T-DXd in a 1-to-1 fashion or therapy of physician's choice, as you see listed here, capecitabine, nab-paclitaxel, or paclitaxel. And here are the key data, the primary endpoint of progression-free survival. You can see here that patients had a delta of 5.1 months with T-DXd compared to standard choice chemotherapy, with a hazard ratio of 0.62 and strongly statistically significant. In the exploratory endpoints looking at PFS between these two groups, you can see that in the HER2 low group that there was a progression-free survival of 4.9 months, and in in terms of PFS specifically in the ultra low group, and in terms of overall survival, also a hazard ratio of 0.075, not quite reaching statistical significance. And if you look again at the subgroup here, you can see that within all of the different categories based on age, HER2 status, prior taxane use, endocrine resistance, primary or secondary, as well as the choice of chemotherapy, that the benefit was generally preserved in that range. Now, the time to progression on PFS by time to progression on first-line endocrine therapy is shown here. We know that patients who have short responses tend to have worse outcomes, but you can see here that in the less than 6 months, the 6 to 12 months, and the greater to 12 months, that the benefit was generally preserved with a anywhere from 6 to 7.5 month advantage with T-DXd. And here are the waterfall plots that show responses. And again, you can see that with T-DXd, the overall responses, complete, partial, and stable disease were more favorable in the trastuzumab deruxtecan group, both in the HER2 low and ultra low. PFS2 is an important endpoint that we look at, especially in patients that tend to get multiple lines of therapy. This includes the progression-free survival from the treatment on the trial, but also what they receive in subsequent therapy. And in the T-DXd arm, patients were looked at with their first subsequent therapy, as well as in the standard chemotherapy arm, whatever subsequent therapy they received. And the PFS2 in the overall population is shown here. And again, this shows a clear advantage. So even with looking at the next therapy, which is an important consideration in this population, you see a delta of 5.6 months. And again, that benefit is seen across the subgroups depending on how long the interval from which they progressed in first-line therapy. The overall safety summary is shown here, and essentially no new signals arose from this analysis compared to what the experience had been in other disease settings. Notably, the number of patients that had to discontinue due to treatment-related side effects was not significantly different. The most common cause of discontinuation was either pneumonitis, but in the standard chemotherapy, sensory neuropathy and cutaneous and mucosal symptoms were common causes. And if you look at the overall pattern of side effects, you can see nausea and fatigue a little more common in the T-DXd arm, and in terms of other side effects like diarrhea and palmar-plantar dyserythrodysesthesias, you can see that that was more in the standard chemotherapy group. Adverse events of special interest are shown here. This is important in all of the new drugs we look at. No new major signals arose on this study. I want to point out that interstitial lung disease is a known side effect, and its incidence has markedly gone down as our experience with this drug has progressed. Clinicians now know to look for any signs of pneumonitis very carefully. Patients, when they get scans, of course, we get to look at their pulmonary status. So that's a good way to keep track of our patients, even when they're asymptomatic. Cardiac ejection fraction decreases were uncommon and not different than previous studies have shown. Post hoc analyses have subsequently been examined and were presented by Carlos Barrio at the most recent ESMO meeting. And this breaks down the primary outcomes by the different chemotherapies received in the treatment of physician's choice. And you can see that the benefit in terms of PFS was seen with T-DXd over capecitabine looked at individually, or taxane, which include paclitaxel and nab-paclitaxel. And similarly, confirmed overall response rates and duration of response according to RECIST criteria are shown here. Again, you can see that the response rate favoring T-DXd is seen both relative to capecitabine as well as to taxane therapy. And PFS, again, by chemotherapy agent is shown here. You can see a benefit both in the capecitabine group and the taxane group when with T-DXd showing better outcomes, again, roughly the same in both groups. And the treatment side effects, this time broken down by different therapies, are shown here. With capecitabine, you can see the distribution of side effects, obviously more PPE, and with taxanes, there was more sensory neuropathy, but the side effect profile of T-DXd, again, about the same as has been seen before. PFS2, again, broken down this time by different genomic lesions, was reported in a subsequent study by Rebecca Dent and colleagues. And I'm just showing you the overview data here, but you can see that the favorable hazard ratio supporting T-DXd was seen in all of the different genomic subgroups that are commonly seen in this population. I want to spend some time talking about patient-related outcomes. Don't worry, I'm not going to read this entire slide, but you can look at the main headings here. This is an important companion set of studies that are now being increasingly used in cancer trials. And it's important because they capture the patient perspective as the patient is reporting them. They enhance our ability to really understand what's going on with the different treatment arms. They align with what the regulatory agencies want to see in terms of patient quality of life. They help you with decision making and discussing these findings with the patient for them to be involved in the decision. And they also help us understand what the needs are in terms of better addressing patient side effects and also advancing our needs to choose wisely and maintain health costs and resources down. And I'll briefly go over the patient-related outcomes and the quality of life scores using the QLQC30 and quality of life and specific symptoms over time. And you can see that the overall trends are similar in terms of what patients are reporting in the global health scores over time. And the conclusions from this study, I'm showing you really the main highlights in the interest of time, is that it's important to remember that the duration of treatment on T-DXd was twice as long. So that influences some of the side effects are reported. But quality of life was maintained with T-DXd, while time to deterioration was actually delayed with T-DXd. So the benefit in terms of controlling the disease showed up with these quality of life studies. GI symptoms reported by patients on T-DXd did not appear to be detrimental to the overall preservation of quality of life, which is consistent with clinician-reported safety data that was concordant. However, they did show that we do see this, and optimization of antiemetic prophylaxis is critical. It is now recommended that we use triple control with 5-HT3 antagonists along with aprepitant and steroids. And so the optimization really is important. And so in closing, I'd like to say that T-DXd is highly effective in HER2-low and HER2 ultra-low metastatic breast cancer, and superior to chemotherapy a physician's choice at a point in time when chemotherapy is felt to be the best option, as I mentioned earlier. The quality of life data is also favorable to T-DXd relative to the comparators therapies, particularly with less deterioration related to some of the side effects we see with capecitabine, so skin and mucosal toxicities, with no new findings that emerged in the overall safety. So I'd be happy to take questions at this point in time, and particularly in the context of decision-making for this particular category of patients at that particular point in time. Thank you so much for your attention.
Yes. Can you hear me? Okay, thank you. So obviously we went from 3+, 2+, 1+, ultra low now. So if you look at the ER positive, at least we're talking about, that covers 85% plus of patients. And then we're reading more and more about T-DXd that maybe we don't need the HER2 itself on the surface of the cells, because this is more in the matrix or in the tissue around the tumor cells. So we may not need necessarily. So my question to you, obviously IHC was not meant to be for this drug. So why bother testing? I know there is the IHC 0 is coming. So, but why are we so centered about that, where we see TROP2 directed drugs approved regardless, even though we know there is correlation with the concentration of TROP2 as well. But yet the FDA gave them blank approval. So what's your thoughts on that?
Well, you're absolutely right. In the DAISY trial, which was a limited study, it was a pilot study, there were patients that were HER2 totally negative. Of course, the pathologists probably weren't as well trained at that time, and they did seem to have responses. But my main response to that is yes, it should. I personally feel that it should be studied. We should probably at some point do a study with this group of patients. TROP2 is a little bit different in the sense that it is an epithelial antigen that's more broadly expressed. Now, there is some variation in TROP2, and there are people that believe that TROP2 intensity does matter, and there's even studies trying to increase the expression of TROP2. And with HER2, we also know that, as you point out, it may be present in all epithelial cells. It is a general epithelial antigen. You can see it in skin cells, mucosal cells. So I agree with you. I think this needs to be assessed carefully. That has come up. That
thank you. I just gave the TROP2 as an example. I didn't mean to, but yes, because FDA never looked into testing even for these patients. I think everybody is tired. Thank you.
Thank you all for your attention.
Okay, so I think we are very excited for this workshop and very tired. So we'll have to also try to be focused and try not to ask a lot of questions too. Yes. Yeah. So this is a hot topic in breast cancer, and I think we're gonna sit down together, try to learn from each other's experience. So without further ado, wanna call Dr. Hussam to be with us in the podium to discuss more about the updates in the management of ESR1 mutation, hormone receptor positive, HER2 negative advanced breast cancer.
I'm aware of the timing, so I'm Hussam Al-Rashi. Thanks, Dr. Aida. My presentation is very simple. It's about the testing ESR1, and my first disclosure is that I'm not a scientist. I don't do the testing, but I'm looking at it from a medical oncology point of view. Things have moved on. Our understanding about breast cancer now finally start to change in the direction to precision medicine. Yes, there are proteins we look at. We all know it. That's been now for decades. We have now molecular, what we call molecular, it's not going to present well. We have genomic biomarkers now. All the guidelines seem to be pushing us into and advising us to check into them. And of course, there are some general biomarkers. We are learning now is that studying ESR1 is very crucial in understanding the resistance of what we call the emerging resistance to endocrine treatment. I'm not going to go about the details, but the estrogen receptor gene encodes these, what we call the receptor on the cell membrane. And when the other way around, the signal coming from the cell membrane to the nucleus seem to be, it's influencing so many genes in the nucleus. And I remember when I was finishing my training into my first decades into practicing, that ESR1 was on a number of what we call papers written, and real interest in it did not come till we start have the question about how do we deal with resistance to CDK4/6 inhibitor. So they knew about it, went into being quiet for a number of times, and I don't need to tell you why, because every studies in the past were looking at the primary, and the primary don't have ESR1 mutation. And more, as you can see, there are now more and more data. To me, Sophia trial is a big thing to me. I remember I was working with one of the investigators as a trainee. Clearly, there is a signal that emerging ESR1 affecting the progression-free survival, as you're all aware of, and now is the predictive biomarker for resistance. We're not going to go into the details, but simply is to do with the ligand-ligand domain. So there's our specific area into that gene of the ESR1. If we can detect, we can predict that the ESR1 mutation is on. What I'm doing with time here. I'm going to miss a lot of things. And again, to move on in terms of the endocrine treatment, this is a slide presented a number of times. We know that's the molecular or the resistance to endocrine. We have the clinical story, which to do with time frames, and we have now what we call the molecular story, which identifying a gene that we can target in our practices. And that ESR1 is one of them. We have the PIK3CA, we have the AKT pathway, the RB1 and the P53. So the whole, I don't think will be new genes we're going to find out, because the whole genome has sequenced to depth now. I think the relationship between them, that's going to be the next one. And you know this, the prevalence of the ESR1 mutation is going to evolve through this journey of the patient. We're not going to talk about it. There's a lot of different type of mutation, and we can now detect number of what we call ESR1. They're not only one brand. And I think this is the most interesting, or the slide that summarized the story, is that the prevalence of these red dots, that's these cells that carry on the ESR1 mutation, once we
push the cells with the endocrine treatment, and that particularly the aromatase inhibitor, the genes that carry on will what we call will show themselves in a more obvious way. But if you check so many different areas, you may not have. So if you have a tissue heterogeneity, what we call heterogeneity, you may have tissue, but you may not be presenting the red dots, what we have here. And that's what we talked about, is if you checked at the primary, these red dots seem to be becomes more obvious. And you can see from, this is one of the early studies from about 12 years ago, you can see the metastasis may have it more obvious than the primary disease. And how we detected, now, and when the best idea, someone told me, if you can pick up what we call the cell-free DNA, it's ideal. But that you'll never get a that's very demanding in terms of the tumor shedding the whole DNA. It have to be a lot of expertise. So all what you're going to get is what we call circulating DNA. As you can see, it's shredded parts of the DNA into the system. And that's about what we talked about, the heterogeneity, is that tissue itself may not represent one clone itself. And that's why if you looked at what's going into the bloodstream, it might be more representing to different clones across all mutations. And of course, once you start detecting all these type of alternations or mutations, you're able to have more targets. So how to test? I'm just going to move on in terms number of studies. So we've been practicing now medicine, breast cancer oncology now since after CTK. We have now more than a decade experience, and you can see the prevalence seems to be a lot of data saying okay, it's worth keep checking on these things. So what I'm trying to say is that it's playing in a crucial part of the resistance, and any trial you're going to do on from now, from any day, from the first line to the second, is going to be more informative. And it's not about the new trials, about the relationship between all the different what we call mutations. So you have in our clinic, if we're going to request it, I have the option of doing on biopsy and I have option doing on free DNA. What is the difference? So if you do a tissue biopsy, because of this one biopsy from the sample may not show the ESR1 mutation, so that means you missed the whole point. So in tissue you don't have that. In tissue it's invasive tissue. You still, it may take a longer time to book for the biopsy and arrange it. Given again the subclonal different mutations, so not all mutation will be detected in tissue biopsy. In a primary, and then if you use the archival one, then you might think about one from the primary tumor. You're not going to pick it up, as I said, because this hasn't emerged. Where the liquid biopsy, it's far more specific. These NGSs, we say more sensitivity compared to tissue, and they're minimally invasive. They can be done in the clinic, very easy. It's quick obtaining sample. There are different ways of doing it. So of course, the licensed drug till 2 days ago, which is the Emerald now, which all the studies coming out seem to be doing it on circulating DNA, and but when we bring that to real practice, it might be a little bit more different. I know I picked 2, but actually in real life there are 3 different ways of checking ESR1. We talked about the NGSs, which mean you sequence the whole, you do simultaneous sequencing to millions of DNA fragments. You can do that, but the sensitivity to pick up a certain mutation, a certain level, is less. So this is where the Doppler, what we call digital PCR, has emerged. There are more what we called more specific in terms of certain area or single strand of the DNA or RNA, and they're very highly sensitive. They're not that great for research. They might be good, particular for what we call everyday practice. The use of what we call the digital PCR is most likely what we're going to move on in our, I would think, for
big group of screening, what is going to be looking at like. And we have now number of data, number of trials coming out to say that the sensitivity or the correlation or concordance between them and the NGS is as good as they're going to be. And I know there is more validation coming into the picture. And of course, the whole idea, if you pick the ESR, you're going to have something you're going to target. When to test, I'm not going to go into detail every single line. I think the simple message is that it's an emerging mutation. So keep checking for it. You might be able to detect it. And as well, one point, we might be able to go, even if you cross to the chemotherapy world, one point you might want to go back to the endocrine treatment. But the bottom line from the guidelines, you can check it after each line. Who's going to test? I think that's what I've just said there. And on that, I'll just finish my part on the testing. Thank you.
Thank you very much, Dr. Hussam. I think you have to join the panel discussion. Yeah, I think. So I think it's very clear when to test, but we will have in clinical practice how we do it. And I'm delighted to introduce the panelists, Dr. Aida, Dr. Adina, Dr. 𝗂𝗂 جلاد, Dr. Valentina. Yes, please. So there is a set of questions. We heard from Dr. Hussam very elegantly how we do the test for those patients and when to do it. So if we can have the questions. I'll keep it warm. So you tackled the testing methods, and here, what is your preferred method for ESR mutation detection, Dr. Adina? So in your clinical practice, what you are doing, we heard that there is the NGS, the PCR, the liquid biopsy, and the tissue biopsy. So in clinical practice, what you are doing?
Actually, in our clinical practice, thank you, Dr. Hassan, for the question. We have a very good applicability to lots of testing. We have in-house foundation. We have the foundation tissue, foundation liquid. So in such cases, we will send them through foundation liquid. We have the support program for patients who cannot afford. So we have the liquid NGS, the Guardian 360, being supported by Menarini. And usually in such patients, if we are even able to get like a new tissue, not only for the case of sake of the ESR, but also for the sake of knowing the HER2, we can get a tissue and send it also for an NGS. So we do both, but at least liquid biopsy to assess the ESR1 mutation through foundation or Guardian 360.
So at least we do a liquid biopsy.
Yes.
Dr. Aida, usually you do it for all patients who progress on CDK4/6 inhibitor?
I actually do it when I decide on the first line treatment, just so I know the baseline mutational profile of the patient, and then with every progression, as long as it's going to help me in treatment decision. And usually I do the liquid biopsy. If it was negative, for example, for PI3K, I would go back to the archival tissue to try to perform it on it.
We know that the archival tissue for the ESR1...
PI3K. PI3K, I mean.
Okay, PI3K. Okay, thank you. We know, do you do, Dr. Valentina, do you do the testing after several, if you do it after CDK4/6 inhibitors and there was no mutation and you proceed with another line of therapy? And depend whether it's hormonal or chemotherapy. We know the stress, mainly it is aromatase inhibitors, fulvestrant, where you probably increase the pressure and then you can have ESR1 mutation. But what about chemotherapy? Do you do the retesting after those lines?
Of course, this is a very interesting point. The issue is whether the ESR1 emerge after endocrine treatment only. And so we have to say that we perform the test in all the patients progressing after first line treatment. Probably we not those who rapidly progress because after endocrine treatment plus CDK4/6, meaning those patients progressing within 6 months from the starting of treatment. I would personally not test because endocrine treatment would not be, or in particular single agent endocrine therapy would not be my preferred choice.
I think it's useful to gain experience in testing at further progression. And of course, we actually do not know whether the endocrine environment will change also after the pressure of chemotherapy. So if endocrine treatment would be an option after chemotherapy, probably I will test and we will see whether to offer elacestrant or other because you know that in the Emerald trial there were also patients that have failed one line of chemo for metastatic disease. So is an option to me.
Thank you. What about you, Dr. Jalad? We know many times with the hormonal positive, we go for chemo, hormonal, and then we start tamoxifen in the era before CDK4/6 inhibitor. So do you consider ESR1 mutation even after lines of chemotherapy and do it? Or no?
Even after, yeah. So it's not just after the first line. I may even consider repeating it. I haven't proven it before, and this is an acquired mutation, that I probably would repeat it after any line of therapy, if it is available to be tested. You know, we understand this still has some financial toxicity to do that in people or in places where you cannot cover the test. So you have to be mindful of that. But in my mind, the standard of care is, at this point, is to repeat it every failure of line of therapy in the metastatic hormone positives until they change their receptor status.
Now, we know that with the SERENA data, Dr. Hussam, usually you do the testing sequentially. And do you do the radiological assessment as well with this treatment to select whether you add or just to change to a second line? And do you think the financial burden of this is really very doable to do it in a clinical practice, or this will be limited only to the clinical studies?
I always try to simplify in my head. The most important thing is the patient in front of me and the clinical progression story, because once the patients start to show signs of progression, I think we are obliged to change the treatment in a way. And the first thing we confirm it is by the radiological progression. So to me, what is the most solid evidence is to move in radiology, because that's to me what I would work on. Now, the new principle of checking the ESR electively and looking for molecular progression is new, and we're learning about it. I think for single person to check that ESR, what we call emerging, is not a bad thing. That's in my opinion, because it's not going to cost the patient more than a blood test doing checking on NGS. But on a health system, it's very cumbersome, and I don't know how if you have insurance system fair enough, they cannot cover it, but I think there would be a lot of resistance. I don't think it will cause a lot of financial toxicity for now, and that's what I try to push it. If you're going to do the PCRs for thousands of patients, or we're going to do quantitative or with what I call droplets or NGSs on the longer term is really a lot of effort. So to me, as per now, I think the clinical and radiological progression is what we act on. But the data is promising, and we will have to adapt very quickly. And I said, for one person, it's fine. For the whole system, it's disaster.
Anything different, Dr. Valentina, from your perspective? Does this implement in Europe?
Yeah, my view is pretty much the same. Even if you find a way to pay for the costs of having serial testing, still I want to see the long-term follow-up of the SERENA-6 study, because now we know that you can use in sequence, so don't know if you early intercept and you change the treatment if really you are changing the long-term outcome of these patients.
So from the clinical outcome, and we know that we didn't compare it with a second-line treatment with those patients. So do you clinically implement with all the burden of doing these tests? And
I think on top of what my colleagues have mentioned, which I agree with, is an anxiety element with the patient and how to address that. For now, I don't think I'm going to implement this strategy until I get more solid data. And most of these patients were not even crossed over to, those with were not switched to begin with. Were not
So it's a proven concept, but it is not a changing practice.
It's a
And it is
beautiful
very
concept,
interesting.
yeah, and it may evolve in the future, but it just, I don't think it's ready yet.
Probably in future it will be cheap, like tumor marker CA15.3. Probably it will drive our treatment. I think if there is any further question before we move to the second presentation.
Just, I want to echo what Aida was saying, because there was no crossover allowed. So when you talk about survival, this is not going to be something for us clinically to adopt if we're not convinced that the survival will be different. So right now, we're still, classic way is to wait for progression.
But you may use it in your clinical practice.
I will.
But you may not change it. So we'll move second for Dr. Valentina, who will present us the data for the ESR1 mutation in the second line and how we manage those patients. And then we will have the final panel discussion.
So thank you. I'll do my best to show you the data very quickly, because a lot of things have already been presented this morning. So please find here my disclosure. Of course, you are very familiar with the data in first line showing that the addition of CDK4/6 inhibitor to standard endocrine therapy really more than doubled the median PFS. So this is very important when considering our treatment algorithm, because as shown before, as long is the and endocrine deprivation, the higher is the probability of increase of ESR1 mutation. So we are facing more and more patients where the ESR1 mutation arise as a mechanism of resistance to the treatment. And you already see seen a part of this presentation. What is important is that ESR1 mutation is a marker of endocrine resistance, but still of the potential with the inadequate targeting of the patients still being still benefit from endocrine therapy. Sorry, they are a little bit changed. And you already seen this. So here is just a picture of the prevalence of the mutation. You see that is very extremely rare in primary tumors, and the prevalence of the mutation start to rise as long as is the prior endocrine therapy exposure. That's why we don't have to go to the primary tumor to test for ESR1 mutation, and that's why it is recommended to retest for ESR1 mutation at further progression, as we discussed before. And now the ESMO guidelines are very direct to the need for testing biomarkers prior to decide the second line therapy. So we have the possibility to test for BRCA mutation for deciding on offering the PARP inhibitors, and PIK3CA or the PIK3CA pathway to switch the patient to a treatment with the endocrine therapy in combination with the inhibitor of the pathway, and of course ESR1 mutation to offer the patient treatment with endocrine monotherapy with new oral SERDs. And this is just a summary of an interesting work that we have done in Europe with 4 labs trying to harmonize the procedure to test the ESR1 on liquid biopsy. So we presented at ESMO Breast at the last ESMO Breast meeting the results of this effort, and where you can see that the lab tried to harmonize the procedure, and by using NGS or digital droplet PCR,
and more than 1,000 samples have been analyzed, and you can see that the prevalence of mutation is approximately 37%, and also another important issue probably that will be useful for future for the future is the evaluation of the variant allele frequency. You know that now the threshold to offer treatment is extremely low as compared to other mutations or in other cancer type, for instance. So we need very sensitive methods to check for the ESR1 mutation to avoid false negative rate, and also of course, there are some mutations that are more frequent, but it is important to cover the panel of the frequency that were analyzed in and that can qualify for patients to be offered to oral SERD. You are very familiar with the EMERALD trial. I don't think we need to review the data, just the point that 100% of the patients were pretreated with CDK4/6 inhibitor combination therapy, and this is probably the trial where in which the patient population really reflects our clinical practice. As discussed before, 1 line of chemo was allowed, and 20% of the patients have received approximately prior chemo, as summarized here. We have patients with visceral mets, so a patient population that represent our clinical practice. And here the data with the benefit observed in the ESR1 mutant patient, particularly in the ESR1 mutant patient cohort. And I found very interesting in terms of discussing with the patient what is the expected benefit in terms of median progression-free survival. I know that from a clinical trial perspective, the hazard ratio is what we have to look at. But I think that when discussing the patient a potential option, I think it's important to discuss. Patient ask for how long should I receive the treatment, and so the median PFS is a surrogate of the expected benefit from a given line of treatment. And in this analysis, it's shown that if you have at least 12 months of prior treatment on CDK4/6 inhibitor plus AIs, you can have a median PFS, unexpected median PFS that exceed 8 months. So I think that for a single agent endocrine therapy is something, considering also the very good safety profile, is a good option for our patients moving to second-line treatment. Now I think that the hot topic is what to do in case of co-mutation, because we have a competitive scenario where you can have the targeting the PIK3CA pathway or targeting the ESR1 pathway. I think we have time later to discuss. What we know for the moment is that elacestrant performs independently by the presence of PIK3CA mutation. So you see that the benefit is the same. Of course, PIK3CA mutation is associated overall with the worse patient outcomes. So you can see that the median PFS is shorter, but also in the comparator arm. Of course, this is a subgroup analysis, including those patients who have received prior CDK4/6 inhibitor therapy for equal or more than 12 months. So it's with this caveat, we have these data. But of course, there are also other, and this is the summary of the evaluation of all the variants. And here is another analysis focusing on the VAF of PIK3CA mutation and ESR1 mutation. And you see the same benefit of elacestrant independently by the fact that there are cases where the median VAF is higher for PIK3CA rather than ESR1. So the VAF is not a driver to select PIK3CA targeting versus ESR1 targeting, but we will discuss also later on. And also there are data coming from real-world evidence showing consistent results in terms of the expected median PFS and in terms of the efficacy of the single agent elacestrant in the presence the presence of commutation of ESR1 and PIK3CA. Just a comment, we have discussed a lot of the attrition rate in triple negative disease, but it is important. I found very interesting this data presented by my friend Rupert Pash, showing that you can have a significant proportion of patients not moving to second or third or fourth line of treatment, even in the context of hormone receptor positive HER2 negative disease. So it is important to have ready the evaluation of the potential targets and the potential algorithm as soon as possible, because sometimes we don't have time to play around in starting the molecular testing at the time of progression. That's why, to me, is important to have the possibility of offering the test on liquid biopsy for ESR1, but also for PIK3CA, because sometimes going back to the archival tissue also for PIK3CA mutation can be problematic, and we have a failure rate in the archival tissue for evaluating PIK3CA around 50%, and you lose 3 weeks just to have the feedback that the archival tissue have not or sufficient quantity or the good quality to test for PIK3CA. So I think it's important to start to have all the potential targets as soon as possible in our available to discuss with the patient the potential option. Of course, the scenario is becoming crowded. We have discussed we discussed the approach of intercepting before clinical progression the ESR1 rise in the SERENA-6. You are familiar with the data with the vepdegestrant, Professor Tripathi already shown this morning the data. Also the imlunestrant, we heard couple of days ago that FDA approved the single agent imlunestrant, but in my view, what is more appealing is the combination of imlunestrant and abemaciclib. And also there is a press release of the positivity of the EVERA trial with giredestrant in a similar patient population of the EMERALD trial. So crowded scenario, and it is important, as discussed before, to have in mind the potential algorithm as soon as the patients develop metastatic disease, just to avoid to lose opportunities for our patients. And I will close by very quickly share with you a case from my clinic. This is a patient who was diagnosed in December 2012 for PT1 and 1 luminal breast cancer. She received surgery and radiation therapy and hormonal therapy for 5 years. And then she developed metastatic disease 11 years after the primary treatment. So this is a pure situation of endocrine sensitivity more than 5 years after the completion of adjuvant treatment. And the metastatic spread was prevalent in the bone. You see a lot of lesions, and also we have pathologic fracture of the pelvis with the also tissue, as shown here. You can see here in infiltrating the muscles. So we have the biopsy in that part. We discuss the problem of having the reliable biomarkers on bone tissue, but here we have also soft tissue surrounding the lytic lesion, and we have the confirmation of ER positivity, HER2/1+. Of course, this is something useful for further lines of treatment to qualify for the Ruxtecan. She at the time of diagnosis, she has hypercalcemia with renal impairment related to hypercalcemia that was corrected with hydration and steroids, and we start first-line treatment with the exemestane, palbociclib, and denosumab. And she did well for 14 months when she developed a metastatic lesion in the liver. We rebiopsy the disease because, of course, if it's feasible, we tend to, because also we have a lot of trials evaluating the dynamic of the biomarkers. So we have a trial matching the tissue biopsy with liquid biopsy to check for changing the profile of the disease, and again the confirmation of the ER positivity, HER2 plus, and we enrolled the patients in the platform that I've shown you, because there were the 4 labs offering the test for the Italy and the Europe, and she turned out to have a mutation in ESR1, the D538G, and with a very high rate of MAP in this case, and the patient start elacestrant, and I'm happy to show you the PET scan showing the response in the liver, and the patient is still ongoing, and next evaluation will be soon. And okay, thank you. Okay, I was 40 seconds left.
Thank you very much. So we'll ask the second panel to go to the podium. Dr. Dia, Dr. Arif, Dr. Dalia, Dr. Aida, Dr. Adima. In this session, we will have a case presentation from 4 physicians. So please, if you can be short for like 3 to 4 minutes for each case, so we can discuss it and we can have the final discussion at the end. So I think Dr. Arif will be we will see it on the screen. Dr. Adima Abdel-Jabbar, you are the first one to present.
Okay, so this case is one of the very interesting cases that I had. She's a 48 years old, unfortunate lady who was diagnosed with the breast cancer. However, she never got treatment for that. You know, those patients that get lost. And she presented to our hospital February 2023 with, from outside, intubated after laminectomy at outside hospital, T9 to T11. Rapid decline in mental status and intubated transfer to ICU. Now, previous outside pathology that show ER/PR positive, HER2 negative. We did not have any pathology report. This is all from outside. History of multiple bone lesions and thyroidectomy. Now, intubated, unable to give any history, no family. There's cousin that doesn't know anything. And we assumed that she's premenopausal, so we started her on Zalodex and Faslodex because this is the safest thing I can start an ICU patient on with metastatic breast cancer. She was unable to take CDK4/6 intubated NG tube because all of them cannot be crushed at that time, and we were able just to give her Zalodex and Faslodex. And you can see here, she was intubated for a while, and then she was trached and moved to LTAC. And you can see here the CA15-3 in February was 157 and gradually declined, and CA27-29 as well. So she has like multiple bone lesion, and she had compression. They did laminectomy, and they had post-op decline in mental status. She was unable to talk. She was intubated for a long time, had trach, moved to LTAC. She's paraplegic because of the bone mets, paraplegic. She cannot move anything. So now after a while, she started to be able to swallow, continue to have a PEG tube, however, able to swallow, still bedridden. So we started her on Kisqali December 14, 2023. So 10 months after we started the Faslodex, we started her on Kisqali. Now, PET scan in May, unfortunately, did show disease progression. And I felt that we did not give her enough time for Kisqali, so I didn't know if Kisqali is working or not. So I started her, I requested the ASR1 mutation, started her on Verzenio and letrozole. She continued that, sorry. So this is the PET scan, multiple bone lesion. This is the disease progression. Now, after being 2 months on Verzenio and letrozole, ESR1 came back positive. However, I had very hard time managing her diarrhea. She is bedridden. She has a bed sore. She is she cannot move, so she has bed sore. And I was worried about sepsis and everything. So I switched her to elacestrant July of 2024. However, she did have response to letrozole and Verzenio. And this is the PET scan, multiple foci that has decrease in FGG activity after just 2 months of Verzenio and letrozole. But I switched her to elacestrant just because of the side effect of these medication. So she started elacestrant July 24 and had an excellent metabolic response. She had no nausea, no vomiting, did very well with that. Next PET scan did show complete metabolic response, and she is still on elacestrant, excellent tolerance, no dose interruption, no dose modification, no side effect. So she is one of my successful cases. Actually, I do have a lot of time. I can say whatever here. Okay, so the thing is, actually, this is kind of like I did on molecular, based on molecular progression. So patient can still tolerate AI and Verzenio in usual cases. Just because of her situation, I decided to go with elacestrant. Sorry. Serena 6, exactly. That's what I did. So I kind of, just because of that, I could have put her back on Kisqali. I decided to move forward with the ESR1, and I'm done, Dr. Hassan. Are you happy?
Thank you very much. So we'll not have the question and answer. We'll keep it to the last panel. So we'll go for the second presentation. Arif, can we see the name for the second presentation?
Assalamu alaikum, thank you very much. So moving forward because of time limit, so this is another case presentation regarding the benefit of hormonal therapy sequencing in patients with breast cancer. So this is a 54-year-old female patient. At the presentation, this is currently 54. At the presentation, this was 5 years back in 2020. She was still premenopausal. She has a neglected breast nodule for 5 years. And from the history, you know what type of personality she has. She's a very difficult patient. And she denied that she has, and you can see the mammogram, the large mass that skin changes. So she was admitted to the hospital with severe bony pain, and we were consulted as oncology team to discuss with her. She was difficulty accepted to have a right breast biopsy that showed an invasive ductal carcinoma, a grade 2, and with almost the luminal B pictures of ER 90%, PR 60%, HER2+2, but the FISH was negative, Ki67 was 20%. So part of the staging workup at the presentation, she has bony disease, lung disease, liver, and brain metastasis. So it's everywhere. And patient was resistant to treatment. She doesn't want any treatment. She just wants to die in peace. And this is an example of the bone. See how the bone was severely affected. And this is one of the lesions in the brain. She refused to do an MRI. This is only the CT. And this is an example also, she has bilateral axillary large lymph node. This is also the lung nodules. There are plenty of this one, plenty of the liver. So she was full of disease. So as a strategy and the plan how to approach your patient and just, you know, how to deliver the news about good and bad, the bad that she has metastatic disease, but the good is she has hormone positive, HER2 negative. So I convinced her to start tamoxifen first. And then we say this is an oral tablet. Okay, you don't want any treatment. Just go on home, take this tamoxifen, and let's see you in 2 weeks. So she came in 2 weeks. She feel a little better. So I tried to convince her to start a CDK4/6 inhibitor. 2020, there are no survival data regarding a CDK4/6 inhibitor. I convinced her, we started palbociclib. She started to feel more and more better. So 2 to 3 months, then I told her about ovarian ablations, and because of this. So we managed to get ovarian ablation with denosumab for bone metastasis. So I started her on gozerlin monthly, and I switched from tamoxifen to aromatase inhibitor. She was doing very well. She started to, have decreased bony pain. I didn't start radiotherapy to the brain. She wasn't asymptomatic radiotherapy from the brain wise. I didn't start any radiotherapy to the bony lesion. Actually, she was resistant to any treatment, but her bony pain and the lesion in the bone were improving on the combinations of total ovarian ablation plus aromatase inhibitor and CDK4s. And this is, you can see, like in 2 years. Why I waited 2 years? Because I said this patient is resistant for it. But however, symptoms improvement, decrease in tumor marker was used as an indirect marker to evaluate her response. After 2 years, you can see that, the breast cancer, the breast mass has significantly reduced in size. Even the MRI brain showed, almost liquefaction of the lesion in the brain. And also there was an improvement in her bony disease. And she was doing well until March 2024, when she started to have more bony pain again. And on PET scan, you see there is a progressive disease on the right pelvis. And we agree, as majority of oncologists will tell you, if the patient has controlled disease and you have, an oligoprogression, you can deal with this oligoprogression and you keep the patient on the same protocol. And this is what I did. We sent her to radiotherapy to the painful region, and then we continued the same, and she was really happy with that. In November 2024, she started to have more progression, and you can see it's mainly in the bone. It is not in the nodes, it is not in the lung, it's not in the liver. These visceral metastases were very consistent. So, and this is her story on CDK4/6 inhibitor. You can see significant drop of CA15-3, which we use it as a marker of response with the clinical symptoms improvement. And you can see later at the 2023 started to rise, 24 started to rise. And this is her leukopenia and neutropenia on CDK4/6 inhibitor, but she was never admitted with febrile neutropenia. Okay, she has some recurrent flu. And that's why when she progressed in 2024 November, she was resistant to change, because she was claiming that this progression in CA15-3 probably because she's interrupting palbociclib. We discussed with her to decrease the dose. She said, I'm happy with this dose. I'm responding from the first. I want to stay on it. And this is also like her hemoglobin was improving. This is her platelet count. And this is her liver function test. So we didn't get any elevation of LFTs on palbociclib. And this is her creatinine level. Majority of the time was normal. Calcium, because we're using denosumab. So upon progression, we were able to convince her to do, liquid biopsy. And we did only ESR mutation. So I don't have data about if she has dual mutation or not. And we said, now I think we should move to elacestrant, because PET scan show progression in the bone disease. CA15-3 is progressing. So she accepted. We start her, and you can see significantly from June 25 till August 25, there is significant from 300, the CA15-3, to 115. So almost like 1/3 drop. And the beautiful thing is that her bone symptoms all disappear. She said, I'm not using any painkiller anymore. And the good thing, she's not anymore neutropenic. And so because she has like recurrent flu, and so she's still till now on, LHRH and denosumab. And now she's almost, from June, almost 3 months on the drug, and hopefully she will continue for longer time. Thank you very much.
Thank you very much, Dr. Arif. We'll move to the third speaker. It's either Dia or Dr. Dalia. Dr. Dalia.
Assalamu alaikum, everyone. So my patient actually, so she's a young lady, starting 33 years old, premenopausal. She's working, married, have 2 children, and she doesn't have any comorbidities and no family history of any cancer. She is standard case presented with locally advanced breast cancer back in 2022. Left breast, huge breast lesion, 6 centimeter, axillary lymph node involvement. Her mammogram and breast imaging confirmed the presence of huge mass, about 6 point something in her left breast, and 5 suspicious lymph nodes. So she was clinically stage, I think, T2 and 3 and 2. Her biopsy confirmed the diagnosis of IDC grade 3, and the immunomarker status was positive for ER/PR Ki-67 25%, and her HER2 status was negative. Her staging workup to start with was negative by CT scan and bone scan. So she started on neoadjuvant, and this treatment actually started not here, it was started in Egypt. Neoadjuvant chemotherapy, partial response, skin sparing mastectomy, reconstruction. She had significant residual disease, IDC grade 3, 3.6 centimeter, 4 out of 24 lymph nodes were positive. So she was YPT2, YPN2. Post-op immunomarker showed almost similar, ER/PR positive strongly, HER2 negative, and Ki-67 50%. Her BRCA testing as a baseline was negative, and she did radiation therapy as adjuvant. So she, by all these parameters, the patient considered to be a high-risk patient for recurrence, and that's why the patient started on endocrine therapy using aromatase inhibitor, LHRH plus CDK4/6 inhibitor. She received around 1.5 years of this endocrine treatment until June 2024. And in June 2024, this was her CT scan, multiple liver lesions. So a summary, high risk early breast cancer. She received the standard treatment, residual disease, adjuvant CDK4/6 inhibitor. And after around 1.5 years of endocrine treatment, she progressed into the liver with multiple new liver lesions. And biopsy, of course, was done at this time and showed invasive breast cancer, ER positive, PR positive, and her HER2 was still negative. So we sent the tissue for NGS, and as you can see here, it showed double mutation, including the ESR and PAX3A. So and the question here in the tumor board was what to start. And the patient was on adjuvant CDK4/6 inhibitor, and I think in this case we may face in the coming years, because we have many patients with this scenario on adjuvant CDK4/6 inhibitor. So the patient, based on the Emerald study, we started him on elacestrant in July 2024, and she tolerated it very well. She has mild arthralgia, like grade 1 arthralgia. She doesn't have a lot of treatment-related side effect. And this is her December 2024 image in comparison to the initial one in June 2024. I know we will have a lot of questions about this patient because she has a lot of disease in her liver, but as you can see here in April 2025, also there is a significant maintained response in comparison to the baseline June 2024 PET-CT scan. I think with this I end my presentation, and thank you for your attention.
Assalamu alaikum. Okay, so we'll go to the last case. And this is a 46-year-old female back in 2020, January 2020. She had bilateral breast cancer detected late in pregnancy. The right breast was invasive lobular carcinoma. It was CT1CN0M0, ER positive, PR negative, HER2 2+, FISH negative, and Ki-67 was 5 to 10%. The left breast was invasive ductal carcinoma, CT3N0M0, ER positive 90%, PR positive, and HER2 again 2+, but FISH negative, and Ki-67 30 to 40%. She had no germline mutation, and patient at that time was booked for bilateral mastectomy, but she got pregnant again. So she was advised to have surgery at week 14 to 16 of her pregnancy, but she, of course, disappeared and presented back again later in December 2020, post-delivery during late August 2020. Bone scan and CT scan of the chest and abdomen showed lytic bone metastasis at the manubrium, left iliac bone, and T10, and she had no visceral metastasis. So her first line treatment at this stage, she had anastrozole plus CDK4/6 inhibitor in addition to ovarian function suppression and denosumab. This was in December 2020. First assessment in April 2020, she had good response with the regression of the breast tumors and multiple sclerotic bone lesions. And after that, she had serial PET CT scan. She was doing extremely well between 2021 and 2024. There was no FDG activity, and she had stable sclerotic bone lesions. In April 2024, this patient had a PET CT scan, which showed progressive bone metastasis with new FDG activity. Liquid biopsy revealed evidence of dual mutations in ESR1 and PIX3 kinase. So these are the mutations detected in the ESR1 and in the PIX3 kinase. So this was back in June 2024. Patient started elacestrant at the usual dose, 345 milligram daily. She had good tolerance and no side effects. And PET CT scan, September, she had evidence of improvement. There was increased sclerosis and decrease in the uptake across the previously noted bony abnormalities, and no new lesions, and again, no nodal or visceral metastasis. Again, in January 2025, she had further regression in her metabolic activity, significant partial metabolic response, and she did well until May 2025 when she showed evidence of progressive disease. I can read here the index metastatic lesion involving L4 vertebral body showed increased measurement of 2.4 by 1.4 centimeter, and previously it was smaller, 1.1 by 0.8 centimeter, and there was another lesion. So clearly at this stage, this patient was progressing. So this is her PET scan at this stage, and we can see the bone lesions at different areas. And at this stage, what's next? This patient is having dual mutations, ESR1 and the PIX3 kinase mutation. So treatment options were discussed. I just put this just to discuss to initiate discussion, trastuzumab deruxtecan, capecitabine, or to target the PIX3 kinase mutation, giving her fulvestrant plus capivasertib. Remember, this patient had the elacestrant. Thank you.
Thank you very much for all the speakers about their nice cases. And if we can open the floor for discussion. So we have a set of questions. Now, I mean, probably all these questions has been addressed during the day presentation, but we need to probably reflect your clinical, addressing your clinical expertise in your daily practice. So the duration of CDK4/6 inhibitors in your treatment approach for hormonal positive HER2 negative advanced breast cancer, if the duration of treatment with the first line CDK4/6 inhibitors, excluding the visceral crisis, do you think those patients is for resistance 6 to 12 months or more than 12 months, Dr. Aida?
Yeah, so very good question. 6 to 12 months, it's really tough to make a case for, for oral SERD, and if the patient had ESR1 mutation, as you would expect that these patients would benefit if they were like, they had longer PFS on CDK4/6 inhibitors. So these kind of patients are endocrine resistant. I think we really have to be vigilant about what organs are affected and whether they are in visceral crisis or not, but you just clearly mentioned they are not in visceral crisis. So if the patient had PI3K in this situation, I may try and see if that will work for the patient. Otherwise, it's going to be antibody drug conjugates at that point. But more than 12 months and the patient is not in visceral crisis, I think if they have ESR1 mutation, PI3K, then this is a discussion where we have with the patient. Most of them, like when we discuss both options, elacestrant will be more intriguing to them based on its impact on quality of life, which is very positive. But it would be mostly, again, based on the targetable mutation that we are dealing with at that point.
Thank you. Dr. Valentina, just again, the definition probably in the old era for hormonal positive is less than 6 months. But with the CDK4/6 inhibitor, and probably specifically for elacestrant, where it showed that if it is more than 6 months, the response rate is from 1.9 to 3 point. But they didn't limit from 6 to 12. They did it more than 6. And probably those from 6 to 12, they are quite resistant in the metastatic setting. So do you think that those, probably we should not consider the elacestrant for those patients, and probably the definition of after CDK4/6 inhibitor can be different than the old era with hormonal therapy, other hormonal therapy?
Yes, I agree here. The point is that after 12 months, I think we are all confident in offering the elacestrant from 6 to 12 months. I think it's a matter of the kind of progression. Sometimes you have bone progression, disease progression only in bone, or sometimes you have really sign of not so
systemic.
Yeah, not that you are really losing the opportunity to stay still on endocrine therapy. So in this case, it can be an option if, of course, the patients would like to bet on the possibility of having a single agent endocrine therapy. What is a little bit my concern is the initial drop of the curves that you observed in all the trial with oral SERD. And again, this drop of the curves is observed independently from the duration of prior endocrine therapy. You see that the figure is exactly the same. But of course, in this patient, I will monitor closely the eventual further progression.
Thank you very much. Dr. Daria, since your case was having co-mutation, so in the presence of co-mutation, whether it is the mTOR pathway, it's a PI3 kinase, AKT, or PTEN, in the presence of ESR mutation, how you select to give a treatment?
Thank you, Dr. Hassan, for the question. Actually, like Aida said, the duration of AI and CDK4/6 inhibitor exposure will help me to decide about which one to pick. As we mentioned, if it is more than 12 months, so I will go for the elacestrant selection. We have the Emerald trial, which showed benefit in this group of patients. But if it is in less than that, or if it is from 6 to 12, I will consider these cases as a primary resistant disease, or like they will progress very soon on the SERD, oral SERDs. So I may consider other options like the 𝗥3 inhibitor.
Dr. Adima, is the tumor burden is related to select between ESR and the mTOR pathway, or just the duration of the progression?
To be honest, I feel, I mean, again, if they full-blown metastatic disease that give me an aggressive, more aggressive, then most likely it's 𝗥3, the one that is modulating, because we see in the ER positive, the one normally they don't progress all of a sudden, right? So it can give you an idea, but mainly it's the duration of response to the prior hormonal therapy is the main indicator. And you know, those patients aren't actually the worst players. I mean, when they have the co-mutations, I don't know, I mean, they always progress. So I usually tend to scan them more often to be able to switch the hormonal therapy earlier. So I don't wait for 3 or 4 months like usual patient. They usually, when they have co-mutation, I scan them earlier. I don't know.
Yeah, I agree with you.
The next question for Dr. Dia. I mean, also I saw some of presentation, they mentioned HER2 negative, and they are not differentiating whether it's HER2 low or HER2 negative. So in the presence of HER2 low, so does this impact on your treatment, whether to go for a further hormonal therapy or you switch it, especially with the Destiny 09?
I think I will.
And whether the tumor burden can affect that decision?
I think in a patient where there is extensive involvement by the metastatic disease, and mainly if the duration of exposure to endocrine therapy, including the CDK4/6 inhibitors, in this case, I would be inclined towards the trastuzumab deruxtecan in such a case. However, if the patient is having a lower burden of disease and the duration of disease control on the endocrine therapy plus CDK4/6 inhibitor is more than 12 months, no, in this case, I would be inclined more towards the elacestrant or the, as in my case, the 𝗘𝗱𝘂𝗰 plus fulvestrant, if the mutation, of course, it's there. In the case of the dual mutations, I think when it's more than 12 months, both options are valid options.
For Dr. Arif, anything different? And if you elect to go for HER2, and we know that there is no certain duration of treatment, do you give it for certain duration and then you switch to oral SERD?
Thank you, Hassan. So we all agree that patients with hormone positive HER2 negatives will be treated by hormonal therapy. And I can say it like in briefly, whenever there is an indication for chemotherapy that we were using in the past, here there is a role for trastuzumab deruxtecan, because trastuzumab deruxtecan shows superiority to any other chemotherapy that we used before, like capecitabine. What are these indications? Progression within 6 months, visceral crisis, all these no mutations. Sometimes you do liquid biopsies, there's no ESR, no PI3 mutations, and really you need to move to subsequent therapy. So these are the patients you may move. And you have to take in consideration also patient, performance status, comorbidities, and the wish of the patient if they want to go for really a chemo or hormonal therapy. Thank you.
So if you elect and you give the chemotherapy, then HER2, do you switch it at any time back to the oral SERD or no?
Probably if it was the data available, probably, but I will go for post-monarch first.
So I think we have
Just one
a couple of questions before we close.
Okay, so, well, I've been listening silently.
Thank you very much.
Just a couple points. Guys, we cannot compare.
We appreciate this.
Okay, the elacestrant data, unfortunately, it's single agent. When we say, would you choose a PI3K or elacestrant, almost everything else we look at is a doublet, not a single agent. So you cannot compare and say, I will do this or that, because they are not really the same. And I will go further. We have 3 other oral SERDs, and almost all of them are in a doublet situation. Whether you are with the EMBER-3 or the newer kid on the block, as we say, the giredestrant, or the imlunestrant, or Kamel, what's the other one? Anyway.
𝗘𝗱𝘂𝗰𝗵.
The other one.
Kamil.
Thank you. So my question.
But I mean, before asking your question, the approval for elacestrant as a single agent, it's not as a doublet, as a second.
No, I understand. I'm asking for the future, because this is not where we want to be. Single agent is fine at the time, but I think we moved on. Most probably the newer approval that we're going to see either with everolimus or
combine
abemaciclib, exactly.
The PI3 kinase inhibitors plus IKT inhibitors.
So that's my question. Well, there will be cases where single agent may be enough, especially those who had long duration. But I don't think it's going to be one size fits all.
The problem,
I think there will be room for combination.
The problem, we don't know the driver, and we are predicting the driver for the progression-free survival. And this is usually, if it is driver PI3 kinase, usually it is short. If it is the ESR one, it's longer, but it is not an ideal way of differentiation.
Everolimus plus giredestrant now, it's all over the place. There is survival, press release. We know the EMBER-3, etc.
You're right, Dr. Hassan. Actually, the thing is, I don't think anybody will be CDK4/6 free. I mean, most of these trials are for CDK4/6
never used before, right? I think in the future we are going to have the ESR1 in the adjuvant setting as well as the CDK4/6 all together. Now we're going to be stuck at that time. I don't know what we're going to do with hormonal patient when they progress on this.
No, Ember 3 was after prior CDK4/6. It wasn't my
60%.
Ember 3.
Yeah.
Number 3, 60% were
It's
treated
not
with
approved.
CDK.
And it's not
40%
approved.
naive. Can I ask a question?
Please.
Very interesting.
What is
discussion.
approved?
I'm one of
A
those
single
who,
agent.
who
No, but I'm
believe.
saying you will be hardly finding patient who did not get exposed to CDK4/6 because it's now in the adjuvant setting, right?
True, but I'm saying the concept of combination,
Yeah, sure.
maybe we should be thinking like that, and maybe for the company, they should be, I'm sure they are thinking of combination because it is not enough to have a 3 or 4 months PFS in a second line.
Yes, so I continuing in this discussion, very unique case that I'm facing. Maybe I discussed with Dr. Arif last week or this week, actually. So it's an 88 years old female with tons of comorbidities, including congestive heart failure, recurrent admission due to pulmonary edema, and coronary artery disease, diabetes, high blood pressure, you name it. So the patient was diagnosed with early stage breast cancer. So we decided to put her on letrozole, single agent, no surgery because she's not fit for it. And the patient has been on it for almost little more than a year. And then she progressed with multiple bone lesions and lung mets, but in a low burden. So I had this huge discussion with the family. The patient is not somebody who would come to the hospital very easy to. I mean, most of the time it's either going to be the family or it's going to be like teleconsultation. So we had this big discussion whether we should do just single agent fulvestrant or like do something. They were not happy about the injection. They were not happy about I was not happy about adding CDK4/6 inhibitor because she was also like borderline pancytopenic, MDS kind of situation. So I did the Garden 360 and 2 ESR1 mutation came and she has a TP53 mutation as well. So it came to my mind whether she would be a good candidate for elacestrant, being an oral medication, good quality of life. So what do you think? I need the panelists and the audience.
Well, there is an ongoing trial in first line. We didn't mention the other kid on the block, polazestrant, that's with ribo in the first line setting. So that's ongoing trial and we'll see. But I mean, it's not unusual to think of oral surgery.
It's a replacement for fulvestrant. If you decide to give fulvestrant, you can give it.
Yes.
So it's exactly the same as my case because of side effect. Patient still responding to AI and CDK4, but I stopped it and moved to ESR1 just for side effects.
The patient never received CDK4.
So that's even better. I mean, so that's even better. I think we can proceed.
Valentina, what do you think?
I will, if you can.
Definitely, I would use it.
Not all ESR1 mutations are the same, by the way. They're not created.
You can have a resistant as well. I mean, for the sake of discussions, for the time being, I think we are.
I need an answer, though.
No, if you decided to give fulvestrant, I think it is fair enough to use a system. I think time's up. I just want to review. Okay. So by this, thank you very much, and thank you for Menarini for sponsoring this workshop. If you need just to close this.
Photo for those who survived the meeting, please come over. Survivors, we call this survivors photo. Every time we take a photo at the end of the day for those who survived. And dinner is in 20 minutes. By the time we move from here to dinner venue, we can have dinner together, inshallah. Yalla, who's going to take the photo? Come on, photo. Jaldi karo.
You play it in a very nice way, I know. مكملين معانا.
Okay, meet us all at the lobby at 8:30, please, to go to the dinner. Thank you very much.